Only the brain tumor, any other tumor? Though not a single tumor, it is a common question in the postgraduate what are the solid ovarian tumor. Another is the metastatic Kuchenberg tumor. It is the solid ovarian. Another is the ovarian fibroma, very rare, large ovarian fibroma. But it is the common conception of the people and also the student. They, probably the malignant ovarian tumor is the fibroid, but not like that. Malignant ovarian tumor usually the variegated appear, solid, partly solid, and partly cystic. And the benign tumor is usually the cystic tumor. And the cystic tumor. But in case of solid tumor, it may not be malignant ovarian tumor, but you will have to exclude the malignant cells by after surgery. So next proceed. Now come
just wait. The one thing is that whenever you are describing a lump in the abdomen, you are not supposed to write it in 32 weeks pregnant uterus. You should be writing in centimeters or inches.
Yeah.
You know how many centimeters? Abdominal lump. You read your surgery. It's always in centimeters. This much dimensions are there. The another thing is partly solid, partly cystic means what? Could you feel solid areas on one side, or was it mixed? What do you call it actually? You just can't define this part is solid, that it is solid, cystic. It's variegated consistency. That's what we use the word for. So,
and one thing is that you have not written about the shape of the shape. You have not. You will have to write down the shape also. Tenderness you have different, but shape and the surface, madam has said, you'll have to say the variegated, or there is no nodularity, because you will have to want to differentiate from the benign ovarian. There is no nodularity. If there is no variegated appearance, and if there is a nodule, likely to be nodularity to or not. Mobility you have said, correctly. Lower margin have said, non-tender tenderness, everything you have said. So shape and give in the measurement in the measurement in centimeter also, and the surface. Okay, proceed.
On pelvic examination, inspection, external genitalia appears normal. Per speculum examination, cervix high up, healthy, vagina looks healthy. On bimanual examination, cervix is high up, uterine outline could not be made out separately from the mass, hence size of the uterus not made out. Bilateral fornicial fullness present. Mass does not move with the movement of the cervix.
Can you move the mass with the movement of cervix? Such a big mass, you will not be able to move with the moving of cervix. It should be the other way around. That
with
movement of mass is not
movement of the cervix with the mass.
Yeah.
Or the opposite, vice versa.
Exactly.
I'm sorry, ma'am.
Anything else?
The same, anything else? Madam, is anything else you will write? You must have to write, because suspecting the malignant ovarian tumor.
No, nodules were felt in the POD.
You always say if there is any nodule in the present. Can you say what are the causes of the nodule and the pituitary gland in case of women? What are the other causes of the nodules in the gland? One is the malignant ovarian tumor, definitely. Any other?
Sir, endometriosis.
Endometriosis. Next. Pelvic tuberculosis you might get sometimes, a nodule, PID and pelvic tuberculosis particularly. Any other thing? It is mistaken, is common, particularly the beginners, the nodule. It's a very vague thing. That is nothing but the hard stool. That is the squabella, small hard stool, chronic constipated women. Sometimes you will get them. So these are the 4 differential features of the nodule in the pouch of Douglas.
Okay. One more thing I wanted to say, cervix high up means what? In the center, anterior or posterior?
Posteriorly.
So then you should say you were able to feel the mass with phonics. Were you able to?
No, ma'am.
Posteriorly means what? Why is it pushed posteriorly?
The mass must be more towards the anterior fornix.
So that part is not mentioned in your findings.
Yes, ma'am.
It's a higher.
You will have to describe here about the mass. Actually, the pelvis is occupied by the mass, whole pelvis. Because if it will get in the anterior fornix, if you get in the posterior fornix, if from the lateral fornix, there is a differential diagnosis. Can you say what is the lump in the anterior fornix? So name some lump in the anterior fornix. That's very practical question. Anterior fornix. Suppose you get some lump in the anterior fornix. What is that? Moderate lump.
Some bladder, sir, bladder tumor.
Bladder is the secondary organ actually, not gynecological case. Definitely there is a bladder mass is the mass. Anterior fornix mass. Very important. Number one, always the dermoid, long pedicle and moderately size and heavy. It comes to the anterior mass. Anterior mass is the dermoid, if you get. And one thing is the fibroid, cervical fibroid, anterior cervical fibroid.
Anterior cervical.
And sometimes the chronic ectopy, chronic ectopy. These three things you must remember. One is the dermoid, one is the cervical fibroid, and third is the chronic ectopy. And also you have said the bladder mass, there will be bladder mass. So these are the and the lateral fornix mass is usually the arises from the adnexa. Any related with the adnexa, that may be TO mass, maybe a hydrosalpinge, or the ovarian mass, broad set of ovarian mass. So proceed now, madam. Anything,
Yes,
Dr.
yes, please,
Sunita?
go ahead. Go ahead.
Okay.
On per rectal examination, a firm mass was felt, nodules felt in POD, the rectal mucosa was free.
So nodule felt in the POD in the rectum, but you have not mentioned in the final examination. You'll have to
The
mention.
examination you haven't mentioned.
Anything else?
No.
Now you'll have to the recto-vaginal examination also. Recto-vaginal examination. Whether the posterior vaginal wall is involved or not. Recto-vaginal examination. And in recto-vaginal examination, what is the two fingers? Can you know how to do the recto-vaginal examination?
Sir,
What is the index finger? Right hand index finger where?
The right hand index finger is in the rectum, and the thumb.
You can do, but you see any standard textbook, clinical textbook, any, you see the recto-vaginal examination, how it is done. It is actually the index finger will be the posterior in the vagina, and the middle finger will be the rectum. You see any standard book, an international book also, how the recto-vaginal examination is done. Whether the septum is thickened, whether there is a nodule. Particularly, it is more useful. Two cases. One is the endometriosis, deep infiltration, DIE, and also the malignant ovarian tumor. And you must mention also whether the mucosa is free or not, which are already described in rectal. Next, proceed. And you say there is no bleeding per rectum. Also say.
Yes, sir.
Yes, go ahead.
Okay.
So my case is a 54-year-old P2L2 postmenopausal for 9 years with abdominal pelvic mass for the past 5 months with no comorbidities and no family history of malignancy. She has come for evaluation and management.
You have to mention the type of mass, queries, Some provisional diagnosis has to be made. You just can't say abdominal pelvic mass. You could feel it through the furnaces.
You will have to pinpoint the diagnosis. For clinical examination is actually, you have said, almost you can pinpoint the diagnosis. At least you will have to say abdominal pelvic mass. There are so many abdominal pelvic. You say the ovarian mass, you say, you pinpoint the diagnosis, the ovarian mass, and probably malignancy, you can say. In two terms, you will have to say. Otherwise, your summary is written very well.
Yes, sir.
Abdominal pelvic mass is a not. You will have to definite diagnosis. You will have to say. So we will get questions. So next, have you evaluated? This is the short history.
Yeah.
Taslima, you have written the history very well. The points we have mentioned, Professor Mittal and myself, you just recapitulate that thing. Now, how will you next proceed? You say.
Yes, we will
How-
first do the in routine ANC investigations.
Like,
Sorry, routine blood investigations,
no, first,
because
wait. You haven't, next slide. What is the next slide? Don't-
most probable impression is a left adnexal pseudocystic mass of
Oh, you have
indeterminate
already said.
pathology. Risk of cyst adenocarcinoma is high. Diagnosis, ovarian tumor, most probably malignant. And management is counseling. We'll plan for laparotomy for surgical staging, followed by TAH with BSO, with infracolic omentectomy, followed by adjuvant chemotherapy.
Do you decide this plan just on the basis of clinical history and examination?
No, ma'am. No, ma'am. First, we'll confirm the diagnosis. And
Yeah.
if our diagnosis is confirmed, then we'll proceed with the management.
So it should be written here, the management. You straight away started after diagnosis management. Management is investigations plus.
My planning actually cannot write like that. They are just after clinical examination, history taking,
It
they
should
go
be
to the.
written after the investigations.
But everything may happen. You do not know. In clinical practice, everything may happen. The abdomen is a magic box. The impression you have written cyst adenocarcinoma. Why cyst adenocarcinoma? This of cyst adenocarcinoma. And you write down the ovarian adenocarcinoma. What is that? What is adenocarcinoma? If you wanted to, but why cystic? I think cystic adenocarcinoma or cyst adenocarcinoma. Why the cystic adenocarcinoma?
That's one thing. Another thing, how can you say it's left adnexal solidocystic
What are
mass?
the then question naturally will come? What are the
Ma'am, I
different of the
we
adeno,
cannot
the
say
carcinoma of the ovari
So why
and their
did you say
incidence?
this left? You
Yeah,
didn't
ma'am,
mention
that cannot be identified. I'm sorry about that. Cannot be told actually. Left or
From this, it looks like that
No,
you've written
you
this
are
left.
not wrong, but you will have to justify. You may not be wrong, but you will have to justify. Now, the next question is what are the different types of ovarian malignancy, that are cancer, and what are their incidence? That will answer, that will, I think, protect you.
So the most common is epithelial ovarian cancer.
And what are the different ovarian cancer?
So the of different ovarian epithelial cancers are serous, mucinous, and endometrioid, Brenner's, and clear cell.
So what are their relative incidence?
So the most common one is serous epithelial cancer with an
Serous
incidence.
Incidence, how much?
The incidence is 80%.
Maybe 80%. More than 50%.
75 to 80%. Endometrioid is 10%. Mucinous is 5%. And
so you will, yes. And others are the 1%
clear
or
cell 5%,
5%.
and Brenner's is most rare.
Brenner, there is Brenner malignancy there. So that is all the important thing, as you can say, when you have already said this, the cystic carcinoma, because it's the more common, the commoner. It will be 50 to 80% chance. And second is the endometrioid person. Then is the endometrioid. And third is the mucinous cyst. So this is the common question. So it is not your discredit, but you will have to protect yourself, prevent yourself. So next.
The other thing is most probably malignant, yes. Can you say about staging just on clinical examination?
Yeah, staging in by clinical examination.
Clinical examination.
Ovarian malignancy staging is always surgical staging. What you can anticipate by clinical.
Ma'am, if there's presence of if there's presence of pleural effusion and
we talk about your patient. What is in the most probably clinical staging in this case?
I couldn't hear you. I'm sorry.
Your patient.
My
what
patient.
would be the probable clinical stage? Can you hear me?
Yes, ma'am, I could hear you.
Yeah.
And most probably 1B.
With nodules in pouch of Douglas, can it be 1B?
No, ma'am.
So straight away it jumps onto
Ma'am,
That single finding.
ma'am, maybe 2B.
if there are nodules in the POD, that means nodules are there maybe in the peritoneum also. It's a part of peritoneum.
Pelvic peritoneum.
So peritoneal metastasis means which stage?
Ma'am, 3.
So at least it's a stage 3, you know.
Yes, ma'am.
So that part should have been written and you should have told also, because you had such positive finding of POD nodules. If they were not there, then you could have said any stage will be there and I'll confirm by surgical staging, but not now. It is, yes, it could be 3 or 4. That's what you have to confirm by your investigation. Let's go to the investigations now.
Next. Is there any slide?
Sir, I'm done.
Yeah, tell us which
Okay.
investigation would you like to do in this case.
You concentrate your case, and other than the general investigation, how to confirm your diagnosis is the case of ovarian malignancy by investigation. What investigations you will do?
Sir, we'll start with routine blood investigations, and then we'll do imaging. In imaging, we will see X-ray chest in order to rule out pleural effusion, an ultrasound, CT scan, PET scan, and we'll see for tumor markers CA125, CEA. Among CA125 and CEA, if the level of CA125 is high, it points towards CA125 to CEA is high, it points more towards ovarian primary. And we will
CA is high, is it primary? It could be primary ovarian or it could be
ma'am, if both CA125 and CEA are positive in our diagnosis, and the ratio of CA125 to CEA is high, more than 25:1.
What does it indicate?
Primary is most probably ovarian, and if the CEA is high, primary is often stomach and GI tract.
So you will not confine to only the CA125, you also do the other.
We'll also do CA 19.9 and AFP, LDH, PLAP.
So how does the CA125 level help your diagnosis or management in case of cancer offer? How does it help? You are already said that will be high. But how much?
Sir, if it is, sir, we do a scoring system with the use of CA125. With the help, sir, it is called risk of malignancy index, and in that we used clinical features, basically ultrasound features, postmenopausal status or not, and CA125 score.
Okay.
And with that,
how much?
If we get a score of 200, it indicates high malignancy risk.
Okay. Do you know what is over one panel?
Yes, sir.
What is that?
Sir, it is based on the biomarkers of tumor, like transthyretin. 5 biomarkers are used: transthyretin, apolipoprotein A1, CA125, and transferrin and beta-2 microglobulin.
Okay. So what is the importance of the combining feature of the CA125 and OVA1 panel? The recent what is said actually. If it is CA125 more than 200 and OVA1 score more than 500,
so it's most probably
particularly in the pre-menopausal.
Premenopausal, yes, sir.
Premenopausal, There is a chance of malignancy.
This is high, and in
And
postmenopausal, if it is more than
OVA
4.4.
score, OVA panel, at that case, it is said the more than 4.4 in the postmenopausal.
Yes, sir.
And what is the fallacy of the CA125?
What is the
Fallacy. What is the
fallacy?
drawback of the
It is,
CA125?
sir, it is false positive in multiple cases.
What are those conditions?
Sir, we find a false positive in endometriosis, PID, and leiomyoma,
And also the pregnancy.
also pregnancy, sir.
But negative?
Sir, it is
Very
false
early.
negative in stage 1, 50% cases of stage 1
Good.
ovarian tumor.
Very early pregnancy, early ovarian malignancy. There is a, so what is the advantage? 725. Advantage. It cannot. It is not specific actually, but positive predictive value in
Sir, it is 96. Sir, positive predictive value is 96% in postmenopausal female.
And any other thing, the advantage. If you are said the in clinical application of the CN25, the short note is given in ovarian malignancy.
Sir, in patients whom we are treating with the help of chemotherapy, we do a serial CA125.
So you for 1, 2, 3 you say.
Yes, sir.
You 1, 2, 3 you say that is the, and second answer is the serial chemotherapy. The treatment for follow-up is the one of the follow-up parameter. Follow-up parameter.
It's more
of the important follow-up parameter. Clinical examination
marker.
Yes, yes, sir.
It's a prognostic marker.
Prognostic marker. You say this is the if after the follow-up, more in the follow-up. So these are the.
This you were saying about this repeated CA125. In which case will you do this repeated CA125? No, if she is non-malignant, it is done in screening purposes. You know, in postmenopausal screening purposes, Roma, that's what it is. So we do serial and we find out if it is increased, then we go for TVS and all those things. So that's meant for that. Not otherwise. Just once a case of malignancy is there, it is once, and then we after the treatment. That's what the follow-up of CA125. That's there.
What is ROCA?
Sir, it is the risk of ovarian cancer algorithm. In this, we do serial. Slope is drawn with serial CA125 measurements.
Slope.
Yes, sir.
People are on the slope of the serial. CA125. What is Roma?
The Roma is risk of malignancy index, and sir, it is based on 3 factors: human epididymis protein 4, CA125, and the menopausal status of the female.
Okay. Can you describe the typical features of the ultrasound found in ovarian malignancy?
Sir, in an ovarian malignancy, the on ultrasound features will be the cyst will most probably be, the tumor will most probably be irregular, multilocular, and if it is irregular and multilocular, the size is more than equal to 10 centimeter points towards it. Presence of ascites, presence of papillary structures, and in color Doppler blood flow, if there's a strong blood flow pattern.
There's already one answer in the chat box.
Yeah, I wrote down that please don't prompt. So you people are prompting.
It is bilateral. They prompted. Not always bilateral, but if there is a bilateral, always think.
Yes, ma'am. Yes,
not always bilateral. And papillary projection, there will be variegated also on a cystic and shifted. What is the aorta?
So that is the aorta score is based on ultrasound criteria.
What is the full form of aorta?
It is International Ovarian Tumor Analysis Group.
Good. So the aorta. That is the typical features of the. Then what is the role of the CCT and the MRI? You have said.
Is that PET also? So what do you want to do in this case? Which imaging technique you want to have in this case?
Sir, Ma'am, we will do a
Dr.
PET.
Preeti, please don't write down answers. Yes.
Ma'am, we will do an MRI scan.
For
Is
what?
there any
What do
role
you
of
want to see
MRI?
on MRI?
Ma'am, we will see the extent, the organs involved, the soft, like organs involvement of the other organs, and
So out of CT, MRI, most of she can't afford both, and you have to choose one. Which one will you choose for ovarian malignancy? Yes, Dasni.
yes, ma'am. Um,
What is the advantage of CT over MRI? Okay, tell me that.
I mean, CT, we will see the in the cyst, we can see the septations and
Now, one important thing you must have to see. That is you have described the local or any other thing. You are describing the local structure.
so
Distal
liver
metastasis, actually the extension of the disease. The extension of the disease, actually the metastasis. CCT is very invaluable. MRI may not be so invaluable. Someone has linked the PT. PT actually is more role in case of follow-up. The PT has role, PT. But is a good sonologist behind the machine of the, in front of the machine of the, it almost replaces all the imaging technique, except that the CCT has role for the extension of that. That is very, and also he has already chat box, the limb vascular invasion, the liver metastasis, and the whole abdominal metastasis, that will be better done by the CT. There is a specific answer for that. Next, what will you do? Next, your plan.
Sir, if the tumor is confined to the ovary and or the pelvic organs, we will do a staging laparotomy.
Okay, staging laboratory.
In which cases you avoid doing staging laparotomy? Or the cases where without laparotomy you give her something else and then proceed for
Chemotherapy
laparotomy.
first go with chemo. In
What are the
advanced stage, ma'am, stage more than if it has spread to the retroperitoneal lymph nodes and it has a pelvic, it has involved the peritoneum, then we go for first we go for a chemotherapy 6 cycles, and then we do a staging laparotomy, and then we do a laparotomy to
What is that called?
We don't go by specific, only by peritoneum. Peritoneum could be pelvic peritoneum also. You have to be specific.
Extra pelvic peritoneum,
And
stage 3.
No, stage 3 is all right. You can do laparotomy in that case also. But
3A2.
in out of this three further classification, and then which cases you give NACT first and then do laparotomy. So that's what.
Ma'am, stage 3A, more than stage 3A2. We in advanced cancers, ma'am, we do first neoadjuvant chemotherapy and then we proceed with the removal, debulking surgery.
What is the difference if we do NACT first and then surgery, or surgery first and then chemotherapy? Any difference? In terms of survival, cure rate?
Ma'am,
see, we do this NACT when porta-hypatosis is involved, when pulmonary mets are there, when base of small intestine, parenchymal liver mets, lesser omentum involvement, extensive disease on diaphragm. Then we prefer doing NACT first and then CRS, that is debulking surgery later on. But if it is less than that, then we may proceed with staging laparotomy and go ahead. So that's what you have to plan beforehand. You have to tell the patient what are you going to do, chemotherapy first or surgery first. Yes. What else?
That is called, what is that called? Adjuvant, they're called neoadjuvant.
Neoadjuvant chemotherapy.
You said the neoadjuvant. What is the duration usually given? What is the duration
Six-
usually given?
6 months.
6 months, not. It is 3 months. 3 cycles. 3 cycles.
3 cycles.
The 3 cycles it is given. What is the drug given?
Sir,
Epithelial tumor.
Sir, epithelial tumor we give carboplatin and paclitaxel.
Paclitaxel. So come to the staging laboratory. You just tape. Quickly you say, because there are so much of time.
Sir, in staging laparotomy, if the like we'll proceed with, first we'll take if any free fluid is there in the pelvis cul-de-sac, we will send it for cytological evaluation, and if there's no free fluid, then we'll
you
take
first say that it is the only general anesthesia, and always say there is the
sir,
vertical
general
incision.
anesthesia, then midline or paramedian abdominal
that
incision is given.
That is very important. And next you say.
So midline or paramedian abdominal incision is given, and if the ovarian tumor is intact, we take it out in toto and we send it for a frozen section.
No,
and if
first you see what is clinical examination. The surgical.
Okay, sir. If the free fluid is present, especially in the cul-de-sac, we will send it for cytological evaluation. If there's no free fluid, we'll take peritoneal washings. This will be done by instilling and then recovering 50 to 100 ml of normal saline from pelvic cul-de-sac, both paracolic gutters and beneath each hemidiaphragm.
Then what will you do?
And then we will proceed with a systemic exploration of all the intra-abdominal surface and viscera in a clockwise fashion. We'll start from the cecum, then the left paracolic gutter, ascending colon, right paracolic gutter, ascending colon, right kidney, then liver and gallbladder, right hemidiaphragm, lesser sac, transverse colon, left hemidiaphragm, left paracolic gutter, descending colon, rectosigmoid colon. And other than this, we will also inspect the mesentery. We will start, we'll see the small intestine and its mesentery. And sir, after this, if there are any suspicious...
Pouch of Douglas you see, bladder you will see. Bladder you will see, pouch of Douglas you will also see. Then what will you do?
Sir, then if there is any suspicious growth or area, we
try
will
to palpate the lymph node also. Try to palpate the lymph node, the parietic, if there is possible. Try to palpate before going to the surgery. Because it is a very, very advanced stage. If the lymphadenectomy has role or not, very advanced stage, lymphadenectomy is a common question. What is the role of lymphadenectomy? If you are not clear, not clearly cytoreduction, the lymphadenectomy has little load. There is a controversy, was little load. Then what will you do? They determine the staging. You have determined the staging. So now, what are the mode of method? Just summarize. What will you do in case of stage 1, and stage 2, stage 3, stage 4? What is the management?
Sir, in stage 1, we will do, if it is a young female, and then we will do one side adnexectomy.
Stage 1, stage 1A.
1A.
Always stage 1.
And sir, if it is stage 1A, 1B, or 2, then we will proceed with the total abdominal hysterectomy with bilateral salpingo-oophorectomy and infracolic omentectomy.
Any other thing you will do? Consider.
Sir, this is followed by 3 to 6 cycles of chemotherapy.
No, how can you say it's followed by 3 to 6 without doing lymphadenectomy? What is your criteria of giving adjuvant chemotherapy in stage 1A? See, you have to, in early case, you have to do lymphadenectomy, pelvic and para-aortic. At least sampling or enlarged lymph nodes.
Sampling.
In early stages, you have to do to find out the stage, because once the lymph nodes are involved, they straight away go to 3C. Even
Yes,
if
ma'am.
peritoneum is not involved, abdomen is not involved. So you are in early stage, you have to do it. In late stages, advanced cancers, you may do debulking as much as possible. You have to remove and then proceed for adjuvant. So that's what it is, and it has to be done properly. And what else apart from this? You said mentectomy, lymphadenectomy. Anything else to be done
Mm,
in staging?
Suppose you are suspecting mucinous cystadenocarcinoma, what will you do? Mucinous,
if it is a mucinous tumor, we will do appendicectomy, sir.
you will do the associated appendix.
Yeah,
So
and you
advanced
have
stage cytoreduction you will do. What do you mean by optimal cytoreduction?
Sir, optimal cytoreduction is if the residual tumor size is less than 1 centimeter.
But recently you will have to do as far as possible. As far as possible. The optimal cytoreduction recently says as far as possible, even there should not be no residual tumor. It's an optimal cytoreduction. So what chemotherapy, what are the different modes of chemotherapy?
So for epithelial tumor, we give carboplatin and paclitaxel. For germ cell tumors, we give bleomycin, etoposide, and
Yeah.
cisplatin.
Any other method of administration of the chemotherapy? Other method? Other method?
you might
Do
have
you know
heard
intraperitoneal? Is there any intraperitoneal?
Intraperitoneal IPEC, sir, intraperitoneal chemotherapy is given.
what is latest in peritoneal therapy. What's the name given to that?
What is the name? Madam is asking what is the name of that?
It's HIPEC. Have you heard the name HIPEC?
Yes, ma'am.
What does it stand for?
Ma'am, it is hyperthermic intraperitoneal chemotherapy.
Yeah, in advanced stage, so that is the latest which is being given. And of course, I think your time, Dr. Shamishta, can we go on? And because ovarian tumor is a very big thing.
I think, ma'am, I think we're just about to end. We are on chemotherapy. You can take another 5 minutes so that this topic is fully covered. And then we start, ma'am, because we started at 11:10.
Yeah,
So,
yeah. So
another
that's-
5 minutes we can spare.
Okay. So what do you want to tell us about relook surgery and what is there? How do you follow up these patients? Let's talk about that. How do you follow up?
Before that, madam, just the chemotherapy, you'll have to conclude that the HIPEC you said, what do you mean by HIPEC and what do you mean by the targeted therapy? You must read these things. HIPEC, PIPEP, and the targeted therapy. You must read these three new things. You must read. And then madam is asking you that how will you follow up case of early stage carcinoma? What is the sequence? How will you follow up early stage carcinoma? After surgery, how will you follow up?
Sir, HIPEC is hyperthermic intraperitoneal
And
chemotherapy.
that is okay. You will read this because
sir,
there will be no
Acha.
time of discussion. Madam is asking you how will you follow up of the case? Any case of after surgery, how will you follow
Yes,
up?
sir.
How will you follow up?
So we will follow up with serial tumor markers. We'll see.
Not only serial tumor marker, we will have to the physical examination. That is the symptoms and signs also, parabdominal also, PV examination also. And then you the serial tumor marker C125 is the one of the parameter. So three parameters: clinical, C125, and also the ultrasound is imaging indicated. What is the frequency? Suppose you have stage 1, you have done surgery, you give chemotherapy, what will be the frequency? When you will come, ask the patient to come? Usually 2 to 4 months. 2 to 4 months. Usually it is 2 to 4 months for at least 2 years, and then half yearly, and then after 1 year. So this will be the follow-up. Now tell me the survival rate. Survival rate.
Sir, it has a very high recurrence rate. Ovarian cancers have
No,
18,
specific
80%.
answer you give. What is the survival rate of the stage 1? Very good survival.
Yes, sir.
Very good survival. Stage 1, how much?
So stage 1.
Stage 1 and stage 2 is very good survival. And stage 3 is the 30%, and stage 4 is the 20 less than that, 10 to 15%. Stage 1, it may be about 70 to 80%, and even 90%, stage 1. And stage 2 below that. And what is the overall survival rate of the cancer service? This is a very common question. Overall survival rate of the
Overall
cancer
survival rate is, sir,
45%.
45%.
What is the
45%.
overall rate of the CA endometrium?
85%, sir.
85%. Overall rate of the CA cervix?
So cervix is 65%.
60?
65 or 75. 65%.
65 to 70%. So majority of the ovarian cancer in the advanced stage recur, usually recur. 80 to 90% recurrences. And on why death is more common is a very common question for the positive gene. Why death is more common is because of ovarian cancer. It is the maximum death of the ovarian cancer and total death of the
So because of rapid spread. So because of rapid spread, first of all, it is more because of it is asymptomatic in nature, and that's why it's diagnosed late most cases. And,
so it is diagnosed late.
Yes, sir, usually.
How much diagnosed in the early stage and how much?
So 25% is diagnosed in the early stage.
Early stage, and let's say 75%.
75%.
Number 1. And number 2, you say.
Sir, it has rapid spread, and sir, high recurrence.
And you have already said the asymptomatic in nature.
Yes, sir.
You said asymptomatic. And number 3. Number 3. What is the difference between the CSRV?
Sir,
The death from the CSRV
it doesn't
reduced,
have any standard method of screening.
Yeah, there is no standard method of screening. Then the question will come: how to cancer the ovarian screening the ovarian cancer? That is I'm not going now. So you must read that how to screen the ovarian. Standard method of the screening.
Yes.
So if it is asked how to screen the ovarian cancer.
For ovarian cancer, sir, we will we'll first try to identify the high risk females.
Good. High risk.
And sir, for that we will see if they have a BRCA1 or BRCA2, if they are carriers of BRCA1 or BRCA2, or if they have a strong family history. Yeah. Other than this, we will measure serum CA125 levels, and sir, we'll also go with ultrasound.
Now, will do the CA125?
And sir, in those who are at high risk.
Only high risk cases.
Yes, sir.
The routine recommendation is not the for screening. High risk cases we will screen. We will have to detect the high risk cases. Then what is about the important question? How to prevent? How to prevent ovarian cancer in the modern day? How to prevent? There are 2 things I ask you when I expecting for you.
So if the patient has a family history of ovarian cancer, and we send her for a genetic testing and see if she has she's a BRCA1 or BRCA2 carrier, and if she is a carrier, we do a prophylactic salpingo-oophorectomy.
So prophylactic salpingo-oophorectomy in high risk cases. Any other thing? Any other thing? Any other thing? What do you mean by opportunistic salpingectomy? Opportunistic salpingectomy. These two things you know, that is the when you will do the prophylactic salpingectomy or prophylactic TH and BSO prophylactic. And second is the important thing is opportunistic salpingectomy. Opportunistic salpingectomy means when you doing any gynecological surgery and the patient is already family completed, you do the salpingectomy, even keeping the ovary. Even the RCOG says also that you can do the high risk cases in case of tubal ligation, salpingectomy other than only the fumaroidosis or like that, salpingectomy. So these two things you know, the prophylactic salpingoperectomy or prophylactic THBSO. So I think this is all.
Yeah, just one more thing.
Yeah.
In which cases you will, at what age will you remove the ovaries along with the hysterectomy? What is the current recommendation? And how much is the risk of ovarian malignancy if you leave the ovaries behind?
Good question, madam.
Ma'am, more than 50 years of age.
What is current recommendation? They say even after 50 years, it keeps on giving you some hormones, some protection against osteoporosis and all. Salpingectomy, yes, opportunistic you will do, but leaving the ovary, if you leave the ovary, what is the risk? You can read about it. Now, all of you can read about it. When to remove the ovary, what is the risk if you leave it, and when to do these procedures. I think that's all.
Yes, ma'am.
Thank you, ma'am.
So it was great, Malik ma'am, Maji sir. It was great to have this kind of, to be involved in such kind of discussion. I was feeling like a student. I was so engrossed with the discussion. So thank you, thanks a lot, ma'am, for leading us to that.
Thank you again. Thank you, Gangaram Hospital Officer, and thank you for good conduct by the Dr. Surmistha, Dr. Mala. Thank you all.
Yeah,
and thank you my co-moderator, Dr. Mittal. Many things I have learned from
Dr. Malik, sir.
Dr. Malik. Sorry. I have already Dr. Malik. Sorry. Thank you.
So again, not to forget, Dr. Tasneem, thank you for presenting such a nice case and leading the discussion to a level that we have discussed the prevention also. So thanks a lot for this beautiful presentation. And for the next session, I would like to call Dr. Vasundhara. She's our next presenter. So she will be presenting her case on primary amenorrhea. And for this session, I will have Dr. Shweta Mittal Gupta. She's a senior consultant, Department of IVF, Sir Gangaram Hospital. And we have Dr. Niti Tiwari. She's also senior consultant, Department of Obs and Gynae, Sir Gangaram Hospital. So I request Dr. Vasundhara to please start with your presentation.
This is a very interesting topic, very fond of I myself, and Molana just arranged primary amenorrhea. But I am very sorry now. I have another assignment. I am leaving.
No problem. No problem. Thanks for your time.
Important topic, that the primary amenorrhea. Thank you. I
Thank
am
you.
leaving. With permission, I am leaving.
Sure. Dr. Vasundhara, are you ready?
Yes, ma'am.
Okay. Please start with the screen sharing.
Vasundhara, we would like your video also to be on.
Yes,
you have to face examiners in your exam.
Yes, ma'am.
So one should get confidence to switch on the video also.
Yes, ma'am.
Okay, good. Start now.
Ma'am, actually, I have sent my slides for to Mr. Vinod for running.
Mr. Vinod, are you there?
Ma'am, I am having the slides. If you permit me, I'll display the slides. Just a moment, ma'am. I'm opening the slides.
Okay, Vasundhara, you can start now.
Okay,
Make it screen share, Vasundhara, because we are seeing it on the iPhone. Mr. Vinod, can you make it screen share? The whole thing, slide share.
Yeah, I think now it's visible.
Yeah, thank you. Thank you. Now we can start.
Good afternoon, everybody. Today I'm going to present my case on primary amenorrhea. My patient, next slide, please. My patient, Miss X, 16-year adolescent, studying in 12th standard, resident of Rajouri, New Delhi, daughter of Mr. M, working as a shopkeeper, belongs to lower middle socioeconomic status by modified Kuppuswamy scale. Next slide. She presented with the complaint of not attaining menarche till date. History was elicited from her mother. Next slide. There is no history of cyclical abdominal pain, urinary retention, mass per abdomen, no history of milk secretion, nipple discharge, no history of cold intolerance, weight gain, loss of appetite, constipation, no history of acne, excess hair growth, deepening of voice, no history of eating disorder, aversion to food, vigorous exercise, no history of headache, hearing loss, absent smell sensation. Birth and developmental history. She is third born out of a non-consanguineous marriage, full-term institutional vaginal delivery, average weight, cried immediately after birth, mother's ANC period was uneventful, external genitalia was of female type and appeared normal. Her motor developmental milestones were appropriate for age. Speech development was normal. Scholastic performance at school is average. Physical growth and appearance correlates with the peer. Mother noticed breast development at 13 years of age and axillary and pubic hair at 14 years of age. Family history. Her mother's present age is 38 years. She attained her menarche at 41 years of age. Patient has 2 elder and 2 younger siblings. 2 sisters, one aged 19 years and other 10 years. Older sister had menarche at 14 years of age. No history of mental retardation, autism or developmental delay in her siblings. Personal history. My patient takes mixed diet, normal appetite, no history of eating disorder, normal sleep, normal bowel and bladder habits, no history of smoking, alcohol intake or drug abuse. Medical and surgical history. There is no history of diabetes, hypertension, thyroid disorder, seizure disorder, tuberculosis, mumps, cardiac, renal, liver, GI disorder. There is no history of any surgery or chemoradiation exposure. On general examination, my patient was conscious, well-oriented to time, place, and person, moderately built, well-nourished, hydration adequate, height 147 centimeters, weight 50 kg, which corresponds to a BMI of 23.1 kg. Per square meter, arm span 149 centimeter, and spine and gait were normal. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema present. Her vitals, temperature 97.2 degree Fahrenheit, axillary, respiratory rate 16 breaths per minute, pulse rate 82 per minute, regular in rhythm, good volume, normal in character, no radio-radial delay and radio-femoral delay. BP, blood pressure 120 by 70 millimeters of mercury in right arm, sitting position. On head-to-toe examination, normal hairline, short neck present, no webbing present, normal alignment of teeth, facial features normal. There was no enlargement in thyroid. Thyroid examination was normal. No other stigmata of Turner's phenotype. No acne, hirsutism or acanthosis nigricans. Secondary on examination of secondary sexual characteristics, breast, the development of breast corresponds to Tanner stage 4. No discharge present. Axillary hair was present. The other system examination were within normal limit. Next slide. On abdominal examination on inspection, flat abdomen with central inverted umbilicus, all quadrants move equally with respiration, no visible mass, stria or scars, hernial orifices appear normal. On palpation, soft, non-tender, no organomegaly, no palpable mass, hernial orifices free. On auscultation, bowel sounds heard normal. examination of external genitalia done in presence of mother. Pubic hair corresponds to Tanner stage 3. Mons pubis, labia majora, labia minora normal. Urethral opening normal. No clitoromegaly. Vaginal orifice seen. Small and blind ending. On per rectal examination, uterus not felt. Summary, 16-year adolescent girl with complaint of primary amenorrhea with a normal height and normal secondary sexual characteristic. On examination, normal stature, breast corresponds to Tanner 4, pubic hair corresponds to Tanner 3, short neck with no webbing, with normal female external genitalia with a blind ending vagina and possibly absent uterus.
Okay, so Vasundhara, after your history and examination,
Yes, ma'am.
what are the differential diagnosis which you can make on only on the basis of history and examination?
Ma'am, on the basis of examination, as possibly on per rectal examination, uterus was absent. It is a case of primary amenorrhea, and plus the secondary sexual development is normal. So we can have a differential of MRKH or androgen insensitivity syndrome, or any outflow tract obstruction. No,
You
ma'am.
are saying that
Only
the
MRKH and AIS as uterus
yeah.
is absent.
And what else do you expect when there is a outlet obstruction? Now that you have uttered this in differential, what
Ma'am,
else do you expect?
in outflow tract obstruction, the patient will give a history of cyclical abdominal pain, plus on palpation per abdomen we can feel the hematometer or hematoculpus as a palpable mass, plus there will be sometimes they can complain of urinary retention and um, uh, difficulty in micturition, pressure
Okay.
something.
Okay. So we have a differential of
And ma'am,
MR.
on examination, there we can see on local examination bluish bulging membrane.
Yeah,
Perineal
you
ring.
can see a bluish bulging membrane. So now that we have two differentials in mind, one is MRKH and the
Yes,
other
ma'am.
is androgen insensitivity. So how will you differentiate between the two? How will you come to your final diagnosis?
Ma'am, we can do a karyotyping.
Okay.
But on initially on the basis of examination, ma'am, in MRKH, the secondary
Are you
sexual
very
character.
confident about, just a minute, Vasundhara, are you very confident about your PR examination? Would you like to confirm whether, uterus is actually absent or not?
Yes, ma'am, I would like to confirm. That's why I just mentioned possibly uterus is absent.
Yeah. So what will you do?
Ma'am, we will go for an ultrasound.
Yeah. So first you should, I'm sure we have to develop our clinical skills in such a way, but with a 16-year-old girl, sometimes PR examination is difficult. They might
Yes, ma'am.
refuse. And even if you do it, they might not let you examine. They are not relaxed enough. So first of all, we have to make sure that, we, after the impression which we have got on the examination is correct or not. So
Yes,
first of
ma'am.
all, we will have to confirm whether the uterus is absent or not. And how do we do it?
Ma'am, we go for an ultrasound.
What kind of ultrasound?
Ma'am, transperineal ultrasound, or
Transabdominal will not tell us.
ma'am, transabdominal
Your
also. But
patient is a thin patient, hai na? She's
yes,
not a obese patient or anything. So first of all, you will go for a more common things which are done, no?
yes, ma'am.
So you will do a transabdominal scan. What
Transabdominal.
thing will you take care of when you do a transabdominal scan in this patient? Bladder full? Simple. Yeah.
Okay, ma'am.
And you will ask her to be bladder full. And what do you expect to find on ultrasound in both the situations?
Ma'am,
You have given me two diagnoses, no? So can you make out something on ultrasound also?
ma'am, in androgen insensitivity syndrome, gonads will be not present.
You might not see them there.
You might.
And what happens in MRKH?
Ma'am, MRKH can present as ma'am, uterus will be absent, or
uterus will be absent in both. Yeah. So first
yes,
thing which you will say is that the uterus will be absent.
yes, ma'am.
Yeah, or there might be a very small bud, but no endometrium. You will not see any endometrial lining, maybe a small uterine bud, or it will be absent. And what do you see in MRKH?
Ma'am, in MRKH, gonads, ovaries will be present.
Okay, what would be the location of ovaries in this patient?
Relatively higher than in normal.
They could be relatively higher. Okay. And now you have done the ultrasound and you are convinced that the uterus is absent. Okay.
Yes.
And you have some idea whether you are dealing with an MRKH or a androgen insensitivity. So how will you confirm that what is the final diagnosis?
Ma'am, by karyotyping.
So what do you find in karyotype?
Ma'am, in androgen insensitivity syndrome, they are genotypically males. We will have a 46XY, while in MRKH, they are genotypically female.
Okay. So now if suppose it is androgen insensitivity syndrome, yeah,
yes, yes,
what we are dealing with, how are you going to counsel your patient and how are you going to proceed? Now suppose this patient is androgen insensitivity, what you are seeing right now, the mother is sitting in front of you. How you are going to counsel her? What is your final diagnosis? How you go about it? How you are going to counsel her?
Ma'am, firstly, we will tell her about the positive points.
Firstly, will you tell her that she's a male actually? How will you break this news of her karyotype? See, counseling is very important these days, है ना? So how will you break this news? How will you counsel her? What will you tell her?
Ma'am, we will tell her about, firstly, we will tell them that, ma'am, we have to tell about the gonads in every situation, because sooner or later after puberty, she will need gonadectomy. So we will reveal that we.
Yes, you are right. So you have to tell them, that her genotypically she's a male.
Genotypically, she is a male, but she will have external female features phenotypically as a female,
and she can lead her life like any other normal female.
Normal female.
Yeah, and then.
And we can offer her, then we will counsel her that because of chances of malignancy formation in the gonads after puberty, after she attains puberty, she has to she has to go for gonadectomy. Then we will also counsel them about the.
But where are the gonads? You said that there will be no gonads on ultrasound. So where will the gonads be?
Ma'am, in the inguinal region, they can be from anywhere between the inguinal region.
Suppose you're not able to find the gonads on ultrasound, and your examination is also not telling you anything. What will you do to confirm where are the gonads?
No, MRI.
Okay, so you can confirm it on MRI, the position of the gonads, so that you can plan the surgery accordingly.
Yes, ma'am.
Yeah, and suppose she's MRKH, how you are going to counsel?
Ma'am, if she is MRKH, then we will counsel that the patient, firstly, we will tell about all the positive points, that the patient can have normal sexual, normal sexual life. She can go for a vaginoplasty before marriage. She can. And ma'am, she will have a normal sexual, secondary sexual characteristic, and will grow as a normal female.
Okay. And
we can give her about options about, ma'am, reproductive.
So what
Okay,
will be
so
your approach for gonadectomy? Will it be, what kind of an approach would you do?
ma'am, the AIS is the single Y chromosomal link disorder in which gonadectomy is done after puberty at the age of 16 to 18 years.
No, what is the mode of gonadectomy you would choose?
Ma'am,
In
mode
today's
of,
scenario, how would you go ahead?
ma'am, laparoscopically.
Yeah, so in laparoscopically, how will you remove the gonads? Because I had a patient who had two malignancies, you know, inside the gonad. So what would be, how will you remove them?
Um,
How will you ensure that there is no spill because you're removing them laparoscopically? So you will always remove them in an endo bag, right? Now, sometimes, you know, in one of my patients, the gonad was very close to the renal area. So it's very important that in AIS, you know where the gonadal location is. Because if they are in the labioscrotal fold, then you don't need a laparoscopy. If you're doing it laparoscopically, then you should know the exact location of the gonads. So my patient had two malignancies. So then all the tumor markers were done. You have to follow them up, and then you can advise them, you know, whatever is the fertility. So yeah. So what were you saying the last?
Ma'am, gonadectomy.
So
Chances of malignancy.
what is one case of where the karyotype is XY, but they have uterus? What is that syndrome called?
Swire.
So clinically, how will a Swire syndrome behave differently from AIS?
Ma'am, in Swire, there is mutation of the SRY gene. Because of that, the AMH formation is less. There is mutation in means AMH formation is less, and it is used to inhibit the Mullerian duct formation. Organs formed by the Mullerian duct. So everything will be formed. It's just that she will grow as a female. And
No. Now tell me one thing. Clinically, how will she present with? She will present with as a case of?
means
She will present with a case of primary amenorrhea. But how will it be different from your MRKH and TFS?
Ma'am, uterus is present in Swire.
Yes, so uterus is present in Swire. So clinically, this will be like a patent outlet with primary amenorrhea. If you have the karyotype, it will be 46XY.
46XY.
But so what do you have to distinguish between? Now, Swires has to be distinguished from one condition of primary amenorrhea, which a karyotype can help.
Of a Turner, because in this
Yes.
also gonadal dysgenesis is present.
Exactly. So clinically, you will see that there's a case of primary amenorrhea. And ultrasound, you will see streak gonads, which you will see in Turner's too. There will be no stigmata of true Turner's.
Yeah, ma'am.
So they will look like a primary ovarian insufficiency, but only when you do the karyotype. So is there a role of gonadectomy in Swires?
Yes, ma'am. As soon as the diagnosis of Swire is made, a gonadectomy is done.
Do you do it at 5 years of age?
No, ma'am. The Swire will present only as a case of primary amenorrhea.
So if you detect something, you know, the girl is not growing her height, and you start seeing and you do a karyotype anyway at some early age. So it's around about the same time when you would do gonadectomy for other cases also. That's around pubertal age group. But what is the difference in the management of TFS, that is AIS, in terms of fertility from Swires? Who is more blessed?
Ma'am, Swires is more blessed because they have uterus. So they can go for donor egg plus IVF, then embryo transfer.
So from the age of 16, suppose she finds a partner by the time she's 25, what will you do in Swires?
Ma'am,
before marriage, before finding a partner, pubertal.
Ma'am, your voice is not coming.
I'm saying, what will you do for SWAS?
What she's saying is she's
Can you hear
basically a
me?
patient
Okay.
of primary amenorrhea, na?
Yes, ma'am.
So how will you, solve that problem? She has a uterus, but she's primary amenorrhea.
Then,
So how will
ma'am,
you
we
solve
can
that
take
problem?
her estrogen and
Yeah.
Yes.
just like Turner's, we can give her low dose estrogen and then progesterone for withdrawal date.
Yeah.
Yes.
So this is hormone replacement.
Yes, ma'am.
So coming back to MRKH and TFS, Dr. Neeti, what all last question you had asked her?
Last we were talking about MRKH only. How do we, because now we have discussed all the three aspects. Can you tell me which is the common tumor which is there in case of AIS?
Gonadoblastoma.
Yeah, good. Gonadoblastoma. So now we are coming back to your patient, Hannah, and you are convinced that your patient is MRKH from your history and examination. You have convinced that she is MRKH. So now, what will you do? How will you counsel the patient? Now she asks you that, I'm basically primary amenorrhea. I want to have menses. What do you tell her and her mother?
She wants to have menses.
Yeah, that is her complaint. No, she never had menses. So what do you tell her?
Ma'am, we will counsel her regarding the Mullerian agenesis.
Yeah.
We will counsel her that she is not having uterus and cervix and the endometrial lining, which needs to be shed off. The uterus is not present, so she can't have that cyclical bleeding per every month.
But the good part is
people have a normal sexual life.
and the good part is that she has ovaries, no?
She has ovaries, yes,
So
ma'am.
she has hormones. She has female hormones inside her. All her secondary sexual development will be normal. And all the positive effects of estrogen would be there for her, but she cannot have menses. So that is how you're going to tell her. And then what about her reproductive life? What about her?
She can have a vaginoplasty as whenever she wants to start her sexual life, or within prior to 6 months of marriage, and after that she can opt for oocyte retrieval and IVF and gestational surrogate.
Okay.
So what are the different surgeries you can offer her for MRKH?
MRKH, either we can do vaginal dilatation, which takes 3 to 6 months for proper vagina formation, proper length, or we can offer her vaginoplasty or
So what are the different methods of vaginoplasty?
Ma'am, vaginoplasty can either be done by split thickness graft or amnion graft, and we take the graft and a mold is used, and by the help of the mold, the graft is placed in position and
what are the risks
quickly also.
What is the risk of surgery? What are the two important risks intraoperatively, and why a skill is required to do this surgery?
To risk intraoperatively.
Very important to risk, because what is lacking? The introitus.
Have you seen a vaginoplasty being done, Vasundhara?
Yes, I have seen.
So what happens? Just tell us, not book-wise, what did you see in your vaginoplasty surgery which was being done? Did you see which route? Which route was it?
Ma'am, vaginally.
Okay.
Placenta was brought from a freshly delivered the baby placenta, and then amnion was grafted from that. And
before that, what was done?
No, what is the plane of dissection? What do you do?
Where do you put the graft? First, you have to
recto-vaginal space, ma'am.
So what are the injuries which can happen very commonly?
Ma'am, rectal.
Yes, and
anterior?
Anteriorly, because the space is not there, right?
Yes, ma'am.
So it's bladder injury and rectal.
Bladder. Yes, ma'am.
So did you see how the space is made? And that dissection requires expertise.
What
That
is
dissection
one
requires expertise.
advantage and disadvantage of split skin graft and amnion? Both.
Ma'am, in amnion there is ma'am, I don't know.
Suppose the patient is in the quarantine period of HIV or hepatitis C and B because you have only done one-time testing. So theoretically, there is a risk of transmission. A split skin graft, of course, you are taking it from the own body. So there's a small surgical procedure. So the taking up of amnion graft is much better. It's more cleaner. I have seen a lot of amnion grafts when I was doing my fellowship. So it's much more cleaner, but the theoretical risk, of course, is that. And then same day, a cesarean or a delivery will have to happen so as to procure the amnion, right?
Yes. Yes.
And what is another disadvantage of the split skin graft? So though it is taken from the medial aspect of the thigh, okay, the non-hairy part of the thigh, it is taken from the medial aspect of the thigh, but the hair follicles are there.
Okay.
Yeah, because otherwise vagina does not have hair, no?
Yes, ma'am.
So the hair follicles are there. So that is one disadvantage, that there could be, those hair, this thing in the vagina.
What is the other new technique by which now this procedure has been performed?
Ma'am, I read it, but I was not able to understand.
Yeah, which is okay. You can just mention it laparoscopically.
Yeah, that's it.
What is the commonest cause of primary amenorrhea, Vasundhara?
Ma'am, common gonadal dysgenesis.
Right.
3%.
Yeah. So what else? So suppose, Dr. Shweta, do you want to ask any question related to MRKH? Otherwise, we can go on to other causes.
No, I think just one more thing, that when you are doing IVF in MRKH, what are the challenges what you can come across?
Which you just mentioned, when we were talking about the ultrasound.
She did that?
Yeah, she did that. So you were saying,
Okay,
what?
Oocyte retrieval.
So then,
Yeah,
Vasudha,
so what will happen?
Yeah.
Ma'am, adequate follicles might not be present.
Why? She can have any kind of profile, like any other woman. She can be a normal responder, she can be a PCO kind of picture, anything. But you told me something in ultrasound, na?
That where can the ovaries be? Where can the ovaries be placed?
Higher, relatively higher than normal.
So what could be the challenge during oocyte pickup, and especially when the uterus is not there?
Injury to adjacent vessels, ma'am.
So the challenge first can be difficulty in the needle going, because if it is high up, sometimes we may have to do trans-abdominal retrieval. And because they have a very small vaginal length also. So the needle has to go very delicately from that area.
Yes,
it's not a normal vaginal length. So once in a while, we did one aspiration transvaginally and one ovary from the transabdominal route.
Yes, ma'am.
What about in TFS? Once you have removed the gonads, what is the fertility option for them?
Ma'am, for TFS, they don't have the gonads, so they can't go for oocyte retrieval. They have only the option of ovum, donor ovum, and embryo gestational surrogate.
Yes, so they will need a donor egg as well as a surrogate. And if suppose in India now, since commercial surrogacy is banned and they don't have their self surrogate, then what is the other option?
Ma'am, then they
will have to go for adoption, right? Okay. Adoption is one option, but
viable option, yeah. And what is another option which we talked about the other day also?
A uterus transplant, ma'am.
Uterine transplantation, though it is still not, that much available right now, but that can be more available now that the surrogacy laws have come in. More research will be done in this area, and maybe, it will come up.
So when you get a patient of primary amenorrhea, how do you quickly differentiate? Can you just give a mind map?
Ma'am, when a patient of primary amenorrhea presents, then we see whether she is having a normal secondary sexual characteristic or not. If normal secondary sexual characteristics are present and on examination uterus is absent, then we go for the diagnosis of differential of MRKH or AIS. If axillary hairs are not present, then we go more towards the diagnosis of AIS. If there is a palpable mass and the history of cyclical abdominal pain is present, then our DD goes more towards the outflow tract obstruction, which can be imperforate hymen or transverse vaginal septum, which is the defect in the vertical fusion of the Mullerian duct formation and the urogenital sinus valve. Then we if the stature is if the height
outlet is present, what are the two important distinguishing differences, differential diagnosis of primary amenorrhea, if the outlet is present?
If the outlet is present.
Yes. So one is outlet obstruction, where
Yes.
you said one is true outlet obstruction.
Then gonadal dysgenesis can be there, Turner or mosaic or.
What are the two WHO? Which category falls into primary amenorrhea outlet present? WHO type, what and what?
One, ma'am, we
in the
start from the
very well.
lower compartment first to one.
So one is hypo. The second is?
Then, ma'am, second is hypo.
One is hypo type 1. And what is type 3, which is hypergonadotropic hyper. Other causes of premature ovarian insufficiency. And the rare causes would be where the outflow is present, the gonadal function is normal, but they have primary amenorrhea. What is that? Can genital tuberculosis present as primary?
Yes, genital tuberculosis, and then
and very rarely, very hyperandrogenic girls, PCO normally will not present as primary amenorrhea, but that. So when you distinguish your primary amenorrhea, then you say outlet present, outlet absent, outlet absent. The true causes are MRKH and your androgen insensitivity. Cryptomenorrhea is all hematocolpus, transverse vaginal septum, cervicovaginal atresia. When outlet is present, then you have type 1, type 3. Normal type will have genital cox. So these are the gross ones, where 90% of your cases will fall into that. Leaving aside, anorexia nervosa or PCO presenting, they are very rare causes. Or severe hyperprolactinemia.
Yeah.
So Dr. Neeti, do you want to wind up? Or is there any other question from the chat box? If somebody wants to speak, we can target that. We have about 5 minutes more.
No, ma'am, no as such questions. There was only one question that since axillary pubic hair were present, so why were we keeping androgen insensitivity syndrome in our diagnosis?
Yes, so because, yeah, Dr. Vasudha, can you give this answer?
Ma'am, because AIS can be complete, there can be complete androgen insensitivity syndrome or partial. Incomplete, there is total absence of hair, but in partial, the hair can be present in
yes. So in partial, what would be happening to clitoris? Can you see a difference if there's a partial?
Be present.
Yeah, so it could be enlarged. There could be a small phallus, and they could also present with ambiguous genitalia. So no matter what the clinical presentation is. However, karyotype is very important because we should not be missing a Y component. Sometimes I have also seen females coming as XX with a little Y on the X, a very small component with little ambiguous genitalia. So karyotype in a primary amenorrhea becomes a mandatory investigation so as to not miss this diagnosis.
Yes, ma'am.
Okay, Dr. Sarmishta, I think we can wind up. Thank you very much. It was a very good presentation.
Thank you,
Thank you,
ma'am.
Shweta, ma'am.
Yeah, thank you. Bye-bye.
Yeah. Thank you, Dr. Vasundhara, for this
Thank
elaborate presentation. So I think we covered all the topics in primary amenorrhea. So it was nicely done.
Thank you, ma'am.
Okay, Vasundhara. So, thank you, Dr. Neeti. Dr. Shweta.
Thank you, Dr. Sarmishta. A very good presentation, Dr. Vasundhara. And I want all the PGs to note that the way she had taken the detailed, history of obstetric history of mother during her birth becomes very important. Family history is very important. Developmental milestones are very important. So one should not miss on these kind of histories. Thank you so much. Good work, Vasundhara.
So now next we move on to the dummy pelvis, which is already a pre-recorded lecture by Dr. B.G. Kotwani, ma'am. So I would request the backend team to kindly play that. So Dr. B.G. Kotwani, ma'am, is our active retired consultant. She has been the teacher of teachers, and she's into academics for, for about 60, 70 decades now. So she has trained most of the teachers who are now in Delhi. So we all know, ma'am. So a big thanks to Dr. Kotwani for giving her time. And I request the backend team to please start with the presentation. Dr. Sakshi Nair is already with us. Yeah. So students, please pay attention. Ma'am will be demonstrating the, so kindly pay attention to that.
You have a occipital bone, then the parietal bone, frontal bone, right? Between the parietal bone and the frontal bone, there are two sutures. There are two sutures, and there is a posterior fontanelle. Then there is a sagittal suture between the two parietal bones, and then there is the root of the nose. Now, when the baby is fully flexed, the diameter is suboccipitobregmatic from below the occipital protuberance to the anterior end of the bregma, anterior end. Now, when there is a normal labor, head is never fully flexed. It is deflexed. So in the beginning, there is occipitofrontal, that is from the same occipital protuberance to the anterior end of the bregma, anterior end of the bregma. So when there is a normal labor, initially there is a suboccipitofrontal suture, and then there is a descent, and then there is a flexion, and it gets complicated on the pelvic floor. And then it becomes suboccipitobregmatic. Okay. Then when there is a suboccipitobregmatic below the occiput to the center of the bregma, then deflexed from the suboccipit to the anterior end of the bregma. Then there is a frontal lobe and there is a parietal eminence. So in occipitoposterior, the engaging diameter is deflex, head flux. The occipitofrontal diameter, that is 4.5 inches. It goes from occipitoprotuberance to the root of the nose. Now in occipitoposterior, if the baby is average size and if the pains are good, then 90% will rotate normally, 90%. So from suboccipitofrontal, it will become occipitofrontal, then suboccipitobregmatic, and then she will deliver normally. Now, when there is a occipitoposterior, normally the shoulder, if it is like that, shoulder is from the occipitoposterior, there is a depression, and the first bony point which you feel is a shoulder. Now this shoulder is between the midpoint between the umbilicus to the anterior superior spine, and the midpoint is where you get the shoulder. ये क्या है? ठीक है. shoulder. Now, when there is a occipito-posterior, the head is deflex. That is, head is occipitofrontal diameter, occipitofrontal diameter. And then it becomes suboccipitofrontal and then suboccipitobregmatic. So when there is a suboccipitofrontal, 90% will rotate normally. If there is a good uterine contraction, average size baby, and late rupture of the membranes. If the membranes rupture, the head will not rotate. So late rupture of membrane. So 90% will deliver normally, but 10% will become problem. Now, in some cases, this occiput will go to the sacral hollow. It will rotate to the sacral hollow, either in the sacral hollow. So it comes down, and the syncipit comes under the symphysis pubis. This is a vertex presentation. So you get vertex presentation, you get flexion followed by extension. So when there is a occipito-posterior, normally they need little help. You need a forceps. You put the left blade, the right blade, and routing will be easy because sagittal suture is in the midline. Then you pull it down till the root of the nose. Then you flex it, occiput comes, so you give a big episiotomy. So flexion followed by extension, face to pubis delivery. So 90% will deliver normally, and some will go into, especially if it is anthropoid pelvis, then it will go into the sacral hollow, and it will come down till the root of the nose. And it is a vertex presentation, so you need help. You put a forceps, left blade, right blade, lopping will be easy. Pull it down till the root of the nose, and since it's a vertex presentation, it will be flexion, and you get episiotomy and then extension. Flexion followed by extension. And some will rotate partially, so it will need some help. It will need some help. So we might have to do vacuum, or we have to do forceps delivery. So this is about the occipito-posterior. Now, when there is the occipito-posterior, the shoulder is 3 inches away from the midline. And when the patient is coming down, there will be descent and more flexion. So suboccipitofrontal, then it becomes suboccipitofrontal, then suboccipitobregmatic. This will come down, and when you are treating occipito-posterior, you mark out shoulder. You mark out shoulder, and keep on seeing whether the shoulder is coming down and medially. If it is coming down and medially, then you will find that this patient will deliver normally. But if it comes vertically down, they need a cesarean section. So this is about the shoulder. Now you pelvis. 1 minute, or if it is attitude there, and if it is occipito-posterior, normally bulging part is on the same side of the back, but if it is opposite to the limbs, it is same now. But if it is extension, face presentation, then you will find that after the head, there is a groove, and the back is not filled properly because there is an extension. So you will find that after the head, you find that back cannot be filled. It will only be filled in the lower part. So this is about the fetus. Now, pelvis. Pele, I always say, you must know the plane of the pelvis. It is an imaginary plane. It is an imaginary plane bounded by the boundaries of the pelvic inlet. That is symphysis pubis, pubic tubercle, pectinal line, iliopectinal line, then ali of the innominate bone, sacroiliac joint, and then sacrum. This is the plane, imaginary plane bounded by the boundaries of the pelvic inlet. The head is pelvis is never at right angles. It is always tilted. So if you extend the plane to the horizontal, it makes an angle of inclination. Now, angle of inclination. Now, I would like you to say what is position, what is attitude. Longitudinal line, you will find either bridge or vertex, whatever. But if it is oblique, then it is transverse line. Acromion is the plane. Now, if you draw one line at right angle to the plane of the brim, one line at the plane of the brim, so you have to find the midpoint of this, an imaginary line drawn at right angle to the plane of the brim in the middle. White transverse is posterior, but center because the baby fetus has to come through the center. So you will find that you draw a line between the two bones and in the center, that means midpoint of the sacral promontory to the midpoint and transverse line. And the imaginary line drawn at right angles to the plane of the brim. And if you do the same thing in the mid cavity and outlet, you want a curve of Keres. Curve of Keres is downwards, backwards, downwards straight and downwards forwards. So curve of Keres is where the baby has to go through the curve of Keres. Okay? Curve of Keres. Now, this is a plane. This is a inlet. If you do the PV, you feed the anterior wall. It is rounded. But if it is an android pelvis, it is beating. So you trace it up to halfway and then you can't trace it. If it is a contracted pelvis, you can trace it. If a contracted pelvis, you will go up to the sacral promontory. But otherwise it will go here, or oblique, and then that's all. So this is what we do when you do a PV. So boundaries of the pelvic inlet are AP diameter. AP diameter is a symphysis pubis to sacral promontory. This is 11. This is 11 centimeter. This is 11. But symphysis pubis is like that. It is like that. So it is nearer. So it is 11.5, then 11, and diagonal conjugate will be from below to the sacral promontory. Normally we don't feel it. So you will find that when you do a PV, you will go rounded, then here and then disappear. Now, at the brim, we have got AP diameter, which is 11.5. But the shape is like that, little below the upper border. The optic AP diameter is there. That is 11 centimeter. And this is the diagonal conjugate is from below the symphysis pubis to the sacral promontory. Now this is 12.5. And it may say main thing is that you cut 1.5 and you get the imaginary plane of AP diameter, so that you can know what is the AP diameter, because you can't measure it. So this is 11, upper border to this thing is 11.5. Then this is anatomical, then obstetric, then diagonal conjugate. Now diagonal conjugate is very important because this is parallel to the sacral promontory. But if it is an android pelvis, the symphysis pubis is big. So when we do a PV, you will have to cut more. If the pelvis is tilted inside, then you have to cut less. So it will depend upon the length of the symphysis pubis. Now the second is a plane of greatest dimension. Side walls are parallel. And they are AP diameter and transverse diameter. This is second and third sacral promontory, and this is 12.5 centimeter. This is not important. If it goes down to the least pelvic dimension, then you will find that you will have problem. Now, what is the least pelvic diameter? Because baby has to go through the least. You go, least pelvic diameter is from the lower border, iliopectineal line, taken to the internal scale spine. From scale spine to the third and fourth sacrum, there is a ligament which is called sacrospinous ligament. Now, if it is sacrospinous ligament, you can't feel this whole arch, but if you can do a PV and you find that it is more than 2 centimeters, then it is shallow and wide. But if it is very tight, this is very here, so it is very nice. It will be android pelvis, narrow and deep. So in gynecoid pelvis, sacrospinous ligament is felt, and then you go above that. If you find that 2 fingers can be kept, then you will find that this is shallow and wide. It is in gynecoid pelvis. But if it is narrow, if it is very narrow, it is narrow and deep. That is in android pelvis. Okay? So knees pelvic diameter, and normally we can feel the scale spine on both sides. You can have an imaginary plane, it is 10 centimeters. So you find out the scale spine, whether they are bulging inside or if it is narrow. If it is narrow, there will be obstruction. Okay? Now comes the outlet. Now, other diameters. This is 11.5. This is 11.5, then oblique diameter. Right oblique is from the right sacroiliac joint to the iliopectic eminence. Remember that AP diameter is 11.5, this is 12.5. And transverse diameter wide this is 13.5. Remember easily that anatomical, it is 11.5. Oblique is from sacroiliac joint to the iliopectic eminence, that is 12.5. And wide this transverse diameter is 13.5. Now 13.5 has got no meaning. Posterior midpoint to the sacral promontory is posterior sagittal diameter, which is 4.5 centimeter. Okay? So main thing is about mid cavity. If the head can come up to the mid cavity or 2 centimeters below, then there is no chance baby will deliver normally. But if it is not coming, it is a scale spine or above that, it will end in some problem. Either the pelvis is small or the baby is big. So this is what it is. Now outlet is very important. Outlet, AP diameter, lower border to the sacrococcygeal joint. And between the two transverse diameter, scale tuberosity. Anterior to the midpoint to the sacrococcygeal joint, it is 6 centimeters. And scale spine to the coccyx is 9 centimeters. So if it is android pelvis, then the baby has to go from the posterior part, and there's chance of third degree perineal tear. So you have to be very careful. You have to be very careful when we do the outlet contraction. Sometimes the outlet is very narrow. If it is upper part, say spine, dorsal spine, there is scoliosis in the lumbar region. If the kyphosis is in the lumbar region, there is an outlet contraction. So outlet contraction, so you will have to make the posterior process, whether it can come. Normally the head comes down and there is a waist space of only 1.5 centimeter and she delivers normally. But if it is an android pelvis, it has to come down from the posterior part, and that is why you get problem. You understand? So position or lie. Lie is a lie means a longitudinal lie or transverse lie or oblique lie. Longitudinal lie is always in the breech or vertex presentation. Oblique lie is in transverse lie. So lie attitude is a position of the fetal parts on either it is flexion diameter or extension diameter. So flexion diameter, you will get it in vertex presentation, and in extension, you get face presentation. So in face presentation, there is an attitude of extension. So you will have to face presentation. This is coming down here. So you keep on face presentation when we are delivering. Then you keep on doing extension followed by flexion. In vertex, you do flexion followed by extension. But in occipital posterior face presentation, there is extension, is a face presentation, then you do a PV, you find that portion between the mouth and the orbits are there. So you keep on doing extension, and even episiotomy, and then you do flexion. So you do extension followed by flexion. You understand? So this is what it is important, that pelvis, you have to know the plane of the brim, plane of greatest dimension, least pelvic diameter, and outlet. Okay? So you have to be very careful. If there is a lumbar region, there is a kyphosis, then there is an outlet contraction. So you must be very careful that the head should not come down to the outlet, because you will end in stillbirths. Bas. ठीक है.
Yeah. So this was ma'am's lecture on pelvis, tummy pelvis, and about the fetus. Since we have more time, ma'am also has a pre-recorded lecture about the breech delivery of the breech baby. So we are going to now play it for the benefit of our PGs.
I think every obstetrician should learn delivery of breech. It is important because the patient may be not antenatal, and second, the breech may have no cardiac activity and she has to be delivered vaginally. And in fetus, they can be moderate or gross hydrocephalus. There, the patient has to be delivered vaginally. And sometimes the patient says she has got 4 children and she wants the delivery by breech. Now, I want to tell you the incidence of breech. 25% at 28 weeks. At 32 weeks, it's 16%. But at term, it is only 3 to 4%. Now, if the first pregnancy is vertex, the breech incidence is 2%. First pregnancy is breech, the incidence is 9%. If 2 patients have breech incidence, it is 25%, and 3 breech incidence, 40%. Probably in last 3, there is abnormality in the uterus, that is uniconvate, biconvate, subseptum or complete septum. Now, spontaneous version occurs in multigravida in 68%, and in primate it is 38%. 25% spontaneous version can occur even after 36 weeks. I had one patient who came with full-term pregnancy, and she was breech presentation, and the report was breech presentation. She was posted for cesarean for the next morning. She was taken to OT, and I found that it was a vertex presentation, and then she was taken to labor room and she delivered normally, showing that patient even at term can undergo spontaneous delivery. Now, the type of breeches are fully flexed breech. Fully flexed breech, it is incidence is 5 to 10%. Then incomplete breech, it is 50 to 70%. And in footling and knee presentation, it is 40%. The third is complicated breech, that is patient has got breech with toxemia and placenta previa. Now you see in this picture, frank breech, yeah. Frank breech, a complete breech, and this is footling knee presentation. Now you see this is a position. The sacrum is the denominator, and the back is on the left anterior quadrant. And in another picture, the sacrum is in the right sacroiliac joint. That means sacro-anterior, left sacro-anterior, and right sacro-posterior. They are lying in the right oblique. And if there is a right sacro-anterior and left sacro-posterior, it will be in the left oblique. Complete breech and frank breech passes through the birth canal, and head are likely to pass easily. But if it is a knee and foot presentation, easily slip through the incompletely dilated cervix, and there will be entrapment of shoulder and head. This is also incidence of cord prolapse. Cord prolapse in frank breech is 1%, 10% in foot link presentation. Now, etiology of breech. It is common in multigravida. If any the मैं दिखा दूं वो है क्या कुछ है multigravida. So no, you see if the uterus is primigravida, it is narrow in the lower part and wider in the upper part. So it becomes a vertex here and breech upper. Because this lower part is narrow, the head comes down and breech comes up. But if it is a multigravida, the lower portion is also wide and the incidence of breech is more. Multiparity. In uterine abnormalities, Way is the one who has done a lot of work on the uterine abnormality, unicornate, bicoma, and subseptum. And Stevenson has done a lot of work on the placental attachment. Placenta, if it is cornwall fundal, the breech is more. Cornwall fundal. Or if there is a placenta previa. Liker, if it is hadrianus or olive. If it is hadrianus, the upper part and lower part are more, and the chances of breech are there. If the patient is 28, 29 weeks and it is oligohadrianus, the rotation does not occur. Contracted pelvis, it is a feto-pelvic disproportion and breech is there. In fetal prematurity, if the patient is premature and she goes into labor, she will deliver a breech. In twin pregnancy, the breech is common. And if the fetus has got gross hydrocephalus, moderate or gross hydrocephalus, it can be breech. And there is a short form. If there is a fibroid uterus, that can push the fetus away, and it can be fetus and short fibroid and ovarian tumor has got incidence of breech. Now, how to diagnose patient? Patient complain of pain in the epigastrium. I had one patient who used to always, before I could examine her, she used to tell me she's breech. And second time she would say today is vertex. So she used to have breech or vertex, and she used to always tell me even before I examine the patient, she used to tell me. But luckily when she goes in at full term, she went into labor and she had vertex presentation and she delivered normally. So if the patient complains of epigastric pain, she can have a breech. Then per abdomen examination in fundus, the fundal grip, the head is mobile at the fundus. But if the patient has got the extended legs, it may be difficult to feel the head at the fundus. Lateral grip, the back is on one side and the limbs are on the other side. In pelvic breech, the breech is felt at the limb. If the breech is extended, it may be engaged. Fetal heart sounds are usually at or above the umbilicus. But if it is a frank breech, the heartbeat will be heard at the same point at vertex, that is midpoint between umbilicus and the anterior superior spine. Anterior superior spine. Now, per abdomen examination, breaches at the heart level. Ultrasound is very important because it will confirm the breech presentation and she will tell us whether it is dorsal anterior, dorsal posterior, dorsal left and there. Weight of the baby, breech will be given there. The weight of the baby can be estimated because if the weight is less than 3, the vagina can be done. If it is more than 3.5, it has to be a cesarean. Placental localization is very important because placenta with placenta will be cornwall fundal or placenta previa. Amount of liquor, we can diagnose hydramnios and IUGR. Cord around the neck, And if the head is extended, the ultrasound will show, and you will have to do a cesarean section. Incidence of breech at 30 weeks is 25%. And patient must be told that full term the incidence is only 3 to 5%. And we will not do any manipulation till the patient is 37 weeks, when external pressure version can be tried. Now, external cephalic version is important, where the abnormal presentation is manually turned to a normal vertex presentation. Patient should be taken consent from the husband and wife, because there are some complications which may occur with external cephalic version, so it should be taken consent. And we should do it only at 36, 37 weeks with adequate wrapper. Even if she goes into labor, she can have a live baby. Availability of EFM, then ultrasound should be there. And the breech should be not engaged. Absent, and there should be no contraindication. That means blood pressure, diabetes, and pleasant apnea. You should be very careful in selecting the patient. It should be a gentle performance and close monitoring on the tocolytic and flaws. Success rate of external cephalic motion is 60%, and thus 40% reduction of CSF. What are the contraindications? If the patient has got placenta previa, or if a patient has got high blood pressure, you will not do external version. Even 140/90 is common. If she has got a spotting, don't do any external version. In twin pregnancy, the one may be vertex, the other may be breech. Oligohydramnios, if the patient has got lace lighter, you will not be able to do external version. And the cord around the neck will be there, you will not do external version. If the patient has got no heartbeat, you should deliver as breech. And if there is a gross congenital abnormality, that is hydrocephalus, you will not do external version. And if there are abnormality in the uterus, which was diagnosed in early before pregnancy, you will not do version. Complication is very important. You should be gentle. If you use too much force, there can be accidental hemorrhage, abruptio operation. And a patient may go into premature, immediately after external version, she may go into labor, rupture her membranes, and there can be a fetal-maternal hemorrhage and fetal distress and fetal death. If the patient blood group is Rh negative, anti-D should be given. Now, how to do an external version? You see this? In this picture, the back is on the left side. It's a bipolar version. You have to keep the breech bipolar, both head and the feet, they should be, movement should be kept in flexion position. You have to push the breech into the side of the back and the head to the opposite side. You see this? And then fetal outcomes are continuously heard, and it becomes a vertex. So you have to maintain flexion and it will become vertex. After version, she should be kept in hospital for at least half an hour. And we should recheck the CTG and should tell her to come after 1 week. If she has symptom of uterine contraction, leaking, bleeding, she should come to the hospital immediately. Now this scoring system is there, and if the score is less than 3, the chances of complication with vagina are high. It does not improve pelvic. Okay. External version. Now what happens if we do external version and we become successful in vaginal delivery, 40% reduction in cesarean section. There will be another patient who will say, external version, you have failed, and I will always do a cesarean section. There will be a third patient who will say, I don't want any external version, I want straight away cesarean section. Fourth patient will say, don't do external version, I want a vaginal delivery. I don't want an external version. And then if the patient version is failed, patient insists that in spite of the fail, I will not get the cesarean section done, and I'll insist on a vaginal delivery. and she has got lot of 4-5 children. So she says she doesn't want a cesarean. Now, what are the principles of vaginal delivery? Patient should lie down except in frank breech. Autogram should be started. Here you will hear the uterine contraction every half an hour, blood pressure every 2 hourly, and continuous fetal monitoring, continuous metabolic. Then if the delivery is allowed, maternal should be allowed till the umbilicus. Episiotomy is very important and it should be done when the local anesthesia put in the cord. If there is an extended leg, you can disengage it. And after rupture of membrane, the PV should be done. Loop of cord should be pulled down and you can feel the pulsation. Cord will be safe in the sacral hollow and there's no pull at the umbilicus. And fetopelvic grip and pull down till the anterior side. Fetopelvic. This is what it is. Fetopelvic. Fetopelvic, fetus and pelvis. Kept it like that. It should be kept like that. दिखाई दे रहा? Fetopelvic इधर दे रहा. Fetopelvic grip. Yeah. Fetopelvic and then pull out till the inferior angle of the scapula is seen. Here, pull it down till the inferior angle of the scapula is seen. And when you feel the inferior, pull it down till the inferior angle and then try to feel the arms in front of the chest. If they are in the front of the chest, you can pull it out. If they are extended, then we'll have to do love seat maneuver or classical method. So you pull it down till the anterior spectrum. Next. Now, pelvis should be adequate. PV should be done and the skilled person, obstetrician, assistant, anesthetist, and pediatrician should be available during the time of vaginal delivery. And we should be availability of OT should be there. If there is any plan, if there is any complication, we should do straight away cesarean section. Fetal weight should be less than 3,000. If we want to do a vaginal delivery, the fetus should be less than 300 grams. Frank breech and complete breech can deliver normally. And frank breech and spontaneous labor with favorable bishop score and good breech score. More than low will lead a cesarean section, but if it is more than. And there should be no obstetric or medical complication. Masterly inactivity is a patient is allowed by up to the umbilicus. Look for the presence of folded arm in front of the chest and visibility of the lower angle of the scapula. If they fail to deliver, they spontaneously they are hooked off. If the arms are extended, they are delivered by love shape and classical method. Next. कहाँ गई है? और ना कहाँ चली गई? आ जाओ रानी और इसके बाद now you see this the fetus when it is reaching the outlet with the liquid you should do lateral flexion. Yes. The anterior shoulder should come under the symphysis vein. Posterior is born, then the anterior is born. Posterior is born. ऐसे ना there should be ये इधर पकड़ लो ये इधर ये ऐसे ही करना इधर हाँ ठीक है next after the arms are delivered the baby is turned anteriorly it should be turned anteriorly should be turned anteriorly and after coming it should deliver by Burn Marshall technique or small lead or a 5% faucet. Not it should be properly managed. Now when to do a cesarean section? If the patient is elderly and she has got history of infertility, and she's got bad obstetric history. That means she has got abortion, premature labor, etc. Where she should be a cesarean. If there is complicated breech, that means patient has got high blood pressure or present previa. Contracted pelvis, there is always a fetal-pelvic disproportion. Fetal weight should be more than 3.5 kg. Putting and knee presentation, the patient should have a cesarean section. If the head is extended, the baby should be delivered vaginally. Cesarean section will be done. If the patient has pre-cesarean section, she should have a. Now, premature breech delivery, husband and wife should be explained that the baby will be shifted to neonatal nursery. And the problem of prematurity will be explained to the relatives. They will give a special permission for cesarean section. I think cesarean section should only be done if the fetus is more than 1.5 kg. For cesarean, abdominal incision should be large and method of delivery the same as vaginal birth. Now, what are the complications? Complication can be growing impacted breech in the pelvis, impacted breech in the mid cavity, and impacted breech at the brim, impacted breech at the outlet. If the arms are extended, they will do something manual classical method. And if there is difficulty in after coming in, they can be delivered by Murashut's medicine. If there is difficulty in coming hydrocephalic, it should be treated properly. Next. Now, if it is impacted breech at the outlet, impacted breech at the outlet, finger should be put there now. Finger should be put between the femur and the abdominal wall. And then pull should be during the uterine contraction, and the pull should be towards the abdomen, not towards the fetus. If you pull towards the fetus, there will be fracture of the femur. If it is one leg or two legs, both should be growing traction during the contraction. During the contraction. And it should be done only when the patient is having uterine contraction. If the breech is in the mid cavity, the patient should have a cesarean section. Some obstetricians do a pinarch maneuver. Now I want to tell you about the pinarch maneuver. You pass your hand along the femur till you reach the popliteal fossa. Popliteal fossa, abducted so that the leg is adducted. Leg is adducted, and you bring down the leg in adduction from the uterine cavity in between the contractions. I repeat it again. Pinarch maneuver, you go along the femur till you reach the popliteal fossa, press it so that and abduct it so that the leg is flexed. If the leg is flexed, you catch hold of the feet and adduct it and bring it out in between the contractions. This method is not done. I would always do a cesarean section if the breech is in the mid. The pregnant, I'll do a cesarean section. So impacted breech at the brim and then अभी नहीं कर
आवाज कम आ रही है, आवाज थोड़ी सी कम, आवाज कम आ रही है थोड़ी.
If the breech is next, now if the arms are extended, now you see this. In the arms are extended, the posterior arm is brought anteriorly. Posterior brought is arm anteriorly. Either. You do the femoropelvic rib. You see this, the posterior shoulder is below the brim, but still you can lift it over towards the abdomen. The posterior shoulder still comes lower, and then you rotate through 1/8 of the rib so that the shoulder comes in the deficient pelvis here. It's the purpose to bend the arm without introducing the hand means of lateral flexion. When the shoulder in the period due to posterior shoulder lies below the level and is brought anteriorly, it lies deficient part of the pelvis. Posterior shoulder should be below the promontory and rotate the shoulder below the pelvis. Hook the finger and take it out. Okay. The advantage is there is no anesthesia and there is no intrauterine manipulation. There is no intrauterine manipulation. Next. Classical method is done under general anesthesia. Here the posterior shoulder is delivered posteriorly. It is done under general anesthesia, posterior shoulder. Now you pass the arm along the posterior wall, reach the elbow, go beyond the elbow, and bring the forearm downwards so that it comes in front of the face. So posterior shoulder should be delivered posteriorly, and it passes along the humerus till the elbow, and forearm is brought in front of the face. So posterior shoulder is delivered posteriorly, and then the anterior shoulder can be delivered. Baby should be turned so that the back is, after the shoulders are born, baby should be turned. Baby should be turned anteriorly. After coming in, should deliver by Burn Marshall technique, Smelly weak and Piper's forceps. Next. Now Burn Marshall technique. Burn Marshall technique, the fetus hangs down by its own weight. Okay. Own weight, encouraging flexion of the head. When the nape of the neck is seen, baby is grabbed by both the fingers. Acted with the fingers in between the two, maintaining the static traction, forming a wide arch. Okay. The trunk is swing upwards and forwards, direction over the mat and the people. It is finally delivered by movement of flexion by suprapubic pressure. Okay, ho gaya. Hang down. So you see this, hang down till the nape of the neck, and then you lift it up, and then the after coming head can be done by pressure over the sympathetic pubis, and head is burned by movement of flexion. Next. Now, how to do a Murashosyan means you put the baby straddle wise on the left forearm. Put the index and middle finger over the maxilla. Either. And here, index finger and ring finger on either side of the thing, and the middle finger over the thing, and you press it so the head is flexed. Then you bring it down. Forearm. Bringing on either side, middle and index finger, they are pressed on either side, male bone. Maintain the flexion. The ring and index finger are on the shoulder on either side, and the summer. Traction is given downwards and backwards till the nape of the neck. Neck is visible under the pubic because the system gives suprapubic pressure to maintain flexion. And fetus is carried upwards towards the mother's abdomen, releasing the face and lastly the trunk. And reach the occipital vertex. Now, how to apply the forces? You give the limbs and this to the, cover it up with the, okay, cover it up with the towel so that they are away from A and A, so that they are away from the head. Assistant hold the trunk and joint so that it may be out of the way as much as possible. The forceps blades are applied at 4 and 8 o'clock position, and they made to lie on side of the head. So as to promote flexion, directly flexion. Fetus is carried upwards. The traction is made till the chin appears. chin appears. And then the forceps are carried towards till the chin appears. Then the forceps and features are carried forward towards the abdomen. Controlled delivery. Its advantage is that there is a controlled delivery of the head. Flexion is maintained and pull is directly over the fetal head. Perinatal mortality in breech is 4-fold higher than the term vertex. Now, to reduce the perinatal mortality, you reduce the incision of breech avulsion by extracephalic version, reducing the traumatic delivery by proper methods, and do a planned cesarean section. You will reduce the perinatal mortality.
So thanks a lot. That was our Dr. Kotwani. Imagine she's 90 years plus and look at the zeal, the way she teaches to all her students. And as Dr. Pratima Mittal said, she is teachers of all teachers, and I will definitely convey your message to ma'am. She would love that. So since we are early also, I would require, I have called Dr. Ruma.
Thank you.
Ma'am, I surely, I loved your messages. In fact,
I'm getting so nostalgic. I'm getting so nostalgic, you know, it's really nice. Thank you.
I'll surely do so, ma'am. So Dr. Rumal Sathwik, she's a consultant at the Center of IVF and Human Reproduction Associate Professor at Reproductive Medicine, working at Sir Gangaram Hospital. Her field of interest being research, male and female infertility, fertility enhancing laparoscopy and hysteroscopy. Ma'am is going to be talking about HSGs. So welcome, ma'am.
Thank you, Sakshi. Should I start sharing my screen?
Sure, ma'am.
Thank you. Yeah. Can you see the screen?
Yes, ma'am.
Just give me a second. Yeah, so hysterosalpingography is a commonly performed procedure which you as students or as consultants have to perform even as general practitioners or if you are specialized in the field of infertility. Now, this is simply put in today's world, the way we practice it, it is an examination, a fluoroscopically done examination of the uterus and fallopian tubes, most commonly used to investigate infertility or recurrent spontaneous abortions. And fluoroscopy here denotes, it's different from still X-rays that would be taken in the past. Here denotes continuous X-ray image on a monitor that you are able to see and adjust the patient accordingly to what you can see. Her position can be adjusted. The force with which you push the dye can be adjusted. The dye cannula can be adjusted because of a continuous image that can be seen on the monitor. Now, this is what a fluoroscopic apparatus would look like. The inbox here will show you that this here is where the X-ray rays are being projected from. This is where the patient lies, the table, and this is where those X-rays, after penetrating through the tissues, will be received. This is the receptor plane. And these arms can be moved aage piche, so or left or right, in order to adjust where those images are falling onto the receptacle. So indications very quickly, immediately, yes, it's infertility to assess uterine morphology, tubal patency or pathology, but it is also done pre-surgically and post-surgically to test residual tubal length when you undertake tubal recanalization. So this is a useful test prior to tubal recanalization in order to know whether your recanalization procedure is going to be successful or not. The best ones are the ones where the tube is blocked at the level of the isthmus and not very much close to the uterus. Similarly, now it is also, but largely given up as an investigation in recurrent spontaneous abortions. It used to be one commonly done investigation in such patients to assess or to rule out congenital uterine defects and even synechia in such patients, which would result as a result of repeated DNC procedures. Contraindications: pregnancy, active vaginal bleeding, active pelvic infection, allergy to radiopaque dye. These are things that you should be able to quickly come out with when people ask you, what are the indications, what are the contraindications? Relative ones that have also been added recently are recent uterine surgery and adnexal masses or hydrosalpinx, and you can understand the reason why. Adnexal masses or hydrosalpinx likely to flare up with the procedure and lead to maybe a PID later. Recent uterine surgery, the scar may give way based on how the test was done. Prerequisites: important to have the lady in her proliferative phase, best done between days 5 to 9 of cycle, largely because the endometrium is thin, it improves visualization of the cavity, and the possibility of pregnancy is negligible. Indications and contraindication compliant, so you have to check that this is a patient who has the indications for HSG, but also does not have the contraindications that were mentioned in the previous slide. Antibiotic cover may or may not be given. We will be discussing it towards the end. And antispasmodic prior is given largely to prevent an inadvertent spasm of the tube, but its role as a pain relieving medicine is a little controversial. We will be discussing this also later. So trolley, what are the things that an HSG trolley should have? It should have the following instruments: SIM speculum, tenaculum, HSG cannula, which could be non-balloon, and within the non-balloon catheters, you can have metallic or non-metallic. There are the balloon cannulas or catheters. Then you should have a syringe 20 ml in dimension or in volume, sponge holding forceps, cotton swabs, gauze pieces, povidone iodine solution, and all of this to prep and drape the patient with. So that kind of stuff on your trolley. Drugs are needed. Of course, you'll need the contrast. You would need some form of antispasmodic agent. So let's say she has not had it prior and she has come to the room without an antispasmodic. You might want to give her some kind of pain relief, either with an injection Buscopan or using lignocaine 2%. Then they have to always be prepared. We don't see as many adverse reactions as of late. You know, as you sort of do this more and more, the incidence of adverse reactions go down, but always be prepared for an inadvertent allergic reaction, shock, or whatever. So all of that emergency tray should be ready. So now these are the cannula types. You have two primary designs. One is wherein the cannula is able to go through the cervix into the uterus, and then it pushes the dye. And this is the Rubens cannula. And the other is the Leach-Wilkinson, wherein it'll stop short just at the internal os, or maybe within the cervical canal. It does not go all the way into the uterine cavity. You can see that both of these are designed in a way to prevent the dye from leaking out. So that acorn tip that you can see in the first picture is largely sort of, it fits at the external os beautifully. It prevents leakage of dye. Leakage of dye has to be prevented in order to build the right pressure inside the cavity so that dye can go all the way through those tiny ostia into the tubes and then spill. So that kind of intrauterine pressure has to build up for dye to go through all the way. There are similar designs available in non-metallic or plastic cannulas. These plastic cannulas are made of a non-reactive sort of polypropylene material. And you can have, the names are not essential. What you will be asked to identify is whether they are metallic, non-metallic, and what designs are they. Then you have the balloon-tipped catheters, which you can kind of, so here the advantage is that the balloon or the device which is used to prevent the back spill or retrograde spill is actually placed at the level of the internal os, above that level. And so that is where you pull it down, so that this provides a more effective seal than designs which are meant to block the external os. So that effective seal is more likely to give you a positive result and a lesser incidence of a false positive block. Okay, so the other advantage of these tipped cannulas are the fact that they are made out of plastic, are likely to be less painful to the patient. Okay, so these are some of the designs. In some cases, we have also used 5 to 6 French Foley's catheter. So metal cannula versus balloon cannula, there's already been a systematic review which tends to say that pain is less with balloon cannula versus the metallic cannula during and after the procedure. What about the contrast media? That is also there on your Viva table, and you would be asked to identify what it is, its advantages or disadvantage over the other kind. So we know that there are 2 kinds of contrast media. One is oil-based media and the other is water-based media. And the oil-based media, I think, largely comes by this one name, Lipiodol. And the difference between oil-based and water-based is that both of them contain iodine. Iodine is reflective on X-ray films. So it's iodine-based. Both of these media, oil and water-based, are iodine-based. But oil-based contains, this is linked to fatty acids, and fatty acids of poppy seed oil, right? So oil-based media, for the longest time, there was this myth floating around that they produce better films, that, you know, the visualization is better, perhaps the pathology, the tubal pathology, because it's able to go and line those little niches within the fallopian tube better. It creates better films, and it is able to diagnose better the pathology, tubal pathology. But and along with that, also that there is a better post-procedural fertility. However, Lipiodol, which was one of the first contrast agents to be used maybe in the 60s and 70s, were largely given up for a higher incidence of allergic reaction, embolism, and oil granulomas that were observed with this media. And this was replaced with by water-based media, which instead of the fatty acids of poppy seed oil were where iodine was attached to benzoic acid derivatives. Now, benzoic acid, you know, is a 6-carbon atom ring. And in this, if you were to substitute the H atoms with iodine at positions 2, 4, and 6, you'd have one of these media, one of these dyes. And there are side chain substitutions at position 3 and 5. So this is the benzoic acid derivative forms the negative component or the anion of a compound, which will have in its positive location sodium or meglumine. Right. And so within water-based media, there are also categories. There are categories based on their osmolarity. One is hyperosmolar. Hyperosmolar, and you can see it's approximately 1500 milliosmoles per liter. And if you will recall, the human blood has an osmolarity of 270 milliosmoles. So if this was to be absorbed, let's say, into the circulation, a 1500 milliosmolar will cause more and more water, because you need to have a state of homeostasis. It will cause more water to be absorbed. So hyperosmolar dyes can cause a lot of pain, whereas low osmolar dyes, although they are still a little more osmolar than blood or than normal tissue fluid, are likely to cause less pain. And what are the examples of hyperosmolar water-based media? You have diatrizoate or urographene, which again was a dye that we have used very commonly, maybe up till 2010. And this has largely been replaced by low osmolar water-based media, which should be the current standard. Iopramide is what is used in our institute currently. Ultravist, which is friendlier to the patient in the sense that it causes less pain. The visibility with low osmolar dyes is similar to that of oil-based media. And why do I say this? Is I'll just come to that slide of evidence. But here, this is what it might look like on your table. Lipiodol on the left, that's that pink thing, and you know the properties of that, and urographene, which is a hyperosmolar water-based media, and you can also see Lopamiro 370, and automatically 370 means osmolarity, which has come down from 1500 to a much lower concentration. Okay. Now, there have been, in fact, this was a very good trial. I said there was this myth floating around oil-based dye that it might lead to better fertility. And we didn't really have anything concrete to refer to say that this is actually improving fertility. But then you can see this trial, oil-based or water-based contrast for hysterosalpingography in infertile women, published in the New England Journal of Medicine 2017. And if you do your reading well, then any JM is perhaps up there, even within the list of medical journals. Medicine and OBGYN, of course, comes much later. So this one got published in NEJM. And it is looking at a large group, right? A group of infertile women who undergo HSG, like 554 women undergo HSG using oil-based media, and 554 women, infertile women, who undergo HSG with water-based media, and they have similar characteristics in terms of age. So all the confounders you can think of, duration of infertility, all of that is similar. And this trial kind of finds that the ongoing and clinical pregnancy rates, if you look at this is the rate, 39.7%. In oil-based group and 29.1% in the water-based group. This is, they are observing them over a 6-month period. And clearly, if you know your rate ratio, 1.37, that this is the number of times higher that a woman who has undergone HSG with oil-based media is likely to conceive. So it's 1.37 times higher, okay, and significant here. So what we are trying to say here, and while this ongoing pregnancy, clinical pregnancy is high, there are no adverse effects which are observed, and which I have noted in the points mentioned to the right, is that there were no contrast-based allergic reactions in either group, which meant that, that we would associate it with embolism and allergic reactions. So perhaps, and the dye they use here are lipiodol, and they are using standard, iopramide for water-based groups. So equal efficacy in picking up tubal or uterine disease. So water or oil don't have an advantage with respect to how they delineate tubal pathology. Pregnancy rates are significantly higher with oil-based dye, and no significant differences were seen in terms of other problems that could arise, like ectopic miscarriage or adverse maternal events, right? So this was one big trial, 2017. By 2018, once again, there had been 6 trials published, enough to be put into a systematic review to say that oil-based dye is actually leading to a higher chance of pregnancy, that it is actually improving fertility by, it could be various theories around it, and we will have to prove it as to how that does it. But the visible effect is clear, that it is leading to a higher pregnancy chance. Okay, so have we switched to the oil-based dye? I think it will take some years for us to incorporate that into practice, not yet. Preparation, patient is asked to void, procedure explained, consent taken, trolleys checked for all the instruments that you have, because you don't want to be, scrambling around for things when you have pushed the cannula and then you find suddenly that the syringe is not there or whatever. Patient is laid in lithotomy. So after you've done all this, you lay the patient in lithotomy and you drape her first before prepping her. Normally it's prep and drape, and here I'm suggesting drape and prep because you're doing it in a conscious state. Draping always helps relieve her anxiety, and anxiety has got a lot to do with pain perception, and pain perception has a lot to do with your what are they called? The corneal lens kind of undergoing spasm. So this is a small step, but it goes a long way in producing the right result. Appropriate size cannula is chosen. Again, I have star marked it, and this is essential because you are not using as a routine those balloon cannulas. I mean, most centers may not be, but some may have switched. But for those who are not using it, you are, remember, with your cannula, you are not just trying to push in the dye, you're also trying to create an effective seal at the external os. And that is only possible if you know what size cervix this is. So knowing the parity of the lady, whether she's had a normal vaginal delivery, the number of surgeries she's had. And of course, a visual inspection helps to decide whether you need a broad-based cannula, which might have looked like an isosceles triangle like this, or again, an isosceles triangle, but a narrow cannula like this might be useful for services which are very small, thin and narrow. And this is usually helpful where the external loss is actually panning outwards, right? So once you have chosen the cannula, you don't screw it in yet. You fill the syringe with dye. Air bubbles are pushed through this cannula and screw, so cannula, syringe with the dye, and the dye has been pushed in so that it reaches the tip of the cannula. And once that has happened, now you screw it in. Now you expose the cervix, right? All of this is happening before. Now you expose the cervix. Exposing the cervix later is also ensuring that her anxiety, her pain associated with that stretch, distension comes down. So once you have exposed the cervix, you can give local anesthesia with xylocaine if that is the practice in your center, or you could, just by gentle talking with the lady, you can calm her down and then slowly screw in the cannula, which has already been filled with the dye. Cervix is held with valsalum after injecting with local screw-in dye-filled cannula into the cervix. Create an effective seal. How do you know it's an effective seal? A backward tuck should not dislodge it from the position that you have put it into. Okay. Now procedure is straighten and so once that has been screwed in, now the patient goes back onto the table. She is straightened because so far she was in lithotomy. She's repositioned under the machine, and you are asked to push 1 to 2 ml of dye to delineate the cavity. Never push all the 20 ml together. So it's 1 to 2 ml initially. This delineates the cavity. The next 1 to 2 ml delineates the tube. And the next 5 to 10 ml will allow you to see the spill if the tubes are patent. Okay, so go slow and things work beautifully. Remove instruments, 1 delayed film after 2 5 minutes. After 2 to 5 minutes, it's not mandatory. Now, this used to be the requirement when we were not doing what are known as fluoroscopic HSGs. When still X-rays were being taken, that is when they would, you might have wanted to do a delay film as well. We don't do that anymore. So now this is what it will look like. The first 1 to 2 ml delineating the cavity. Of course, the uterus has been pushed backwards. So the plane is like more, we see the longitudinal plane in the transverse axis. Here it's much clearer. This is the uterus and the tubes delineated. Here tubes delineated all the way till the end, which is the fimbrial end. It's quite a good film, if you ask me. And here, finally, you have spill seen on both sides, and there is no uterine pathology. The outlines of the endometrial cavity are very smooth and clear. Post-procedural instructions, always check on the patient. Are you okay? Is there any pain? Do you think the pain was more than that you expected? And she'll let you know how well you were able to do it. Talk to her, inform her of the result, antibiotic course. Again, I've put a star. Well, in our center, we do give antibiotics, and it's just prophylactic. Pain relief is added SOS, and emergency numbers you have to give her one way or the other, and tell her where to contact in case she has issues. Complications, sorry about the font size, but procedural pain is the only thing that women wish to avoid, right? And that is one reason why some centers may not even offer HSG as the first line of investigation for tubal patency, and that's wrong according to me. One has to try and take measures to reduce that procedural pain, and these are 3 points that I've written. Talk to patient at every step of the way. Gently try to ease her fears. Use of balloon catheters over metallic. Use of the right size catheter over, is essential. Use of intracervical xylocaine infiltration helps reduce pain. Okay, and we will be looking at pain relief measures soon. Vasovagal reaction rarely occurs. I mean, I haven't seen any, but when it does, please be prepared with your atropine and emergency tray. Dye allergy, rare. Emergency, once again, not seen any, but you have to be prepared with your emergency tray. Vaginal bleeding, yes, because of all the holding that one is doing. But again, it's not so much to cause issues. This is something that you need to inform the patient that she might have a spot of blood later, but that should be fine. Secondary infection, that is a problem. And we may have had a few cases that have required admission after HSG. The incidence is not more than 0.1%, and is likely to happen with silent PIDs. Now, usually we don't undertake HSGs with known adnexal masses, where you think that this is endometriosis and you want to kind of operate, so where laparoscopy is primarily indicated. So there you don't want to do that, but there are silent PIDs with which there is no way of knowing, and it can sometimes, again, rarely flare up. Inadvertent radiation to unknown pregnancy, well, that's because we haven't done our homework well. And this brings us to HSG effectiveness in diagnosing tubal block. Again, a commonly asked question. So when you're assessing something's effectiveness, you're assessing it against a standard, right? The gold standard remains basically, how do you know that what HSG is saying is correct or not? Basically, you have to have checked it by laparoscopy to know if things are what HSG is saying or not, okay? So now there are studies which so you don't actually undertake laparoscopy. It's an invasive test. Nobody will want to do that to say that HSG is right or wrong. But there are situations where women would have undergone HSG for, as a first investigation, but 6 months later, because, everything that you did, IUI, medicines, blah, blah, things haven't worked, and then you have undertaken laparoscopy. So it's not in the setting of a trial, but in the setting of what is done practically, where HSG and laparoscopy have been undertaken over a short span of time, and wherein you have had the opportunity to assess where what laparoscopy is saying is corresponding with what HSG is saying. So we do know that HSG as a test for tubal obstruction has a sensitivity of 0.65, specificity of 0.83. Now, what that means is that when HSG suggests tubal obstruction, that this is blocked, it will be confirmed by laparoscopy in 38% of case. Now, why I want you to know this, 38, that's 1/3 of blocks on HSG is actually open tubes, okay? That it is not a reliable indicator of tubal occlusion, especially the ones that are at the corneal level, okay? Please remember this, because if you don't remember this, you'll end up offering her the wrong advice. So, when HSG suggests tubal patency, that it's saying tubes are okay, it's almost always correct, right? HSG is a reliable indicator of tubal patency, but not such a reliable indicator of tubal occlusion, especially the occlusion that shows up at the corneal ends could mostly be wrong, and it's wrong in 2 out of 3 cases when assessed on laparoscopy, right? So why I bring this up is, let's say there was this lady, a PCOS woman, who gets her periods only on withdrawal with Meprate, right? And it's been a year, there is pressure from everywhere, conceive, and the first thing she comes to you, and the first thing you order, let's say, or somebody has ordered this, we shouldn't be ordering HSG as the first test. First thing that we would want to do, that this is indeed PCOS, you want to confirm that this is not any other pathology, and ovulation. 90% of women with secondary amenorrhea are likely to have PCOS, okay? So anyways, but you have confirmed this based on an ultrasound, based on maybe one test, which is FSH and E2, and things look like she's PCOS. The first thing you want to do is induce ovulation in her. But let's say there was an HSG that had already been done, and it was showing bilateral corneal block. What will you do? Knowing this information, you have to give her the benefit of doubt. You'll have to say, I know that 2 out of 3 cases of corneal block, especially with a history such as yours, you've never ovulated, I'm still going to give you I'm going to give you letrozole, I'm going to give you cyphine, whatever it helps you ovulate. And voila, 2 months later, she will be pregnant despite the HSG showing that block, okay? That's about it. HSG versus laparoscopy, 2 most widely used methods to test tubal pathology, both invasive procedures, but HSG is less so. Detection rate of tubal pathologies is better with laparoscopy. However, the detection and treatment of pathology missed by HSG does not increase live birth rates. So laparoscopy as a first investigation for assessing tubal pathology should not be undertaken unless these conditions are met: history of PID, known adnexal masses on ultrasound in women with tubal disease on HSG, long duration infertility with normal semen analysis and regular ovulation, and failure of 3 to 4 IUIs with good ovarian reserve and normal semen. I'm just going to skip these slides. We are going to pain relief during HSG. What is effective, right? And this is again an issue that we all deal with every day. So what all has been used? Opioids have been used, like tramadol, morphine, and versus placebo, it is not effective. And thankfully, we have a Cochrane review on this. It's looking at pretty much all interventions that have been undertaken for pain relief. So this was oral opioids. What about intravenous opioids during the procedure compared to no treatment? Well, it may improve pain relief during the procedure, and the mean difference in scores is minus 3.53. So if the score given for pain was 10 without medicines, with the intravenous opioid, the score given would be 6.5. But also remember that there's one participant out of 32, and that's a significant line. I'm just going to do this, will have apnea because of intravenous opioid. So it's not a very safe alternative, okay? Next is non-opioid oral analgesics, like let's say NSAIDs, like your Voveron and Combiflam. Would that help? It has no effect. What about topical anesthesia versus placebo or no treatment? Topical anesthesia is you've put some lignocaine spray right there and on the cervix. And so they're saying it may reduce pain during the procedure, but not after. So for later, you'll have to add something. So you can use local anesthesia spray for when you hold the cervix, just before holding the cervix. And later post-procedure, you could give her a Combiflam or something. Locally injected anesthesia, that is intra-cervical xylocaine, would that work? It reduces pain during and also after. So here there are no side effects per se. And locally injected anesthesia would perhaps be one of the better methods which will reduce pain during and also after the procedure. Topical anesthetics versus paracervical block. Topical anesthetics are more helpful than paracervical blocks. Okay, now so here it brings us to the different radiographs that we have. You will be given different radiographs from the centers that you go to exams for, and I'm just bringing out some of them here. And this is showing radiographs, 4 films of the first film displaying the uterus well outlined. The second one, in addition to uterus, is showing the tubes as well bilaterally, and the dye seems to have gone all the way till the end in the second film. In the third, we see spillage evidenced by sort of dye smudging in the pelvis on the left, but also on the right. The right seems to have, if you see, a restricted spill, not a free spill, but the left seems to have a free spill. So what, based on, let's say, her history, if she has had 3 years of unexplained infertility, what would be, and she's still young, let's say 30 years, and she has good ovarian reserve, what would my plan for her be? I would say perhaps 3 cycles of monitored ovulation and added intrauterine insemination. And if that doesn't work, we can discuss laparoscopy or we can discuss IVF. So we'll have to explain cost and success rates of both and let her choose later. What does this look like? This is an irregular space occupying defect inside the uterus, most likely to be a synechia. I mean, based on the shape that it looks like, it's a central oval defect. Now here you can see it's a radiograph of the uterus tubes with dye having gone into the tubes both sides. I'm not sure if I would call it a block because I'll have to see the next film to say that this is a block or not, but it seems to have gone all the way to the distal end. But what is significant here is a deep depression of the fundus. Now, this is a uniform depression of the fundus. What would that indicate? It could indicate a big fibroid sitting there, a circular fibroid, but usually it will not be uniform. It could indicate arcuate uterus, or it could indicate a partial septum. How will I know what it is? Of course, I'll have to do an ultrasound or a 3D ultrasound to know what this is. Okay, so in this case, the answer given was septate or arcuate uterus, which wouldn't be incorrect. Fibroid, like I said, it could have been a fibroid. It could have been a type 3 intramural fibroid. But usually you'd see that it's very kind of rare for fibroid to be sitting there so symmetrically, right? So it is most likely this, but it's very easily confirmed by an ultrasound. And what do we see here? Once again, the cavity seems to be divided into two halves, all the way till the level of, actually above the level of internal os. And the two horns that we see are acutely angled with respect to each other. And the dye seems to have gone on into both the tubes and has also spilled, so that's very good. And so here, what would I put this as? Of course, septum is my first diagnosis because of the acute angle between the two horns. But could it be the other one? Could it be, what do we call it, biconjugate, unicollis? Less likely, but again, I would maybe confirm it by a 3D ultrasound. The question you would be asked maybe, so let's say spot diagnosis. So I said septate uterus. The next question is, what are the problems associated with septate uterus? Reproductive outcomes, kitna farak hota hai usme? So you could say that septate, and I want you to remember this, will not cause infertility. Okay, so pregnancy, in this case, she should have had pregnancies at least, but sometimes the miscarriage rates are higher in septate uterus versus in normal uteri. Okay, so that is something you need to know and should be able to answer. What is this? Now here you can see, now this is a classic sort of a contrast to what we saw in the previous film. There are two horns, there is one cervix, and they are placed so widely angled from each other that it appears less likely to be septate, and this is most likely a biconjugate uterus. And in this film, why has this been brought here is because to say that sometimes the division is complete all the way to the cervix, right? There are two uteruses, which is diadelphys, and along with two cervices. And so if you did not care to look carefully at the cervix, sometimes you'll miss out on this one completely, and that there might just be one of these. So it is important to be able to delineate two horns separately, and which is why you'd put your cannula in two separate areas. Here with the single cervix, it is possible to put just one cannula, which will still be able to delineate both sides of the uterus. Okay, and so this is biconjugate uterus with various degrees of duplication. So it's not just one lady, it's 4 separate ladies with 4 separate kinds of films. What does this look like? Now here is a conjugal block. Okay, it's very clear. Now, the next thing they'll ask you is maybe someone, and we don't expect you to answer this, but it could be whether you think this is a false or a true block, okay? What are false blocks due to? What are true blocks due to? Those are the answers you should be ready with. Is it possible to differentiate false from true? And there's just one examiner who's come and who's told us that, and I can't confirm this, but I would still like to tell you that if there's persisting with that question, frankly, the answer is no. If you ask me, can you distinguish between a false and a true? I'd say not by looking at the films, right? But if they are still persisting with the question, they expect an answer that it was a beak-shaped sort of outline, right? A sharp beak-shaped outline. So you can see it on this side here, is that it is likely to be a true block, right? A spasm is like a sudden curtailment. On this side, it might be a false block, which is because of a spasm. And this side, it could be a true block. And frankly, I have no studies to be able to support that view. What is happening here? Is this a bilateral spill or is this something else? Well, I'll answer that. So here, it might appear that, you know, the dye is going in through here and probably spilling here, but this is very beautifully, in fact, delineating the vascular architecture of the uterus and the pelvis, right? So this is extravasation. Extravasation will happen with a badly performed HSG, but it will also happen if there has been so let's say in where the vessels are accepting things or more easily. So let's say the space between those cells, endothelial cells, is slightly more wide or open, so more likely in infections, endometritis. Okay, so even with regular pressures, it kind of intravassates. So the first X-ray showed bilateral corneal block. On forceful pushing, the dye intravassated. This X-ray demonstrates the complete uterine venous drainage of the dye. Okay. So we are not going to go into this. What is happening here? This is uniconnuate with spill on one side. And if you have done your examination clearly and you know that there is no passage on the other side, then you can give it as uniconnuate uterus with ipsilateral spill. Now here, what is happening? Again, it is essential to ascertain the presence of a single cervix in this case to differentiate it from a biconnuate bicollis with cannulation of a single cervix. We've already spoken of that, right? Now this is a clear-cut case of hydrosalpinx, bilateral, with distal block, no spill, and the question that you will be abnormal uterine cavity, and the question you will be asked is, what does one do with hydrosalpinx, different reasons for hydrosalpinx pathology and all that? Please be ready with that answer. Here, this is a mid-segmental block, okay? So HSG, if you ask me, is best for diagnosing mid-segmental block, that its specificity and sensitivity for mid-segmental block is almost similar to laparoscopy. Not so much with corneal blocks, but yes, with mid-segment blocks. So bilateral isthmic block, the dye line ends abruptly. This was a radiograph taken post-laparoscopic tubal recanalization showing failure, okay? What does this look like? Okay, there's one arm going up, one arm going to the side, and one. So this is probably, the uterus is not in this plane, in the, so one is sagittal, the other is coronal, okay? So it's probably tilted a little to this side so that one side looks smaller. You will have to kind of, while doing the procedure, make sure that the uterus is properly aligned. But the other thing that could be possible, because there is also a kind of a rotation to this side, it's possible that there is a mass lesion sitting here, which is causing the uterus to look like this. And what was the answer was, yes, it was a mass effect on the uterus by a huge fundal fibroid. And this has to be differentiated from a biconnuate uterus. Clinical correlation and an ultrasound will help to differentiate between the two conditions, right? So one last thing, and I hope this is the last slide, I'm sorry to have taken so much time, hysterosalpingography and radiation exposure. How much is one is exposed to like one film of X-ray under fluoroscopic control with procedure lasting approximately 2 minutes and 6 radiographic stills. It is 3 to 5 millisieverts, which is equal to background radiation exposure of 1.6 years. Okay. And I'm happy to take questions, but before that, I'll stop share. And only if Dr. Sakshi allows, because I know I've taken a lot of time.
Thanks to Dr. Kotwani's lecture. We have time. We still have 10 minutes if we go according to the previous schedule.
Okay.
Yeah, but I can't see any question in the chat box. But yes, people loved answering your HSG films. One was saying tuberculosis with the hydrosalpinx, one was saying extravasation. In fact, I was feeling when we show the HSG, we should have a quiz.
Ah, right. But that's like a lot of people today, no? Everyone won't be able to unmute.
But it was really nice. I can't see any questions, so I think we can move forward. But it was really good. Very nice. You covered all the basics.
Thank you, Sakshi. Bye.
Bye-bye. There's one question I can see now. Oh, please compare Foley's with Leash-Wilkinson.
So that we did try to tell you that in terms of, see, Leach Wilkinson is our first go-to cannula. And it comes in different sizes, and we still kind of prefer to use Leach Wilkinson's. It's when, let's say, you're not able to create an effective seal at the cervix, you would want to move to a balloon cannula, which is specifically designed for HSG. If it is not available at your center, then you use the Foley's. Foley's maybe size 6, 8, up to 10 can be used. 10 would be too big, but I think 8 would be decent. It's not very easy to cannulate with a Foley's. You need to have an artery, you need to know the passage, and with that kind of you push it in gradually and then you inflate. You may not be able to find the right place to inflate it. But once there, it is likely to create a more effective seal than a Leach Wilkinson's. So it is, you know, by the time you've reached to Foley's, you've already created or caused her enough pain. So I'm not sure how it's doing on the pain front, but generally, if this was your first attempt at cannulating the cervix with the Foley's, you might cause her less pain. But I think apart from that, the other disadvantage with Foley's is that you'll not be able to delineate the lower uterine cavity pathologies or the cervical pathologies, which you are still able to do with Leach Wilkinson's, right? Okay.
Thank you, ma'am.
Yeah.
So for the next lecture on contraception, I would like to invite my very first teachers when I started my journey with obstetrics and gynecology, Dr. A.G. Radhika. Ma'am is a senior consultant in obstetrics and gynecology at University College of Medical Sciences at GTV Hospital. Her special interest being evidence-based healthcare guideline development. She also currently is National Coordinator of Clinical Research at FOXY and National Corresponding Editor at Journal of Obs and Gynae of India. She's received number of awards, number of publications to her credit. Welcome, ma'am. It's a pleasure to invite you.
Thank you so much, Sakshi. It's so nice to see you.
As well as I'll invite Dr. Mrinalini Mani, sorry ma'am. She's the head of the Department of Obs and Gynae at Gurukul Hospital, Government Hospital at Delhi. She's also the founder, president of Delhi Gynecologist Forum, and she has a FOXY committee member and the breast and the family welfare. Her special interest being safe motherhood, contraception, quality in healthcare. Welcome, ma'am.
Thank you so much.
So thanks, Sakshi. We start off from here. So good afternoon and warm welcome to everybody. It's been, I'm sure, a very informative, extremely academic session since morning. We are going to change the format of this session now. We are going to make it interactive. So Sakshi, we had wanted 6 students to be there with us on the panel.
Okay.
Have they been, you know, I think Mala had identified 6 names and they were to be in with us live.
All right. I wasn't aware of it.
Okay. So, you know, since we have a WhatsApp group, I think I can tell you the names.
Yeah, sure. That would be great. Then I'll call.
So the today what we'll have is we have, like I said, interactive sessions, and other than that, there will be a few important bits of information that we would be sharing, both Dr. Mani and me. So it is okay. So one is Pooja Singh, and other people's names are not here. Oh, that's very unfortunate.
Just have their phone numbers actually.
I think Pooja Singh would be able to put us on with rest of the people. Sakshi, why don't you try to get
Dr. Radhika, Dr. Sakshi, can I interrupt?
Yeah, sure.
Yeah, Dr. Sakshi, you can call the whatever the people are on, board, they are available. They are attending, they can listen, they can opt themselves.
That was I was thinking to call
they can come forward and they can, they can suggest, okay, we are interested to participate.
I can already see Pooja Singh there, no?
Pooja Singh is there. Dr. Nisha Yadav is there. Dr.
Great. Dr. Shweta, you can invite Dr. Shweta, and anybody can participate. The people who are interested, they can come forward and participate.
I can.
And let's have the videos on, please. So
Yeah,
that
we
we're able
need
to see
5
you.
or 6 of them, so that should be okay. 3 are already there.
That's great. Okay.
The point
Okay.
is, contraception is something which is taught every time.
Dr. Madhubanti Mukherjee wants to also attend.
Yeah, everybody is welcome.
Yeah, so Dr. Madhubanti Mukherjee, then we have Dr. Tasneem, Dr. Vasundhara, Dr. Pooja, Dr. Shweta, and Dr. Nisha.
Oh, that's
Dr.
great.
Shweta,
Great.
can you name yourself? You are just saying
Sakshi,
doctor, so you can name.
इन्होंने volunteer किया है या you are reading out their names? What is it like?
See, Doctor, I'll tell you. See, the rest of the 5, Pooja, Nisha, they have been RPGs. I'm sure Dr. Mala must have suggested their names.
नहीं, but वो है ही नहीं यहाँ पे. They are not responding ना. Because we would like to start fast.
Yes, ma'am. Dr. Madhubanti Mukherjee has volunteered. Dr. Ruhi Jain has volunteered.
हाँ, तो उनको कर दो in ना, so that we are able to see their
So the
faces.
back-end team, please make them in because they are in the attendees group.
Yes, ma'am. Yes, ma'am. I am promoting them.
Yes, ma'am.
And I'll just give a call to Dr. Pooja and everyone.
Ma'am, I'm already here.
Oh, great. That's nice. Pooja, can we see you, please?
Yeah, please switch on your video as well, Pooja.
And Sakshi, in the meantime, I'll start sharing my screen.
Sure, ma'am. Thank you.
No.
So it's visible?
No, ma'am, not right now.
Achha.
I can just see a black screen, nothing else.
Okay. Better? आ रहा है?
नहीं मैम, black screen ही दिख रहा है, ऊपर दिख रहा है you are viewing Dr. AG. Yeah, now I can see.
Now we can see.
Great.
We'll make it full screen.
Yeah. I'll just do that. Fine?
Yeah.
Right. So who all have joined? Pooja, आपके साथ और कौन है? See, the reason for wanting to see you is so that we are able to ask you and know that you're responding. Otherwise, it becomes difficult, no? Online.
Yes,
that is the reason. Yeah. So anyway, let's start with you.
Okay.
So Dr. Mrinalini and myself, so we are just going to discuss out a few things with you. So, so the first aspect, which is rarely spoken about is about the principles of contraceptive counseling. So I think most of us, if you are asked this question, so today the interaction is going to be purely, other than the clinical aspects, the practical aspects, it is going to be exam oriented. Okay. So because now the system is OSCE pattern and a lot of questions are even otherwise, hair splitting of subjects are getting done. It is important for you to be comfortable in all these areas, and that is why we have changed the format. So the counseling is today extremely important. The respectful care of the client has been greatly appreciated. So we need to be respectful, not judgmental. I think the entire list is here. Dr. Mani, would you like to add to this? Would you like to explain the important points here?
Yeah, so when we are dealing with contraception, what we normally do is like the people sitting in the government hospitals particularly, and are the lower staff like ANMs, and they are normally first line of contact of the clients. I should not call them patients because they don't suffer from any disease and they have just come for asking. So what we tend to do is we just list out the options and tell them, ye hai, tumhare liye ye theek hai. That's not what is contraceptive counseling about. So we have to have a proper room of contraceptive counselings and ensure a proper privacy. And ideally, a couple counseling should be done. And we have to be non-judgmental because these days we have a lot of unmarried people also coming forward asking for contraception, and adolescents as well. And we have to be very welcoming and ask them certain questions, leading questions, and have to give a broad counseling has to be done, giving key messages across. And it has to be an interpersonal communication skills have to be used. And also then after introducing the method, we should encourage all these couple, I should say, asking any questions or if they have any concerns. We should have a habit of listening, give them our ears. We should do minimum talking initially. And also, it is best to have some audiovisual aids, or we can have some models, and of course, the samples of the contraceptive. As we call in the medical jargon and the family planning jargon, we should have a contraceptive basket ready on our tables to show them what are the different methods available to us. And one thing what we have to keep utmost in our mind, which is priority number one, that any method chosen has to be voluntarily chosen by the client, and it's an informed decision.
Right.
So these are the ways.
Yeah, so the atmosphere has to be friendly, and you need to understand, first start with, trying to understand what she is already aware of, understand her anxieties and fears if she is, tilting towards any certain type of contraceptive. And then you can, help her, give her some more added information and support her in arriving at a decision. So with that, we go on to the basic, the contraceptives that are available today. So we'll go into some details. So we know that the hormonal contraceptives have basically two components, that is the progestins and the estrogen component. So the progestins, many years back, it started with first generation, and today now we have the third and the unclassified progestins, which are there in the oral contraceptives. And we do know that the third and in fact, the most recent, in fact, some people even call it the fourth generation, have got a better lipid profile, better metabolic profile as compared to the older ones. So we will be going into the details of some of them during the course of our discussion today. And the estrogen components could be natural estrogens, that is the estradiol, estriol, or estrone. And the synthetic estrogens, which are more potent than the natural estrogens, are ethinyl estradiol, mestranol, and there could be non-steroidal like diethylstilbestrol, dextrol, and dinestrol. More commonly, the used synthetic estrogens in contraceptives are estradiol valerate and 17-beta estradiol. So, Pooja, can you enumerate some of the non-contraceptive benefits of hormonal contraceptives?
Yes, ma'am. In case of abnormal uterine bleeding, we can use to regulate the cycles or to control the bleeding. In case of anemia due to abnormal uterine bleeding, that can be controlled. Then, ma'am, in the case of
Pooja,
yes, ma'am.
so you want to say that it helps in reducing the blood loss, the
Yes,
mean
ma'am.
blood loss during menses. Okay.
Yes, ma'am.
So that is number one. Well done. Number two.
Number two, ma'am, we can use it for reducing the size of the fibroid. In that case, also it can be used.
Are you sure?
Then,
Reducing size of fibroid? I really don't think it is used for that.
yes, ma'am.
Because
Ma'am, then in the case of to regularize the cycles, like in case of
Okay.
PCOS, we can give.
Okay.
Then, ma'am, in case.
So it is a good idea to classify,
Yes,
so
ma'am.
there could be menstrual benefits,
Yes, ma'am.
for with respect to malignancies,
Yes, ma'am. Endometrial
benefits with respect to benign diseases. So would you
Yes,
like to
ma'am.
now answer in that direction?
Yes, ma'am. Like it is also used in the treatment of endometrial hyperplasia. Those women who are in the phasal place and they are not willing for any surgical treatment. In
So
that case,
yeah, so that I think you tried it well. So see, this is the entire list of benefits of the combined estrogen progesterone pills. Okay.
Yes, ma'am.
So it helps in reducing the menstrual cramps, pain during endometriosis, menorrhagia, which you very rightly said. There is a thought that it also helps in reducing the risk of ectopic pregnancy. But it is also a known fact that combined oral contraceptive pills could actually be also responsible for some increase in the STIs, because the protection that is offered by the other types, like for example,
Barrier.
the barrier contraceptive may not be there. So it is comparative. Then there is a reduction in the premenstrual syndrome, benign breast disease, ovarian cysts, right? So reduction in the ovarian malignancies because of the reduction in the numbers of ovulatory cycles, There is a protection against endometrial cancers, colorectal cancers, moderate acne, hirsutism, and regularizing the menstrual cycles. Okay, so these
Yes,
are the
ma'am.
benefits of the combined oral contraceptives, but there are also the benefits which are derived from the impregnated intrauterine device, that is the levonorgestrel intrauterine device. So again, the benefits are very similar with respect to the reduction in the cramps as well as the blood loss, pelvic pain related to endometriosis. So majority of the hormonal benefits are reflected here. Now, progestin only, again, menstrual clamps as well as the menstrual bleeding. Copper IUD has been recently also found to be associated with a reduction in the cervical cancer as well as with the endometrial cancer. I don't think this needs to be, dealt with, especially when you are answering during your exams. These are recent evidences. People may not be, this is open to discussion, okay? But the hormonal benefits are definitely there. Benefits with respect to barrier contraceptives the condoms is also there. It's a good idea to highlight those. Okay. So there could be short
ma'am.
notes or it could be across the table viva.
Yes, ma'am.
So,
Other kids are other PGs are Dr. Vasundhara, Dr. Gurpreet, Dr. Pooja.
Okay. So if they are here,
Dr. Tasneem, yes,
okay.
ma'am, they're here.
Okay. So now what I suggest is instead of we asking you by name, Gurpreet, Vasundhara, Pooja, you can go ahead and give your answers, right? I don't think we are going to ask you by names. And the person who answers first is, we'll probably clap for you or something like that. Okay. So, this okay. I'm showing you the answer. That's very bad. Okay. So the ovum is able to be fertilized up to 48 hours after ovulation. Is it true or false?
It is false.
What is the right duration?
Ma'am, it is 12 to 24, ma'am. 12 to 24 hours, ma'am.
24 hours.
Okay. The sperm can survive within genital tract for up to 5 to 7 days.
Other than Pooja?
Ma'am,
72 hours.
Yes, ma'am. This is also false.
So is it 72 hours? So we'll just go to the next slide and see the answers. Ovulation can be detected by a rise in luteinizing hormone.
Yes, ma'am.
Yes, ma'am.
True or false? So how, if it is true, after how long after this rise, peak of LH does ovulation take place?
After
12 to 36 hours.
36 hours, yes, ma'am.
Right. So it is around
36 hours.
12 hours, around 12 to 24 hours. Average conception rate for mid-cycle intercourse is approximately 15% per cycle. Right or wrong? Conception rate following coitus in the fertile period.
Wrong, ma'am.
What is the right answer?
25 to 30%.
Okay, near about
25%.
So the ovum is fertilizable up to 12 to 24 hours. Sperms can up to 5 to 7 days, right? We have been traditionally reading it up to 72 hours, but it is now clear that it is 5 to 7 days. Ovulation can be detected by a rise in luteinizing hormone. True. The average conception rate is around 30%. Okay, so well done. So Dr. Mani, over to you.
Yeah, so moving forward, whenever we are prescribing contraceptives, we have to make sure that the patient is, this client is lady is not pregnant. So can any one of you take this question? How can one be reasonably certain that the lady is not pregnant?
Ma'am, urine pregnancy test can be done.
Okay. Any other? Dr. Vasundhara or Dr. Gurpreet or Tasneem? Any other? See, a lady can come to us, she can come to us postpartum, she can come to us post-abortal, right? So I'm giving you hints here. Or she can come post-menstrual or during a cycle, anytime she can come to us. So how do you ascertain that she's not pregnant? Any inputs from anyone else? UPT was one, as mentioned by Pooja. Gurpreet, you need to unmute yourself, please.
Ma'am, serum beta HCG level, ma'am.
Okay, the serum beta HCG level, being ambitious.
Ma'am, last menstrual period date.
So we will start with history, clinical examination, and biochemistry. Okay, for all answers, you will proceed the way you would normally do as a clinician. Is that okay?
Yes, ma'am.
Yeah.
The history, something from examination, last comes for investigation. We need UPT and CBT. So you can, like you mentioned, in last menstrual period. Anything else? Nisha is also.
In the chat box, certain PGs have answered day of cycle in which she is coming with sexual intercourse history. Tasneem has answered ultrasound. Dr. Preeti Mehta has answered post menses.
Okay, fine. So whenever we want to assert that.
I'm
Ma'am,
sorry,
your
your voice
voice
is breaking.
Yes, ma'am.
No, ma'am, your voice is breaking. We can't.
I suggest, Dr. Mrinali, you can, close down your video. Probably the bandwidth is not good enough.
Better?
Yeah, once you speak, we'll know.
Okay. So when we are seeing that, how do you ask? So what we have to see is a lady can come to us, like Dr. Adhika mentioned, history. So we have to see whether what was her last menstrual cycle. So obviously, if she is bleeding, having a cycle, or she has come immediately after menstrual cycle, we are certain that she is not pregnant. Okay. Or we can ask her, suppose she comes in between. Right, so we can ask her when was the last sexual history of last sexual intercourse. We can also ask them whether when did they deliver last. Suppose she has delivered just recently in the past 4 to 6 weeks, or she had an abortion recently, right? Or she may be lactating. So if either of these questions we see whether she's in lactational amenorrhea or she has had when was the last intercourse.
So I think they have answered that, isn't it? I think they answered well. Yeah.
That if she says no to any one of them, then we need to go in for further investigations, right?
Yeah.
Otherwise,
Absolutely.
we are certain. So now, like I had mentioned, she's in lactational amenorrhea. So can anyone elaborate what is LAM method of contraception, lactational amenorrhea method? Anyone? What is lactational amenorrhea method of contraception? Yes, Gurpreet. Dr. Gurpreet?
Ma'am, voice is breaking, ma'am. I'm not able to hear, ma'am, properly.
Okay, what is LAM? Gurpreet, what is LAM?
Ma'am, it's lactational amenorrhea,
Okay,
ma'am.
define. What are the components of LAM? Anybody else? Pooja?
Ma'am, if the mother is exclusively breastfeeding the child, so due to the raised prolactin level, the level of FSH.
See, we don't want the pathophysiology. See, we have limited time, right? And we want to make this as crisp as possible, the way you would answer in the exam. Okay, this is a kind of a rehearsal for you. So you should be also aware that you need to stick to the point. You said very rightly when the mother is lactating. Very good. What else? Exclusive breastfeeding was 1 point. Yes.
Yes, ma'am. The first 6 months after the delivery, when the mother is exclusively breastfeeding,
it can be beyond 6 months also.
Yes, ma'am. She doesn't have her menstrual cycle regularly. Right. Then that period is called lactational amenorrhea.
So, what is the importance of knowing that?
That is the natural way of. That is a natural.
Method of contraception for the
contraception.
How successful as a contraception?
It has a very high failure
rate. What
rate.
Percentage? High failure rate? Okay. Yes. What do you think, Gurpreet? So lactational amenorrhea method is a good contraceptive period which is natural. Okay. The protection is almost up to the tune of 96 to 98%. Are you able to see the screen?
Yes, ma'am.
Yes, ma'am.
Okay. So the point is that it helps in protecting against pregnancy. It is a very efficacious way. There are only 2 important factors to be mentioned here. The mother should be exclusively breastfeeding, and second, she should be amenorrheic. So how do you confirm exclusive breastfeeding?
At least she has been giving the night feeds, and whenever the
8
baby
to
is
10 days of
and
8 to 10
other
times
than
per
mother
day.
and other than mother's milk, the baby has been not on any other feeds.
So she should have, there should be at least 8 episodes of breastfeeding, 2 in the night time. And she should be breastfeeding from both the breasts and all that. But
Breast.
the fact is that there should be no top feeds being given to the baby. Okay. So now let's go to the progesterone only pills and injectables. Which of the following is true? In women undergoing treatment for breast cancer, POPs can increase the rate of disease recurrence. True or false?
False.
Okay. Are you aware breast malignancies are hormone dependent?
Yes, ma'am.
Okay. And still choose the false answer? Okay. They are associated with an increase in the risk of thromboembolic disease?
Not
This is false.
they.
Gurpreet?
Ma'am, this is false. Ma'am, progesterone only pills, they don't increase the risk of
Gurpreet is
thromboembolic.
wondering or doesn't know. I don't know what is the answer. Pooja says it is false.
Ma'am, it is a relative risk, ma'am, for the POPs, ma'am. It's not the absolute indication. ma'am.
There's a question here. Did you read the question here? They are associated with an increased risk of thromboembolic disease.
No, ma'am.
Okay. Vasundhara was also there. No, we can't hear Vasundhara answering. Okay. They are contraindicated in women with insulin-dependent diabetes. True or false?
Ma'am, false.
It is false, ma'am.
Okay. They should be discontinued 4 weeks prior to major surgeries.
Ma'am,
Ma'am, true.
Okay. Major mechanism of action of depomedroxyprogesterone acetate is? How do the contraceptives act?
Ma'am, ovulation suppression.
Inhibiting of ovulation.
So what is the major mechanism of action of DMPA?
Ovulation suppression.
And number two?
Making the cervical mucus. And ma'am, endometrial atrophy.
And it is recommended as the first line of contraception in young women, meaning adolescent age group?
No, ma'am.
No, ma'am.
Why?
Menstrual
Don't read the
irregularity.
answers. Pooja, don't.
Yes, ma'am.
Don't read the answers. See, it is the idea is when you are reading from the books and when it comes to translation to practice or actually answering across the table. This entire 1 hour we are going to do just that. Because I'm sure you would have read contraceptives many times in your life, isn't it? We start from MBBS and then as a postgraduate. The problem comes when you're actually doing it hands-on. So
Yes,
this
ma'am.
entire exercise is to get you more familiarized with these kind of, situations. So first was breast malignancy. So in women undergoing treatment for cancers, POPs increase the rate of disease recurrence. So all hormonal contraceptives are generally contraindicated. Okay. Now, the progesterone only pills have not been found to be associated with an increased thromboembolic risk.
Yes, ma'am.
And you were very right in saying that they are not contraindicated in insulin-dependent diabetes, right? And what was discontinuation of the POPs before 4 weeks? Not required, right? DMPA inhibits the ovulation and also thickens the cervical mucus. In young women, DMPA, after 2 years of continuous use, there was found to be a reduction in the bone mineral density. But largely now the recent evidence suggests that probably it is safe. So adolescent probably we would still not be happy with. You were very right in saying false, that it cannot be used. But in young women, yes, it can be. It is a good long-acting reversible contraceptive. It is LARC. Okay, especially for spacing for over 2 years. I think it's a great idea to use. Right? So are you aware of a depot injection for subcutaneous use available in India? Gurpreet?
Subcutaneous use.
Yes. In fact, it has been introduced it's not available free supply, but it has been recommended by the Ministry of Health.
No, ma'am.
Is
Ma'am,
sub
Antara.
Pardon?
Antara. It's a sub Provera 104 mg. It's
Who says Antara?
um
Okay, Vasundhara is saying Antara. Do Gurpreet and Pooja Singh agree?
no,
No,
ma'am.
ma'am.
Ma'am, it's sub
But it's
Provera.
IM.
Ma'am, it's sub Provera 104 mg. Ma'am, it's coming in new, ma'am.
Okay. No, but what is your thought against Antara? For Antara or against Antara?
Ma'am,
Vasundhara
Antara is
says
given,
Antara.
ma'am. Ma'am, Antara is DMP
IM.
only, ma'am.
Pardon?
DMPA.
Ma'am, Antara is DMP only by the name of the government, ma'am. It's
What is
given
the route
IM,
of
ma'am.
IM.
Very
IM
good.
dose is
So it is intramuscular. So Gurpreet, you were saying 104 milligram. Can you tell us something more about it?
Ma'am, it is given subcutaneously, ma'am.
Very good. So it is
Subcu-
available by the name of Cyana Press. It's available in India, right? And it is also called as the depot subcu. The mechanism of action and properties are very similar to DMPA. It is 104 milligram in 0.65 ml suspension for injection. And the dose of the medroxyprogesterone acetate is at least 30% less than Antara, right? It has got a slower and more sustained absorption. It is 62% lighter and 25% less voluminous and easy to transport. It is available as a uniject system. Okay, this is the way it is a single use and throwaway. Okay, so now this is available in India and it is available by the name of Cyana. Cyana Press. So again, we go to true and false questions. Intrauterine coital contraceptive can be inserted up to day 19 of a 28-day cycle. True or false?
Ma'am, true.
Till 5 days, true, ma'am.
Very
True.
good. Mifepristone can be used for postcoital contraception.
Mifepristone.
Yes, ma'am.
Don't guess.
True. Yes, yes, ma'am. It can.
True, ma'am. Yes, ma'am.
So I can even ask you to justify why. Why?
Ma'am, it is anti-progesterone.
It can be used as an interceptive. It has got a central as well as a local action. So it prevents, there is a possibility that it inhibits the conception as well as in implantation. STI screening results should be available prior to fitting intrauterine contraceptive device.
No, ma'am. False.
Very good. Ulipristal acetate is as effective as an intrauterine contraceptive device with respect to postcoital contraception.
No.
No idea. Okay.
No, ma'am.
Gurpreet, you wanted to say something?
No, ma'am.
Okay.
No, ma'am.
Okay. So the intrauterine device can be inserted up to day 19 of a 28-day cycle. And they are more effective up to 120 hours after unprotected intercourse in comparison with oral levonorgestrel, okay, the EC pill, which is available in our country. So 85% efficacy up to 72 hours and 64 up to 120 hours. So this is the success rate of emergency oral contraceptive, which is 85% up to 3 days after exposure and 64% up to 5 days after exposure, whereas the intrauterine contraceptive device is up to 99% protective within 5 days of exposure. Okay. Okay, so what was the second question? Mifepristone can be used for postcoital contraceptive. Though it has been known to be an interceptive, it is not yet approved in India. It is used in rest of the, some of the countries in the world, but in India it is not approved. So your answer was right. I think you said you didn't know. I
No,
explained to you
last-
that it is available, it can be used as an interceptive, but for Indian scenario, the answer is false. Okay. When you said intrauterine contraceptive device can be fitted in an asymptomatic woman, we don't need an STI screen. You were right in saying that. And ulipristal, it is more effective compared to the oral ulipristal acetate, meaning the intrauterine contraceptive device is better than the emergency contraceptive pill as well as ulipristal within in about 5 days after exposure. So the first choice for post-coital contraception is intrauterine contraceptive device, followed by the emergency contraceptive. But the ulipristol has also been recently approved in India for use. So there are 3 choices that are available. It is important for you to know. Okay?
Yes,
right. Yeah.
Yeah.
So Dr. Mani, please.
Yeah, so moving ahead, so we would be talking about adolescent contraception. So anyone of you can answer this question. Are all contraceptive methods suitable for adolescents?
No, ma'am.
No.
So which one you would prefer and which not?
Ma'am, barrier contraceptives.
OCPs will be preferred. OCPs and LARC also, ma'am, are
Glass.
and
Barrier
POP
contraceptives.
because of menstrual
Okay,
irregularity.
one by one. So you said barrier contraceptive. Next.
Ma'am, LARC. OCPs.
Okay. Okay. And any other, what somebody said LARC. So which LARC would you like to use? Someone said LARC. So basically all contraceptive methods can be used in adolescents, right? So we'll be coming to the answers. Next
You
question.
you want me to show the next slide, the answers, Dr. Mani?
We will discuss the answers later on. Then let's
Okay,
ask them the
fine.
questions because they would be seeing the other
Yeah,
answers.
Yeah.
Basically, in a adolescent, we can use any of the methods after proper counseling and taking the history initially. Any method is suitable, like in any other adult. And next is, can combined oral contraceptive pills cause weight gain and acne?
Ma'am, due to the content of estrogen, ma'am, present in the
yeah,
combined,
which causes edema, ma'am.
So your answer is yes or no?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
What about the newer contraceptives?
Low dose
Ma'am,
estrogen.
they have a low dose estrogen, ma'am.
So what is your answer? So with the older pills, this was a problem. Does it continue to be the hindrance?
No, ma'am, not in
So to a
lower
lesser
dose.
extent. So do you think it is used for? You just now told us that it could be used to treat acne.
Yes,
Here,
ma'am, in
the
PCOD
question,
cases.
yes, it can be any case. So here it says COC pills cause weight gain and acne. So what is your thought on acne? They are actually used to treat acne, isn't it?
Yeah, she's contradicting herself.
Yeah.
Actually. There's no special weight gain, right? And it decreases in most of the cases because of the free androgens. And next is STD before initiating contraception.
No, ma'am.
No. Okay. And
Why? Justify why?
Next is IUCD affect future fertility?
No, ma'am, it should not affect future fertility.
Okay. Why so?
Ma'am, because the return to fertility rate is higher with the it is immediate after removal of IUCD and stoppage of combined oral pills.
Okay, so which of the contraceptives will have effect on fertility? Will be delayed return of fertility. Any other contraceptives?
Ma'am, injectable or the implants which can have the.
Yes,
Right.
very good. There is a delay of 7 to 10 months can be there.
Actually, there is a echoing of the voice, ma'am, when you're talking.
Yeah, I think you can close the video, Dr. Mrinalini. Your voice is not coming okay.
8 minutes.
So the next question is, condoms can be used with any lubricant, including petroleum jelly.
No, ma'am.
No, ma'am.
No, ma'am. No, ma'am.
No, ma'am.
Why? What
They
is the
leads
problem?
to breakage.
And
They lead to breakage. Anything else?
slippage of the
Slippage of the condom also.
So all contraceptives can be used in adolescents. The answer is true. I was telling you about DMPA also. Now there are safety profiles which have come for the adolescent use. So COCs cause weight gain and acne. The answer is false. No association with weight gain. Acne improves because of the reduction in the androgens. PV is mandatory before initiation of any contraceptive. The answer is false. But in India, we practice the opportunistic screening. So for cervical cancer. So because we rarely have the women coming to the hospital. So if somebody is presented to the hospital, it's a good idea to at least have a look once. Okay. So for prescription, it may not be required, but then the answer would be that you would want to examine her at least once because it is a kind of a opportunistic screening for cervical malignancy, because that is what is the routine, isn't it?
Yes, ma'am.
Do COCs and IUCDs affect the future fertility? The answer is false. IUCD cannot be used in adolescent and nullipara. The answer is false. They can generally be used. It is a MEC category 2 of usage for both these categories, right?
Yes, ma'am.
Okay. So, Dr. Mani, I think you wanted to basically show the failure rate. Yeah.
I just wanted to show the efficacy. Now, I think now my voice is better.
Yeah.
Yes,
Yes, yes.
So basically, we were comparing the efficacy of different methods available to in our basket. So you can see the different tiers here. The lowest rank is the least effective methods which are there, which is the female condoms and the natural techniques of withdrawal and the use of spermicides.
So, Dr. Mani, I think Pooja said that for adolescents, our first preference is condom. So that
I
may
would
not
like
be the
to,
best thing to
I would
advise
like
because
to
of
tell
it.
Pooja here one
Yes,
thing.
ma'am.
See, any method which we are prescribing, we would like to use a dual method, especially in the adolescents, because we do not want them to get pregnant. And also, secondly, we also want to provide effective contraceptive and prevention of STI,
STDs.
because they are a high-risk population and they may tend to have multiple partners. And this is a period of risk behavior. So dual method is always preferable. And as I counsel all my people who come to us, and we teach our residents also, always go ahead with the dual method, right?
So there is one important point. Actually, condom use is act dependent. So it is to be used at the time of act, and knowing the youngsters, the young mind, so they may not be ready for this kind of a thing. Number one. Number two, the failure rates are high. Okay.
Yes, ma'am.
And number three, we want them, even if they do want to use the condoms, it is a good idea to dual contraceptive, right? So regarding contraception in the adolescents, there are a few thoughts which are to be very important to be remembered, right? So after that, the injectables and the pills and the lamp, Dr. Mani, you want to say something? Because we would be also talking about these in the next few slides.
We will be discussing these methods.
So can we go ahead then?
Yeah, we can go ahead. And this
because
is
I have put the timer on, so we are already, we have about 30 minutes left and the slides are there.
Yeah, we can move forward.
Yeah. So, Dr. Mani, over to you again.
Yeah, so like when we talk about giving contraceptions, we use two terms basically. One is a quick start and one is a Sunday start method. So can anybody elaborate what is a quick start method and what is a Sunday start method?
Ma'am, in quick start, the patient is asked to take the pills as soon as she has been prescribed. And in the Sunday, ma'am, within the first week, she is, the next Sunday, I'm not sure, ma'am.
Anyone else? So basically, quick start is when the person comes to us asking for a contraception, we give it immediately. That is quick start. We just take a proper history, ascertain her need, and start immediately without waiting for the next menstrual cycle. And what we do is there are two advantages associated with this. The compliance is more, and it has been seen that no increased instance of breakthrough bleeding or other side effects are there, right? And also what we have to see is if she's come in a mid-cycle or after 7 days post-menstrual, we just need to ensure and tell her that and reiterate the point, a backup method will be required for the first 7 days by the time this method is effective. And for backup method, generally what we use is our barrier contraception. The condoms can be used or they can abstain, right? So this has to be done. This is what is quick start method. And what is the Sunday start?
After
First Sunday after
the
mens.
first Sunday of them when the mens is over, ma'am.
Yeah. So what happens here in this method? So we can tell or we can wait for the menstruation to finish like we start in any other. So that is, and what is the disadvantage of the Sunday start? Or advantage over the quick start, either of the things? One advantage and one disadvantage.
If you don't know, you can say don't know, so that we go to the next
skip,
one.
so we don't waste time actually.
Yeah.
Yes, ma'am. Ma'am, I don't know, ma'am.
Okay. So I think Dr. Mani, you can tell the answer.
Yeah, see, basically quick start method is definitely for adolescent particularly. We don't want them to get pregnant. So it is, and she may not come back to us. You know, adolescent asking for contraception, coming to a doctor, it needs a great amount of courage on her part. She's come to us, so we are giving her her method. So that is one advantage of a quick start method, right? And Sunday start method advantage is that it's easy to follow for the adolescent. Once we make sure that they are not pregnant, we can do that. And if it's a married female is coming to us, so the best would be to use an IUCD, because IUCD would act as a continuation method as well, right? So that is the advantage. So we can move on to the next one, Dr. Radhika.
Yeah. So when can the contraceptives be initiated after medical abortion? Medical abortion. Please remember the word medical abortion.
Medical abortion. Ma'am, immediately can be started or within.
Any other thoughts, Gurpreet? Vasundhara?
40 days. Ma'am, in the second ma'am, in the second trimester, ma'am, abortions,
So
ma'am.
do we do medical abortion in the second trimester?
No, ma'am.
Okay. So the combined contraceptives can be started on 3rd day or 15th day of medical abortion protocol. This is as per Ministry of Health guidelines. Okay. Whatever we are telling you is as per our country guideline, and you should know these. So as long as there are no medical contraindications, the progestin only, centromin, DMPA, all can be started from day 3 of medical abortion protocol, right? IUCD can be inserted once the abortion is complete around day 15 and the presence of infection has been ruled out. Is that okay?
Yes, ma'am.
Okay. So how many signatures are required for conducting medical termination of pregnancy?
Ma'am, the MTP, according to the MTP Amendment Act 2021, if the abortion has to be done within 20 weeks, then one registered medical practitioner, and if 20 to 24 weeks, then 2 registered medical.
Okay. Very good. Well done. Okay. So now we come to perimenopausal contraceptive. Dr. Mani, for you.
Yeah. So now coming to the perimenopausal lady, going ahead from the adolescents, are copper IUCD suitable for women age more than 40? You can answer in yes or no.
No, ma'am.
No.
Everybody goes with that. We'll discuss the answers later. Let's finish the questions first. Combined hormonal contraceptives cannot be prescribed to them. Yes or no?
Ma'am.
Combined hormonal contraceptives cannot be prescribed to a perimenopausal lady. Yes or true or false?
Can be
Gurpreet, what is your
Ma'am,
thought?
it can be given. Ma'am, it's true, ma'am.
Okay, so all the three say yes.
Okay, so all the three says yes. Then next is progesterone only contraceptives can be prescribed to perimenopausal lady. True or false? Progesterone only.
Ma'am, it's true, ma'am.
True, ma'am. Yes, ma'am.
All go with that?
Yes, ma'am. True.
Yes, ma'am.
So then progesterone only contraceptives can be given to a lady with a recent VT episode?
Yes, ma'am.
Venous thromboembolic episode?
Yes, ma'am, it can be given, ma'am.
It can be given, ma'am.
Okay. And list some of the indications of combined hormonal contraceptives.
Ma'am, venous thromboembolic episodes, breast
cancer.
And
having the migraine, ma'am, having the migraines and headache, ma'am.
Smoker, chronic smoker,
liver
age more
disease.
than 35.
Obesity.
Abnormal bleeding, suspected abnormal bleeding, ma'am.
So what is happening now is everybody is giving two answers and it is coming out as if the entire list is done. So it is important for each one of you to remember and recollect these points. Okay. I'm sure you know it. It's difficult to answer offhand. You're doing well, but be a little more fast in answering,
Yeah.
right?
Yeah. So now coming to the answers to your these, the first question, are copper IUCD suitable? Yes, it is suitable. We can prescribe copper IUCDs. Rather, is one of the long-acting reversible contraceptive methods, and it is very suitable for her. And by this age, some ladies may have some medical problems. So, and copper IUCDs have no problems. Can combine hormonal contraceptives to prescribe to them? Generally, we avoid but we have to now, these days we have low dose estrogen contraceptives. So we have to weigh their medical history and accordingly, but generally we abstain from prescribing them. They are the second choice if available. Progesterone only, yes, they can be prescribed easily, just no problem. And a lady who had a recent thrombolic episode, we do not give them, because progesterone only contraceptives are known to increase these thrombolic episodes. So we do not prescribe them these, right?
So while progesterone only pills can be given safely, they compared to the combined pills,
yes.
the safety profile is much better. But a lady who has had a recent BT, we would certainly not want to give progesterone. So two things we have learned today: the breast malignancies and recent BT. Okay, progesterone only pills.
Progesterone only. Yeah. So moving ahead, now a lady in a perimenopausal group, she's using a contraceptive. So at what age should we advise them to stop using a hormonal contraceptive? What age should we advise? When should she stop using a hormonal contraceptive? Like we mentioned, combined hormonal contraceptives are not to be prescribed generally. Anyone?
Ma'am, don't know, ma'am.
Okay. Okay. So next question. 42-year-old lady who had a IUCD inserted, copper 1. Now she's amenorrheic since 1 year. Should the device be removed? The amenorrheic since last 1 year. She had IUCD inserted. Now can we remove the device? No, she has that basically meaning this is not at the risk of pregnancy.
Gurpreet,
Ma'am, it's not necessary. It's not mandatory to remove. If she wants,
no,
then
she comes to you and she says, I want removal. What is your advice to her?
Now I'm menopausal, so I don't need the device. So you remove it. So would we?
Yeah, ma'am, then it can be removed. Ma'am, I'm not sure, ma'am.
Okay, fine. So let's go to the answers now.
Yeah. So when we generally, by the age of 55, nearly 96% of women become menopausal by this age. So that's a good idea to start using contraceptives by then. And if we measure the FSH levels on at least two occasions, which are 4 to 8 weeks apart, then they predict ovarian failure, right?
Yes.
And for non-hormonal contraceptives, if after 1 year of amenorrhea or 2 years of the last menstrual period of more than less than 50 years of lady, we can easily stop the contraceptive. And IUCD, if we like the second question, we had inserted a copper IUCD if it was more than 300. Now we have 375 and 380A in our basket. Yes. We are no longer using copper 220. So then if it was inserted after 40 years of age, we can leave it till her menopause is attained. So there is no problems with that. And also, we keep in mind that amenorrhea is not a reliable indicator of ovarian failure, right? So if a lady, she's using a combined contraceptive pills, we should advise them to switch to other methods if they become the age of 50. And also, POP and implant, that is progesterone only, we can very comfortably continue till 55 years of age, right? And if we have checked her levels of FSH, and they are both the times, they are more than 30 international units per liter, that suggests ovarian failure, and we are then certain that she is in menopause. We can ask her to stop the contraceptive use without any worries, right? And if a lady has an NNG device inserted after 45 years, we can ask her to continue till 7 years, 2 years afterwards, which is a very good practice point. And because sometimes what we have seen is a lady assumes at 40, 42, She hadn't had a cycle for 8 months, 1 year, and they stopped using contraceptives. And then she believes she's not.
I think
she
it's a
cannot
good
get
idea to
pregnant.
let them continue to use
Let
it for
them
7
continue.
years. Yeah.
Because we have had
It should
patients
be-
coming to us
yeah,
with a pregnancy after 8
I'm
months
sure.
of amenorrhea.
Yeah. So let's
we
go
can
to the
move
next
ahead.
one.
I think we can move ahead. This we have discussed already, Dr. Radhika.
We have done that, isn't it?
Yeah, we have
Okay.
discussed this.
Okay.
So then, and these now coming to these ladies, some are put on HRT. Do these women need contraception? Right? So we cannot be advised to lie solely on HRT because the doses are low and they can get pregnant. So we can use progesterone only pills with these as an effective contraceptive method, or if they have an IUD inserted, or they're using a barrier contraceptive, that is also fine. Right?
Yes, ma'am.
No, if the lady is menopausal and she's on HRT, do we want them to use POP, Dr. Mani? What exactly is this? Second point?
Basically, what happens is this was like we see some ladies coming to us in a perimenopausal and they
No,
are
but
having
this is, I think, not the usual practice. This is important
not
for
the
the
usual
students.
practice, but
Yeah, so it
sometimes
is important
rarely
for
it happens.
students. Yeah, I just let me highlight two things for the students. Number one, can contraceptives be used as HRT? Contraceptives, like we said, use synthetic estrogens. We don't, we want basically three benefits by way of HRT: the bone mineral density, the cardiovascular, and the neurological, the effects on the brain. So the amount of estrogens and progestogens and the potency so much is not really required, and we prefer the natural estrogens for HRT, and hence it is a good idea to change over to HRT. Number one. Number two, as regards the second point, POP can be used with HRT. That is more of an exception than the usual. It is usually a good idea to continue with the HRT and then customize as per the requirements of the patients. Okay?
Yeah, that sums up everything.
So what follow-up, Dr. Mani?
So yeah, so what is follow-up required for a lady using contraception in a perimenopausal? Should we be, what should we do? When should she come back for follow-up? Any one of them? Anyone? Pooja, Nisha? So basically, since we are short on time, so we can discuss this. So we can advise them to follow up if they develop any problem with the contraceptives, or they have any other of the medical problems are there, or they attain the age of 50. So it is whenever like people are putting in a LARC, they are using LARC method, they tend to forget and they don't forget to follow up. So this point has to be reiterated to them that if they have any problems, they have to come back to us. Right. And with the era of COVID coming and telemedicine coming, it's a good idea if we have records of our patient, we can always call them back and keep asking telephonically the follow.
So the indications are if there is any irregularity in period, number one, or if she misses her period, despite taking, there is a possibility that there is post-pill amenorrhea. It can develop in the period. But if any of these situations, if there is irregularity, amenorrhea, or if she develops a new medical condition, because that is the stage at which these conditions arise. Not only medical conditions, it can be malignancies.
Malignancy.
So whenever there is a change in any of these health conditions, the patient needs to report to you, right? Okay, let's go to the next one. Sorry. Okay, we
Yeah.
have discussed this, isn't it?
We have discussed this already.
Now let's talk about the technique of PP-IUCD placement. So can you tell us three important points with regard to the placement of the postpartum IUCD? For instance, what are the basic instruments required on the tray?
Ma'am, Kelly's forceps and
Sims, Kelly's.
Sims, yes, ma'am.
And where is Gurpreet and where is Vasundhara? So don't you want to hold the cervix, Pooja?
Yes, ma'am.
What do you want to hold?
Valsallam.
Ma'am,
So
scissor
that-
also.
it's not a good idea to use Valsallam. What is the right instrument?
Sponge holding force.
Sponge holder. Okay. So what are the contraindications?
Ma'am, in case of ma'am, the bleeding, if the PPH or in
Very
case
good.
of
Postpartum hemorrhage. Number two.
Ma'am,
Yeah, carry on. Don't look at the video. I'm just trying to forward the answer is not going to come here. Answer is not going to come here.
yes, ma'am.
Ma'am, rupture
Any
of
kind of
membrane is more
infection
than
within 48 hours.
Within 40.
So more than 18 hours of rupture of membrane, any signs of
Membrane.
chorioamnionitis if she
Amnionitis,
has,
infection, yes,
or
ma'am.
any signs of postpartum hemorrhage. In any of these situations, it is not a good idea. Or if she has sustained a genital trauma, especially
ma'am.
something like that's again a part of the postpartum hemorrhage. In any of these situations, it's not a good idea to insert the PPIUCD. So I asked you what should be the composition of the trolley. So it is these three basic instruments, and of course for cleaning and draping. And then of course you also need to have the, is there a different kind of a copper T, or is it the same copper T 380A that we have
Ma'am,
available?
same copper T, ma'am.
Okay. Okay, so I asked you for 3 points. So you have, I asked you about the composition of the tray. Number 2, the contraindications. Number 3, anything special about the technique of insertion?
Yes, ma'am. Ma'am, the copper T is held with the Kelly's forceps. When the first the Sims speculum is applied, and the anterior lip is held with the sponge holding forceps, and then,
Okay.
ma'am, the copper T is removed from the pack, and it is held with the Kelly's forceps.
So how is the copper T removed from the pack? So what I suggest is you people can go back and look at this the training video, which is freely available in the FIGO site, the GLOWM, which is there for the low middle income countries. So this is available. So this is by the no touch technique. You just remove the plunger and insert the Kelly's forceps into the pack, remove it. Look at the way it is getting held. You
Yes, ma'am.
hold the copper T at the junction of the stem and the arms.
Yes, ma'am.
Right? There is a reason for holding it like that, to avoid it getting the folded on its own self. So then it is inserted into the uterine cavity. So once you do that, what is special? What do you do to the uterus?
We massage.
There is there is a differential angle to the uterus with the cervix. So it is important that you insert it right up to the fundus. So if you don't feel this is the sharp angle that I was telling you about. There is a sharp angle between the axis of the vagina and the uterine cavity. If you don't correct this angle, then your instrument cannot go up to the fundus. Okay, so the uterus needs to be elevated in the abdomen and pushed upwards to straighten this angle. Right? See, can you see the
Yes.
abdominal hand? And
Yes,
there is
ma'am.
this uterus which has been pushed up and pressed back to straighten the angle. And then you insert with the Kelly's forceps inside up to the fundus. And then after holding it, this is the copper T is held at the junction, like I told you, of the stem and the arms. And then when you're drawing it, you draw, what is special about drawing out the Kelly's forceps? Anybody? How do you draw out the Kelly's forceps from the uterine cavity? So after you release the copper T inside the cavity, you sweep the Kelly's forceps along the uterine wall. If you're a right-handed person, along the right side of the uterine wall, or along the left side of the uterine wall, so that there is no entanglement of the strings or withdrawal of the copper T when you are removing the instrument. Is that clear for you?
Yes, ma'am.
Yes,
I
ma'am.
think somewhat it is clear, but I don't think it is very clear to you.
Okay, you can see the videos, watch the videos again, download from the
Yeah,
website as
it is
Benjamin.
freely available.
Yeah.
So can you see that? So it is
Yes,
just
ma'am.
coming out.
Yes, ma'am.
Yeah. So you remove that along the wall of the uterus, right?
Uterus.
So do you cut the thread? Do you
No.
cut the thread, yes or no? So the answer is no.
No, ma'am. No, ma'am.
So when do you cut the thread?
Ma'am, it's postpartum, so the uterus size will be
So do you
enlarged.
anytime in her lifetime, do you cut the threads? Or
Yes,
is
ma'am.
it
Next
Yes,
visit.
ma'am, in the visit.
when is the next visit?
6 after a month.
Yeah,
6
somebody
weeks.
was answering correctly.
Yeah. So
Ma'am,
6
after a
weeks.
month,
6 weeks.
6 weeks.
6
6
weeks.
weeks, ma'am. 6 weeks when
So
we
you
tell her
will
to
tell
follow.
her that the thread needs to be cut. Now, similarly, is the postpartum insertion of the IUCD during cesarean section. So what you have done is you have incised the uterus, delivered the baby, delivered the placenta. After confirming that everything is fine, now here this is a progesta cert which is getting inserted. Let's take this to be the copper T. You can insert the copper T either with the finger, held in the same way. You hold the copper T between the stem and the arms, go up to the fundus and release it.
Junction.
Okay, or again you can use the Kelly's forceps. Now here is a artery forceps, if you can see, and you insert the thread into the cervical canal. So you ensure that the thread is visible and can be seen in the postpartum visit and cut it short later on. Is that okay?
Yes,
Yes.
ma'am.
Is it
Yes.
clear to you? Have you seen assisted cesarean insertion of IUCD, postpartum IUCD during cesarean? If you have not seen, then you please pay attention to what I have told you just now. Is that okay?
Yes,
Any
ma'am.
doubt? Okay.
One thing, Dr. Ravika, I would like to add here is when you are inserting vaginally after a normal delivery, so if the thread is coming out, you can see the thread outside the cervix. So most probably we have not done a fundal placement, right? So if you have done a fundal placement, then the thread is generally inside. It is not visible. Right?
Why is that? It's a very important point to be noted. The reason is the uterocervical canal, the entire length is about 25 centimeters.
That is the
postpartum.
length of a thread.
So
Yes.
the length of the copper T thread is shorter than that. So if you see it at the coming through the os, through the cervix, that means it's not been placed in the right way. So in case it has not been placed, draw it out, throw it, use a new one.
Another
Okay,
one.
don't go
New
on doing. Okay, so this is a case scenario. 26-year-old para 3 had 3 cesarean sections and would like to be considered for sterilization. She is now separated from husband. Enumerate the eligibility criteria for sterilization surgery in India.
Ma'am, the client should be married, ma'am.
Okay.
And
So do you think this lady is eligible?
Yes, ma'am, she is eligible.
Now she's separated.
Yes, ma'am, she is eligible.
Okay. Okay,
Ma'am,
carry on.
the female should have one of her kid at least 1 year of old, and the consent of the spouse is not needed for the sterilization operation.
Okay.
And the age is, ma'am, more than 22 and less than 49 years of
Very
age,
good.
ma'am, of
I
the
think majority of
parent.
it, your combined effort has proved quite successful. So she should be ever married, 49, between 22 to 49 years of age, should have at least one child above 1 year unless the sterilization is medically indicated. Clients or their spouses should not have undergone sterilization in the past, should be in a sound state of mind so as to understand the full implications of sterilization procedure. Mentally ill clients must be certified by the psychiatrist, and a statement should be given by the legal guardian or spouse regarding the soundness of the client's state of mind at the time of surgery. So well done. I think you did well in that answer. So what about eligibility for male sterilization procedure?
Almost similar. Anyone can answer that. Yes, Sakshi? Gurpreet? Almost similar to the female. There's hardly
If
much
you
of.
don't know, say don't know so that we go to the next one. Don't waste time, no?
Ma'am, same way the spouse should not have gone any sterilization operation, and
the
same,
age
ma'am.
should be less than.
Age should be?
Ma'am, it should be less than
So
45.
should be ever married?
No.
Less than 60 years of age? One child above 1 year? Should not have undergone sterilization? Sound state of mind? Certified by the psychiatrist if it is mentally sick. Right?
Yes, ma'am.
It is important to know for you the eligibility criteria, Ministry of Health guidelines. Whether, okay, true or false, vasectomy has a lower failure rate than female sterilization?
Yes, ma'am.
Vasectomy has.
Yes, ma'am.
Yes, okay. Gurpreet, you agree or you don't know?
Ma'am, I don't know.
Yes,
exactly.
ma'am.
Okay. There is a significantly increased risk of testicular cancer following vasectomy. True or false?
False, ma'am.
False, ma'am.
Okay. So it has a lower failure rate compared to the female sterilization. And the answer that there is a significant increase in testicular cancer is false. There is no rise in cancerous problems following sterilization. Okay, what suture is recommended for the tubectomy procedure?
This
Cat.
And why?
cat,
Ma'am.
catgut.
Catgut, ma'am.
What number?
Let me see. Ma'am, don't know, ma'am.
Number one.
Okay. Why catgut? Why not Vicryl?
Ma'am, it is monofilament. Ma'am, not sure, ma'am.
Anybody else? Gurpreet, Vasundhara? Simple answer. No idea. At lap ligation,
No,
what is
it has a good,
it has a
ma'am, it has a good tensile strength, ma'am.
what at lap ligation? What is the ideal location for placement of the ring?
Ma'am, ampullary junction.
Okay. Enumerate two important indicators to confirm appropriate placement of the Phillips ring. How do you confirm that the placement of the Phillips ring is appropriate?
Ma'am, don't know, ma'am.
Don't know, ma'am.
So absorbable chromic catgut is recommended. The idea is that because it is absorbed very fast, it helps the two cut ends to fall apart, and thereby there is less chance of re-anastomosis. And that is why it is a good idea to use chromic catgut and not Vicryl. So lap ligation, posterior limb of the prong should be along the inferior aspect of the tube, about 4 centimeters from the cornu. You are very right, isthmo-ampullary junction. 2 centimeters of the loop above the Phillips ring should show acute angle in the mesosalpinx. So as you can find in this photograph, here the length of the loop should be around 2 centimeters and the angle should be acute here, and you can see the mesosalpinx getting puckered. Now, if this were not to happen here, what could be the possibilities? If the length of the loop is not adequate, then you could be only partially ligating the cavity of the fallopian tube. And while you see from the top that you have applied the ring, you have not successfully obliterated the cavity of the tube and thereby the failures. Okay, so accurate placement is extremely important.
What we can also see is there's a blanching at the base of the loop is there. So we know we have adequately clenched and the loop is ring is fitting well. So that's also good to see.
That's important. So now let's come to endometriosis and contraception. I'm just going to read this out, no questions getting asked because I think it's a little, probably it will take time. Estrogen progesterone contraceptives are thought to suppress ovarian function and thereby reduce endometriosis associated pain as well as activity. The mechanism of action is by dehydrogenation and subsequent atrophy of the endometrial tissue, and that is the reason for pseudo-pregnancy states that we try to create either with OCPs or with progestogens. I hope you are aware of that.
Yes,
are you aware? Okay.
Yes.
In addition, estrogen contraceptives have a slow progress. They cause a slow reduction in the progression of the disease, although the evidence is conflicting. Progesterone only pills can be appropriately used. So one can use norethindrone acetate, dipomedroxyprogesterone, Dynogest. So now in India, we have the Dynogest pills which are available in combination with estrogen. So we will be just seeing that in the next slide. And the other alternative is LNG IUS system, right? So we have now combinations of estradiol valerate with Dynogest available in India. There is, it's a stepwise decrease and of the Dynogest, stepwise decrease in the estradiol with a rise in the Dynogest along the period. So it's a multiphasic pill. It is available by the name of Clyra, Natassia, Veronica Combi. Kit is available in India. Clyra is also now available. So it is 3 milligrams of what you see in blue is the estradiol valerate, and what you see here is Dynogest. Okay, so you see that it goes on altering along the period of cycle. Okay, so malignancies, women with history of breast cancers, we told you it's not a good idea to use hormonal contraceptives. It is a good idea to consider using copper IUDs unless they are taking tamoxifen. And in the latter, off-label use of LNG IUD can be used to reduce the tamoxifen-induced endometrial changes without increasing the risk of breast cancer recurrence. Is that okay?
Yes, ma'am.
Yes, ma'am.
Yes,
Okay.
ma'am.
So contraceptive choice in medical disorders. Dr. Mani, to you. So in a cardiac patient, Dr. Mrinalini, are you there? So what
I
is the
think
best?
we are running short on time, so I can also enumerate instead of asking them.
Yeah.
Yeah. So, which is the best method for a lady suffering from a cardiovascular disease with the multiple risk factors? So, and also, can we prescribe CHCs in cardiomyopathy? So, as we can see from this slide, a person having multiple risk factors, IUCD remains the best method for use, the copper one, and rest, the LNG IUS and implants are category 2. They can be used, but MPA and the combined oral contraceptives are not to be used unless we have no other method. And with cardiomyopathy, if there's a normal cardiac function, any of the method is good. Even the combined oral contraceptive pills also can be used. But if there's an impaired in cardiac function, then we do not use a combined hormonal contraceptives. We just use a progesterone only method, and also copper device IUCD can be used. And with atrial fibrillation, again, combined oral pills are not to be used. And if there's a long QT syndrome, if we are initiating, then we are not to use IUCD and LNG because they might introduce an infection. But for continuation, we can leave them as such, and there's no need to change the method. And other methods, progesterone only pills and combined oral contraceptives can easily be used in this. So
So
as we can see,
so the
the
take-home
take-home
message
point
is,
is copper IUCDs are very safe, and so they can be used in a lady having because we are using aseptic techniques, right? You want to add anything, Dr. Radhika, into
yeah, I
this?
think the combined oral contraceptive pills have to be taken with some, conservatism. The rest of it is quite safe.
Quite safe, yeah.
Yeah. And also DMPA in smokers and women with cardiovascular disease, again, there could be a problem. And one can use others quite safely.
Yes. So moving on to the next disorder, which is very common, hypertension. So in these, can we use MPA, a lady having hypertension, or we can prescribe combined hormonal contraceptive pills, and also if a lady has suffered from preeclampsia. As we can see from this chart, again, if it is a controlled hypertension, we can see basically the take-home message is the combined hormone contraceptives are taken with a pinch of salt. We should not be using with a lady with hypertension.
So all others are safe, and
all others are safe,
it
basically.
is important to know that in preeclampsia, again, the oral contraceptive pills can be given, and others are absolutely safe.
Absolutely
so this
safe.
is a little different from the known hypertensives or the chronic hypertensives.
So next is the common disorder is diabetes. So even in a lady who has diabetes, except the one having any complication like retinopathy, neuropathy, or a known vascular disease, we should not be using combined hormonal contraceptives. Rest all, otherwise all are safe. The progesterone only pills and intrauterine devices are the very safe method, right? And in a lady having GDM, again, we can use any of the methods can be prescribed to her if there are no complications, right?
Yeah.
So moving on to the next one, Dr. Radhika, you can take on over
So
from here.
while it's important for us to also talk about the vasectomy, it is hardly ever mentioned. So at least 3 important points to be stressed. Anything you want to speak? Tell us. So contraception should be used for a period of at least 3 months with a negative semen analysis at the end of the time. So the point is that it is not immediately effective. It's not like tubectomy. Vasectomy takes effect after 3 months. So you have at least 3 semen analysis which need to be negative. Okay. So you can advise the lady to use another form of contraceptive, and in case she's already on one, for example, if she was on copper T, remove it only after 3 negative tests after vasectomy for the male. It is reversible, although re-anastomosis may be successful. This does not guarantee patency or fertility. It is associated with a failure rate of 1 in 2000 in comparison with 1 in 200 lifetime failure with tubal occlusion. So these are 3 important points that need to be we need to know actually before we, consider telling others. So is that okay? So the
Yes.
the effect comes after 3 months. The reversibility is not assured. The failure rates are much lower than when you compare it with the tubal. Yeah. So I think with that, our presentation is done. So we are well in time.
I think. Thanks a lot, ma'am. It was lovely. Loved the way you did a panelist with all the PGs. It just kept them to the toes, and I really liked it.
Oh, thank you so much, Sakshi.
It was really interesting and innovative. Never thought about
a
it.
very boring topic otherwise to deal.
Yes, ma'am. So it became very interesting and to the point and very practical questions. Even I was thinking, I don't know a couple of them. Right. Thanks a lot, ma'am. So now the last session of the day.
Thanks for inviting us. Thank you. We would like to thank you too. Thanks, Sakshi. Thanks, Dr. Mala and the entire organizing team for having us here. So we enjoyed it. Thank you so much.
Thank you, Sabina, and thank to the students who were our panelists.
Absolutely.
Thank you, ma'am.
Definitely.
Thank you, ma'am. Thank you, ma'am.
Okay.
Bye.
Thank you so much.
Okay, so for the last session of the day on endoscopy, I would like to invite upon the two endoscopic surgeons of Gangaram, Dr. Kanika Jain, Senior Consultant Gynae Endoscopic and Robotic Surgeon. She is also the Chairperson of Endoscopic Committee and Vice President of AOGD 2020-21. Welcome, ma'am. And Dr. Ela Sharma, who's an Associate Consultant in Minimal Invasive Gynecology Unit and also the Co-Editor of AOGD in 2020-21. Welcome, ma'am.
Yeah, are we audible, Dr. Sakshi?
Yes, now you're audible.
Yeah, very good afternoon to everyone.
Jasma. And I hope we'll be able to show you the instruments here online and you'll be able to understand. So shall we start
Sharing the screen?
Sure, ma'am.
Okay, Sakshi, can you see?
Yes, ma'am. Just make it full screen.
Yeah.
Just a second. Yeah, can you see it now?
Yes, ma'am.
Okay, so we start straight away. Are all the PGs there?
Yes, ma'am, they're all there. There are 124 participants there.
Okay, so if we ask questions, would anybody answer?
Ma'am, they might be able to answer the chat box.
Okay, fine. So maybe Sakshi, you can read out whatever comments we are getting on the chat box, whatever queries or whatever answers, so that we are able to acknowledge them.
Sure, ma'am.
Okay.
Okay, so we start with first thing in laparoscopy, that is patient positioning for laparoscopy. There is a video, I'll just show it and explain it simultaneously. As you can see, first of all, the patient is laid in a supine position and the hands are tucked. You can see the hands are, there is a glove gel, a glove made of, filled with water or air, which is placed between the fingers so that it acts as a gel pad. And the fingers, the arm as a whole are tucked inside the patient so that the armrest can be removed
by the side of the patient,
yeah,
so that the armrest can be done away with.
Yeah, so that we get a space around the patient.
And there are extension tubings which have to be attached for the IV line, for the pulse oximeter, and for the BPR.
Yeah.
So
here you can see the arms are being tucked in. These are the anesthesia machine along with the BP monitor.
And the extension tubings.
Extension tubings are being attached. Here you can see this is this is the Allen stirrup which we use. Here it is, there are both, the legs are kept in the Allen stirrup. First their floatron pumps are applied. Beneath that we apply the monopolar cautery pad so that it is not dislodged, it is fixed. And these are put in, the legs are put in this stirrup and covered with the this gel, leggings basically. And here you can see this is a floatron pipe tubing which is going. Here I'll show you. The advantage of this Allen stirrup is that it can be maneuvered even if we are washed by the surgeon himself. see how it can be maneuvered externally. Now you can see this is the warmer to keep the patient warm. These are the Flotron pumps which are attached, and this is our warmer. So once the patient is comfortable, then we can proceed further.
So these precautions are very apt, very necessary, because otherwise the patient later on can have
second slide.
Full screen, full screen. So these are the modified Allen stirrups, which you can see in the above slide. So these are much cheaper, but they cannot be maneuvered by the surgeon. And the proper Allen stirrups can be maneuvered intraoperatively comfortably by the surgeons himself or herself. And one thing I thought I should add, that the cautery pad should be applied over a well vascularized and preferably muscular area. It should not be applied over fat, because then the conduction is not good and the patient can have cautery burns. So, the calf muscles
Generally,
are
we apply on the calf muscles.
Yeah, and it should
so
be
that
broad
they are
and
well placed and broad area is covered.
yeah, very right. So
this is our machine which monitors the pulse, blood pressure, the basic things, and the SpO2 saturation. Now this is a video showing the machine.
Basically, I was sort of learning from the technician the details, because we just know the theoretical part and the technicians explain it better. So this is the this was the harmonic for the ultrasound, and this is the connecting tube. And we have kept the harmonic minimum at 1 and maximum at 5. We normally keep it between 3 and 5. 3 minimum and maximum.
So
5.
what is this maximum and minimum?
Yeah, basically for the minimum, if we keep it at a lower level, like 1 or 2, that helps in coagulation. That is vessel
There's more
sealing.
coagulation and less of cutting.
Yeah, and maximum 5 is for cutting. So we keep it at this setting when we are requiring more of vessel sealing with the harmonic. So
now this is.
Can you hear the background noise, Sakshi?
Yes, ma'am.
Okay. So we can play it. So this is the Karl Storz
insufflator. So what are these pressures which are being shown here? The first digit, can you see 13, which is written there, all the PGs? So this is the pressure which is being, which is required,
which is being
maintained intra-abdominally. Now the second digit which shows, this is the maximum number of liter flow rate, which is maximum up to 2 liters per minute, but here it is 1.5 liters per minute. This is the actual number of liters gas which has
gone in. So this was a radical surgery, so a lot of gas has gone in, and it's the end of this. And this is the amount of gas that is gone in. Right? So this is a radical surgery, there is not none of this. This is the insufflator tubing, which is not attached to the warmer. So the tubing I am showing is not attached to the warmer, it's at normal temperature. And this is the recorder, the Sony recorder that we have. This is a camera insert, this Karl Storz, and this is the light source. And we have the Xenon.
Ma'am, आपकी ना the video
is 4 light source.
Ma'am, can you hear me?
Sakshi, yes.
Ma'am, आपकी ना जो
yes.
जो वीडियो आ रही है versus what you were saying was वीडियो थोड़ी slow चल रही है उसके सामने comparison में.
अच्छा, okay, मतलब there is a lag.
There is a lag.
There is a lag.
Okay, fine. Okay, so let us know in future. So Sakshi, I'm not saying anything. This video is self-explanatory, so I'll just hold on because the lag would create further confusion. So basically, let me show you how to put it on. So we press this propeller in the hand. You press it in first, then put it on. Keep moving till the light starts blinking. Right? In the way. Once the are blinking, we press on any button and they stabilize. And that is when you. So we have the LED fluid coming from this side. It's going in, and from here, when we put it on, it goes here, and then we will install for the irrigation. This we are using here in laparoscopy. It can also be used, its main purpose is for this system. So here we have the monitors, HD monitors.
Ma'am, video is almost done. Video के ना in between voice आ रही थी, voice नहीं आ रही है.
अभी आ रहा है आपका आवाज?
Ma'am, नहीं आ रही है अभी.
Okay.
So that
Okay, fine. We'll explain. So this is the force triad. This force triad is quite covalent, and this is the cutting column, that is the monopolar cutting and coagulation blend. This is for the bipolar, and that is for the ligastole, which is the advanced bipolar. So this instrument can be used for all three modes of energy sources, the electrosurgical energy sources. And it's a good. This is the warmer that we're trying to show, with which we had the air blanket as we had shown in the position video. So,
So now we come to the next instrument, which is a Verey's needle, which is the first and foremost thing required for laparoscopy. It has two parts. It has a needle which has a diameter up to 1.2 to 1.8 millimeter with an external diameter of 2 millimeter, and it is 14 gauge. Length of this instrument is approximately up to 70 to 120 millimeter. Then it has a stylet, which has a blunt end, which is atraumatic, with an eye to facilitate the flow of a flow rate at a maximum of 2.5 liters per minute.
So this is just a video showing. We lift the anterior abdominal wall, just give a stab incision over the abdominal wall, and we are trying to hold it in a pen-shaped manner, and we are trying to rather dart. It's held like a dart, and we go in and we feel the. If we are intra-umbilical, we feel 2 clicks. If we are away from the umbilicus, we feel 3 clicks. So once those 3 clicks are felt and we feel the loss of resistance, that's when we are in. Then we check with the saline. So first we aspirate to make sure we're not inside any cavity, I mean in any vessel or etc. Then we push in saline, then aspirate again just to check. And here you can see the important sign is the intra-abdominal pressure should be within 10 millimeters of mercury. It should be in single figure.
So here you can see it's 6 millimeters. So we are well inside the peritoneum.
And the liver dullness goes at around 300 when around 300 millimeters of gas has gone in.
Yeah, now these are the various trocars. These are the non-optical reusable trocars which were used earlier. But now we use mostly the disposable ones. These are again, these can be optical as well as non-optical. So what is the, I will just show you.
These are the
Can you see
the optical trocars?
Yeah, Sakshi, are we visible?
Yes, ma'am.
Yeah.
So basically this tip is of plastic. So this is the thing which makes it optical. That is, we can see through them. And it's locked inside. And once we have the scope, like this is the scope. So we put it in. We open this latch, put it in, and then close it. So this gets locked. And then whenever we insert, we screw it in. And this is done under vision. Once we are in, we take it out, take out the sleeve, and then put it in again. So this is the optical trocar, and the other is the non-optical trocar. And in this, can you see the arrow? This is the reducer. What we can do is, if we take the 10 mm trocar, we have to introduce the instrument, which is like 4 mm. So this is the reducer for that. Otherwise, the gas keeps leaking. And here, if you can see, the optical trocar has a conical end. So it just teases away the tissues. Whereas this one, the non-optical, has a sharp cutting knife. It's a triangle blade with a protector. which comes off the moment we pierce the peritoneum. Now, this is the Hassan's open trocar technique. Can you explain?
This is the Hassan's technique in which the incision is given through the skin at the umbilicus. We tease the muscles basically and catch hold of the fascia with Alice and incise the fascia and the peritoneum. This is all under vision. A suture is placed over the two ends of fascia and a shielded trocar is then inserted while looking inside directly. So this is like open.
Suture is tied to the holes here.
So that it holds the instrument, it's like acts as an anchor.
It doesn't slip away.
So now we come to the laparoscopes. These are the various laparoscopes, 10 millimeter with 30 degrees and 5 millimeter with 30 degrees. I will show you just. Now what do you mean by 30 degrees? There is an angulation basically.
This is
0, 30. Okay. Yeah, there is an angulation. I don't know whether you can see or not. Can you see it?
Yes, ma'am, we can see it.
Yeah, so there is an angulation which is around 30 degrees. And this is a 5 millimeter scope. The advantage of this angulation is like once we go inside, you can have a more vision as compared to the 0 degrees. Normally used telescope is the Hopkins forward oblique telescope, 30 degree, diameter 510, length is approximately 33 centimeters and is autoclavable.
So basically this is connected here to the camera and we have the 3-tip camera. We have to do the white balance first, making sure that all the colors in the spectra are correct. Basically, there are 3 primary colors. That is why we have a triple chip camera, red, blue, and green. The resolution is 1080 pixels, and the camera head consists of a gold lens, a prism assembly, and 3 sensors for acquiring the primary colors of the image. And we know that if there is a bloody field, the light gets hampered because it's more absorbed and we are not able to see clearly. So this is just a video showing the accessory port placement. So we do the trans illumination to see the superficial vessels of the skin. But actually from inside we have to see with the camera.
So we avoid basically the vasculature area.
Yeah.
We don't have to pierce that area.
And the trocar has to be kept, as you can see, perpendicular to the skin and pierced in a perpendicular manner. The moment the peritoneum is pierced, then we go obliquely in to avoid any injury to the vital structures. But if the trocar is put in through a tunneling effect, then it becomes very difficult for the surgeon to maneuver, as well as it becomes very painful to the patient because there can be bruising of the abdominal muscles once we pull it in any direction.
Hematoma is formed inside.
So this you can see is going absolutely perpendicular. So once the trocar goes in perpendicular, it's free to move in all 360 degrees.
Yeah, so now coming to the various ports which are placed. One is the umbilicus.
Yeah, umbilical port is very easy to go in, especially in virgin abdomens, because the layers are fused here. So we just, as I said, feel the 2-click with the various and we go in. But again, the angulation depends. In the obese patients, the angulation has to be absolutely perpendicular, whereas in the lean and thin patients, it has to be approximately 45 degrees
to the pelvis.
Towards the pelvis. Otherwise, we may directly go into the greater vessels. Yeah. So these are the accessory points which we've tried to show marked with the computer itself. So our handwriting is great. So we have the Palmer's point, which is most favored, which is 3 centimeters below the left subcostal margin and the mid-clavicular line. This area is usually safe of adhesions, and in cases of previous surgeries, we prefer to go in with this. Once we see, then the other ports can be made under vision, and maybe if we want, we can use the other ports, because with Palmer's operating in the pelvis, deep in the pelvis, becomes sometimes very difficult. It's very high up. The next point is the Jain point. This has an advantage over Palmer's, that this point can be used as an operative port. This is left in the left paraumbilical region at the level of the umbilicus in a straight line drawn from 2.5 centimeters medial to the anterior superior iliac point, vertically upwards. So as I said, it's different from Palmer's in the sense that this can be used as an operative port. Then we have the Li Huang points, which is between the xiphisternum and the umbilicus, more towards the xiphisternum. The disadvantage is that the falciform ligament is sometimes pierced, injured with this. And then we have the intraumbilical, of course, in virgin abdomens, which we use, cosmetically better, relatively avascular, and very convenient for the surgeon. So this is an optical trocar placement being shown. And Dr. Ila would explain.
Yes. Should I start the video? This video is not working.
So the video is not working, but it's the same.
It's like same we explained it, like you insert the trocar. You can see in this. This is the camera. You just open this catch, insert the camera. Can you see it? Yeah, insert the scope.
Lock it.
Lock it. And then we insert it in a screwing movement.
Camera attached.
Yeah, with the camera attached in a screwing movement so that we can see layer by layer when we are going inside. Once we are inside the we don't have to apply very much force in this because we can very well see the layers separating and we are going inside. Once we reach, we just open this, remove the camera. By these two, you can see side buttons. We just have to press them, remove the trocar and then insert the camera again. Can you see it? Dr. Sakshi?
We can see it.
Yeah, okay.
So this is the uterine manipulator, which we normally use for hysterectomy cases, but we can use them for myomectomy, for endometriosis surgery, for any surgery in which we require uterine manipulation as well as elevation. So this has a screw here, and it can be, the length can be adjusted according to the uterocervical length. Then we fix it up with a screw, taking care that the screw is in the upwards direction, not in the downwards direction, because otherwise manipulation becomes difficult. And then this is a
colpomatizer cup, cervical cup, which is put inside this, applying the jelly, and then we fix it in the.
And the thread is attached so that we are able to hold it and control it. And once we attach it, I'll just show the video. So basically what we do here is we've measured the uterocervical length, we fix the uterine elevator at that length, put the colpotomizer cup over it, and then we put in this end which should be insulated. The insulation is gone there. We put it inside the cervix. Once we are sure that it's in, then we gently remove the same speculum, and following which we release the anterior slip of the cervix. Yeah, valsellum or Alice, whatever it is. So we release the anterior lip of cervix and then push it in. Once it's in, then we can check laparoscopically whether we are in proper inside the uterus or not. Sometimes it can inadvertently go into the through the uterus and the cervix or into the bladder also. So we want to be careful.
I would like to add, the whole lip of the cervix should be inside this cup.
Yeah. So ironing is being done.
Ironing is being done so that just to check that the whole cervix is inside this cup.
Yeah, and there's no vaginal tissue which is
holding in the
trapped inside the cup.
That is very important because when you cut laparoscopically, you might inadvertently, if you have not checked it, you might cut the vagina also.
So now coming to the laparoscopic hand instrument. So once we are in, we put in the trocars and cannulas. We put in the scope and we've done the uterine elevation. Then we start with the surgery. So for the surgery, we need some laparoscopic hand instruments. So there are traumatic and atraumatic hand instruments, and these are the non-traumatic. Apart from this one, which is the tooth one. This is Maryland's. This is the tooth grasping forceps. This is the flat grasper. And
This is the
this is
Maryland.
the crochet. So Dr. Ila would show you the instruments.
Yeah. So you can see here. Can you see it? It's a curved blade with a pointed end. This is a Maryland.
This is used as a dissector.
This is basically used as a dissector. This is the crochet. You can see it has holes inside it, flat
very
blade,
gentle
and it is
serrations.
basically used for holding the bowel.
And the
This is
delicate
basically
structures.
atraumatic.
This is another type of. This is the tooth. This is the tooth graft.
This is atraumatic. Yeah. Here you can see. Can you see it? Can you see the 3 claws? Yeah, tooth.
We can see the 3 and 2 on one side.
Yeah, 3 on one side and 2 on one side. So this is a tooth grasper. And this is the gentle teeth. It is again, you can see very fine teeth are there. This is again a tooth grasper. And this was a disposable Maryland, again used as a dissector. Can you see it? How curved and pointed it is. Yeah, this is a 10mm Babcock just to hold the fallopian tubes.
So these are the parts of the instrument being shown. We have the handle. Okay, so this you can see. This is the handle, and this has a rotating knob with it. And we have a lock here, which has serrations, and it gets locked, so it can be tightened once we hold the tissue. It can be tightened, and then we release it. So we release it this way, and the instrument opens. So this is the handle with the lead here. I think all the instruments usually have a lead here attached for the monopolar, and we have the.
One of the PGs requesting you to show the 10mm Babcocks.
Yeah.
It is not actually proper Babcocks. The Babcocks has a groove here. It is not proper Babcocks, but it is an atraumatic grasper.
Yeah.
Used to hold the tubular structures.
You can see there is a space between the once we closes the tips, there is a space between. So the tubular structures can be held without traumatizing them.
Okay, so we have one more thing I forgot to mention, that we have to check the insulation of all the instruments. Before we start any surgery, we have to check the insulation of all the instruments. That's very important, because any breach in insulation can be very hazardous. There can be capacitation and non-capacitation burns. So this, as you see, the whole instrument is insulated. So that even the area, the hinge part is also insulated, if you can see. So this is very important, which we had forgotten to mention. And so we have the insulated outer sheath, and there is a cap to the instruments once they are kept outside. Then there is an insert, which see. So this sheath.
This can be removed.
This can be removed. This can be, the inner part is the instrument which can be removed and cleaned. And then the outer sheath, which is insulated, is detached.
Ma'am, the same PG is asking, can we use the Babcocks for holding the bowel as well?
Yes, we can. Definitely we can use it, but very gently. For the bowel, preferably we should use the crochet or the bowel grasper, and that too we should not actually use it to grasp. We should not actually hold the bowel properly with it.
We should not close the tips.
Yeah, we should just open it and retract the bowel as far as possible, not hold the bowel properly. In case we have to hold it and pull it away, we should use the epiploic and not the
tinea can be
not the
actual bowel.
Not the actual bowel tissue, because that sometimes can cause bruising. So preferably a very gentle handling of the bowel has to be done, for which these instruments are quite atraumatic. So these are the various types of instruments, tips that we can see. So we have the Maryland, Maryland, then we have the Metzenbaum's curved scissors. We have this scissors which is disposable. So this is a curved scissors. If you can see, the tip is curved and it is rotating as well. So we can turn the direction. So this is a Metzenbaum's curved scissors. Then we have the tooth grasping forceps. Then we have Alice grasping forceps, fenestrated grasping forceps, and we have the endoclint grasping forceps. These are the bowel graspers. This is the older version, the traditional one. And here we have the crochet, which is what we showed right now. And there are other kinds of tooth graspers. And that is the Babcock's. If you can see this one, that is the Babcock, which has another groove which is curved, which is
the tubes can be
which is like the open Babcock's forceps. And the lower one here, this one is the ureteric grasper, what we call, which is the oviduct or a tubular, basically to hold delicate tubular structures. It has a loop like this. So we just hold the tube in between or the ureter in between. Then we have the parrot beak scissors, this one, which is a hook scissors, normally used to cut the vascular pedicles after we've ligated them. So these are the scissors, various types they've shown, the disposable ones. The tip is like that. And these are the traumatic instruments. So this,
here you can see the
Single
sharp tooths. These are the single tooth grasper. You can see.
Okay. So this is the myoma screw.
This is the myoma screw, which is screwed in a clockwise fashion. Once we rotate it clockwise, it goes into the tissue and catches the tissue. This is the suction irrigation cannulas. Here the suction is attached and one is for the irrigation, basically.
So we have a knob here. This is a broken, basically just for demonstration. The knob is broken here, but we have a knob which we can move in either direction, towards suction or towards irrigation, and it has holes here. And as you can see, there is a hole here in the center, plus it has fenestrations in the sides also, so that there is not, the suction is not absolute. Yeah. So there are holes to sort of prevent damage. And as you can see, the knob in that. So these are the needle holders. There are two varieties of needle holders, the auto riding or the self riding and the manual. So these what we are showing are the manual ones. The self riding needle holders, they have a groove here inside the tip. They have a groove, and these are just serrated and are manual ridings. They do not hold the needle or position the needle automatically. We have to maneuver and hold the needle. And this is a right-sided needle holder because the curve is towards the left. And for a left-sided person, left-handed person, the curve is towards the right. Or there is a straight needle holder also, which is neutral in position. So this is just to demonstrate. It's not working. Just to demonstrate the how the suture is taken at the vascular pedicles, the uterine vessels, with the needle holder. So this is a specimen retrieval bag. Can be EQ'd and reused. It comes in a disposable tube and it is wrapped this way. it comes in a wrapped position only. And since this is a reusable, so we PTO'd it for use. And this is the way it is introduced inside through a 10 mm port. And once it's in the specimen and retrieved in this is a thick rubber wire which is inserted, which is inside it, and we pull it out through this. And this is quite sturdy, doesn't really break very easily. So these are the oscillators, the Karl Storz oscillators. We have 10 mm, 15 mm. And if you can see, this is the electric cord connected. This has a serrated end through which gas can leak whenever the blades are not in. This is the blade, which are, these are very sharp circular blades. And this is the trocar, which is blunt, absolutely made of solid steel, and it's very blunt. So once we are in, this is our safety guard to protect injury. Once this is removed, we screw in the blade. So this has to be done under vision, because otherwise the sharp blade may injure any of the vital structures. And these are the washers to prevent leakage of gas. This is the more safe morcellator bag. We have one. So basically, I think demonstrate on this itself, because that has to be open. We can just show them. So this again has a rubber ring or a silicone ring, and this is the main bag, and it has a nozzle here. So it has to be introduced. One has to be introduced to the 10 mm port, and through the other we introduce the morcellator. So basically, this is the thing. So what we do is through one end we introduce the morcellator, through the other we introduce the 10 mm port, we introduce the camera, and then the gas is insufflated. Once the gas is insufflated, this inflates to a big volume. As you can see, the volume can be quite enormous, and the tissue is put in and it is morcellated within the bag. So there is no spread of the tissue cells anywhere. These are the smoke evacuators that we have. So this is a smoke evacuator connected to one of the ports. Like it can be connected here, screwed in. And then it is, now what we've done these days with COVID times, we connect a tubing here and let the gas come out through this trocar, and we connect it with the tubing and put it underwater in a bucket which is filled with 1% hypochlorite solution. So the fumes go underwater under the 1% hypochlorite solution. And this is another one which has the HEPA filter with it, which is again connected to the trocars, and this is a smoke evacuator for the safety norms. Now these are the port closures. So once we've done the surgery, whatever, we have to close the ports.
Especially the 10 mm port.
Only all these more than 7 mm ports need to be closed, especially the lateral ones more than 7 and the central ones more than 10. They need to be closed. So this is the Unimax needle, which is the tip is protected with a guard. So this needle comes out and the flanges, they open out. So the thread is held with this. Like for example, if this is the thread, we can hold it with this and then pull it in. So this has 2 holes. So once we go in, pierce this goes in down. So this goes in through the 10 mm port, and we put it in.
So once we are inside the peritoneal cavity, we release
open it, release the thread, then go in through the other hole,
side and try to catch hold of this thread again,
and we take it out. So that way we are able to
close the rectus.
Yeah, basically it's to close the rectus sheath, and then the skin can be closed with staples or the subcuticular stitches, whatever is.
This is the stapler.
Yeah. This is the stapler just to show.
This just works
how
like
we
a
staple.
paper stapler. It's exactly like same.
We just hold with the forceps, the tooth forceps, the skin is held and the staples are applied. So this is how we do it. So these are the latest devices which have come up for endosuturing. If somebody is not very well versed with endosuturing, so these are the latest devices which have come up. This is Proxy Shore, which automatically sutures inside, and this is Overstitch. So as you can see, it's working like a miniature sewing machine inside. So then we come to the energy sources, because apart from suturing, we have this option of energy sources. Yeah, this was an instrument wisdom. This is a needle.
Aspiration needle.
This is aspiration needles through which we can aspirate whatever, if a cystic fluid needs to be aspirated, or we can push and vasopressin in myomectomies through this needle.
Energy sources.
Okay. So what we have?
Yeah, we have electrosurgical energy, which can be monopolar as well as bipolar. Then we have ultrasonic energy. Then we have laser. So what is basically electrosurgery? Electrosurgery is the application of alternating current to the biological tissue to achieve effects like cutting, coagulation, desiccation, and fulguration. By the to and fro movements of the electrons, this kinetic energy is converted to thermal energy. So now let us see what happens. What are the various instruments? Now this is first is a monopolar hook. Can you see it?
This is basically a monopolar hook through which the current passes, and the other end of the current, the other end of the lead, it goes through the body, through which the earthing that we have created with the cautery pedal. So monopolar works on the principle of this one lead. So I had a video, I don't know whether it's playing, to show the colpotany being done with the monopolar. It works very well. It is usually used for cutting, but can be used for coagulation also. And it is used in lap colis and other surgeries as well. And the other one is the Roby forceps, which is the bipolar forceps. And can anyone tell me why?
Form of
Roby
also. It is basically, as the self-explanatory, is a rotating bipolar. Okay, rotate it.
So we can rotate the direction of the bipolar instrument. That's why it's called Roby. It is not after the name of any scientist. So this is the lead for the bipolar, and these are the handles. This is the rotating knob, and it's quite like a Maryland forceps, but connected to a bipolar source. So this is a monopolar needle, which is normally used for like drilling in PCOS cases. It has a self-riding stellate, and sort of that's the protective mechanism. And once it comes out, we, as you know, in PCOS, which is normally not done these days, but the ovarian drilling used to be done at 4 points at a depth of 4 millimeter for a duration of 4 seconds. Now, the question arises, why don't people get electrocuted during surgery?
This is because the current from an electrical outlet, that is 120 volts, traveling at a hertz of 60 seconds, is more than enough to cause neuromuscular stimulation. In the 1920s, Dr. William Bowe discovered that nerve and muscle stimulation ceases at 100,000 cycles per second, that is 100 kilohertz. Now, today's electrosurgical generators operate safely at frequencies of 200 kilohertz or above. If the generator is operating at 100 kilohertz or higher, there is no risk of neuromuscular stimulation.
So that is why we don't get neuromuscular stimulation of burns, because we are operating above 100.
Now there is cutting cautery, which has a low voltage and for a longer time. For coagulation, we need to work on high voltage with a short time. Cutting divides the tissues with electric spark with intense heat at surgical site. While in fulguration, there is high voltage coagulation current, which coagulates or chars the tissue over a wide area. In desiccation, the cutting current touches tissues, the cells dry out and the proteins denature and form coagulin. There is less heat and no cutting. In vaporization, rapid spread of high heat causes vaporization. Now using same frequency, we can generate more heat and thermal damage by increasing current output, decreasing the surface area, increasing the resistance and increasing time. Less surface area, more kinetic energy that leads to cutting, while more surface area, less kinetic energy leads to coagulation.
So this is basically the monopolar electrosurgical unit that they're trying to show. The current comes out from the generator to the active electrode, which was the hook that I showed.
This
and
is
then
the hook which is being used.
Then to the patient, to the return pad, which is put at the
This
calf
is the pad,
muscles.
you can see. From
And
this
then
it returns back to the electrosurgical unit.
So here we can see the importance of this pad. If the cautery pad is not properly applied or applied over a less vascular area like fat or buttocks, then patient may get burns. So this
is not okay.
So this was a video just showing the colpotomy with a monopolar hook. So what are the advantages of monopolar? It is very easy to use, cheaply available. We can adjust the current intensity. It can be used for cutting, blending, desiccation. But the disadvantages are: one, it interferes with the pacemakers. Two, it has the maximum thermal spread. And the maximum thermal spread, lateral spread, is seen with monopolar cutting, followed by monopolar coagulation, followed by bipolar, followed by the advanced energy sources that we have these days. And so the better the more advanced the energy source, the lesser lateral thermal spread it has. And obviously it is nil, the lateral thermal spread is nil with what?
With the
with the cold scissors.
Cold scissors.
So it has a disadvantage also that it is unable to seal vessels more than 1 to 2 millimeters. And there are more incidents of burns if the contact surface area is reduced, and it takes time to cool down also. And bipolar has the, it basically employs the technology of going between the two blades. So the current comes in through one, goes in through the other. So it is kind of a sealed circuit. Both the poles are there in one electrosurgical unit. So it results in less potential damage to the surrounding tissues and less risk of capacitive coupling. So this was again a video showing the bipolar coagulation. It's not working. So basically, what precautions do we have to take for electrosurgical devices? The grounding pad for the return electrode should be wide, over a wide, well vascularized area, which should be close to the surgical field. We should always inspect the insulation. As I said, there should be no breach in insulation. We should start with the lowest power settings, preferably 1820. And if it doesn't work, then move on to the higher one. The contact mode of coagulation current for desiccation should be used. It should be a brief intermittent activation and not a continuous prolonged activation of the footbed. We stop coagulation at the end of the visible vapor phase. Once we are coagulating any vascular structure, we should not just keep on coagulating once the vapor phase goes off. If we coagulate any further, then there will be charring. And this charring should be avoided because this charring gets stuck to the tissue, and the moment we to the instrument,
then
yeah,
there is again
the
bleeding.
char comes off and there is a fresh bleeding. And we should not activate in close proximity to another instrument. This should be very important point. We should check that no two instruments should be touching each other. And identify the source of bleeding and then cauterize. Never do a blind cautery. Then if there is charring and the instrument is sticking every now and then, we should clean the instrument tips. Preferably, if available, hydrogen peroxide should be used, and then it should be washed with normal saline and then reused. So the advantages of bipolar?
The risk of cautery burns are reduced. They can be used in patients with pacemakers. There is less lateral spread and better coagulation in hemostasis because it's a closed circuit. Now, disadvantages cannot be used for cutting. It requires more time to coagulate and more charring and adherence to the tissue, which may lead to tearing off of the adjacent vessels. Now there are advanced bipolar vessel sealers. These are the new generation vessel sealers, which are basically bipolar forceps based on 3 factors, that is compression, temperature, and time. Now, vessel sealer generates high frequency, low voltage between two jaws of the instrument, resulting in temperature up to 60 to 100 degrees Celsius. There is increased temperature causing denaturation of the proteins. Now, by adding compression to the temperature, the ability to seal larger vessel has been achieved up to 7 millimeter by degeneration of collagen and elastin in the vessels, followed by prompt renaturation. Adding a blade to the handpiece makes transaction of the pedicle possible without changing the instruments, thus reducing the operating time. It forms a vascular seal and high elastic strength. So now here you can see the advanced bipolar, which is ligashore.
So basically, as you can see, it has a knob also to rotate the blades. So we can rotate the blades in any direction. And this is the blade which cuts the tissue in between. So once the tissue is held in between, we coagulate with compression and then the blade comes off and cuts it. So now these three things are very important in advanced bipolar devices: compression, as I said, temperature and time. So there is an automatic cutoff of the supply once the required coagulation effect has been achieved. And then there is a noise which comes tick, 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 tick. And once it stops, then that is when we should press the blade, and the blade comes in between and cuts the tissue. So the two instruments need not be used. The scissors as well as the coagulation occurs in the same way. So this is not working. This was a video just to demonstrate the effect of the advanced bipolar device, that is ligashore. And but one must remember that these vessel sealers cannot be used for small oozing. For small capillary ooze requiring 1 to 2 millimeter of coagulation, we should always resort to bipolar because
Why? Because they don't have collagen, much of collagen.
the smaller vessels do not have much of elastin and collagen in them, so the advanced devices would not work on them.
So now electrosurgical injuries which can occur because of the direct application. If the tip of active blade touches adjacent viscera, example during ball transaction in TLH, the underlying bowel may be touched by the tip of the monopolar hook. Then there is a residual heat in all the electrosurgical devices, so the tip must never be rested on any viscera immediately after activation. Even the tissue which we cut is heated to a large extent, and it should not touch any other bowel or anything. Now, insulation failure induced stray current. If the insulation of active electrodes, especially in monopolar devices, is damaged, stray currents can reach non-target tissue. Coagulation with monopolar should be avoided as it uses higher voltage. So we must check for insulation before using any kind of electrosurgical instrument. Then there can be direct coupling occurs when the active electrode is in contact with another conductor like a laparoscope, metallic grasper, etc. So tip of active electrode should always be kept under vision and should not touch any other instrument while we are applying electrosurgery. Now there can be capacitive coupling occurs when two conductive elements or instruments are separated by an insulator and form stored energy. Then there can be return electrode bunds if it is not placed in close contact with the patient's skin or is placed over bony prominences. The return current can get concentrated and this high density current can result in bunds. Then there can be injuries due to lateral thermal spread. Now lateral thermal spread is particularly important while coagulating the uterine arteries in total. Laparoscopic hysterectomy as the ureter is closed to it. Now coming to the ultrasonic technology.
Now, so basically, this works on the piezoelectric crystals, and there is an active blade and a passive blade. The passive blade has insulation. The passive blade has insulation of silicon, and the active blade vibrates at a frequency of 55,000 to 60,000 per second. And this creates a lot of this, because of this mechanical energy creates a lot of heat and it gets heated up to 100 degrees Celsius or maybe beyond. So this is the active blade. To prevent it damaging the other structure, the passive blade is insulated so that it is protected.
So this is basically conversion of electrical energy into mechanical energy, which is further converted into heat energy.
So the advantage of the ultrasonic is that it causes very less thermal damage, Disadvantage is that there is the vessel sealing effect is not that good. And it has two knobs, the minimum and the maximum, as I showed with the, yeah.
This is the maximum one, the upper one, and this is the minimum one. So with this, we close the blades.
Yeah, lock the blades. So there is minimum lateral thermal spread, no electricity going through the patient, minimum smoke for better visualization, multifunctionality. The main purpose is with the motion of the blade, there is vaporization. So the vapors form, they expand the tissue. So there is the layers, they tend to separate. So this effect really helps in dissection, especially like this is a video showing the UV fold being cut with the UV fold being cut with the harmonic. So once we cut it, one, the pneumoperitoneum gas enters into the space, and two, because of the vaporization effect, the layers separate like very smoothly, and the dissection becomes much easier. Then we have the laser. The laser is a good instrument in the hands of experts, but it needs a lot of training, a lot of practice, and it is very expensive. And many precautions need to be taken in the OT. Special operation theaters need to be used for this. Basically, it is the principle is that the cells are made up of 75% water, and because of which they are evaporated instantly and the cells explode. So this is the basic principle. The depth of tissue penetration is very precise with laser. There is minimal lateral thermal spread. The smaller the spot size, greater would be the power intensity. Various lasers that we use are the Nd:YAG laser, the CO2 laser, the argon beam coagulation, and the KTP laser. Commonly used is the CO2 laser and the Nd:YAG laser. And in gyneobs, we can use these laser beams in cervical conization surgeries, in endometriosis surgeries. They can have many applications, but as I said, needs a lot of expertise, a lot of training, and a lot of time. So then now coming to the need for the use of ergonomics, proper ergonomics in laparoscopic surgery. Why is it more important as compared to open? I think we should just brush through this. We are running out of time. There is lack of tactile feedback. There is a two-dimensional view. There are long graspers. We have to operate, like I can just show that we are holding the instrument here and we are operating here. So the length of the instrument is around 37 centimeters. So this is the thing which produces a lot of fulcrum effect. So this is the trocar holding on to it. So what we do is we operate here and the effect is produced there. So you can imagine just a little bit of movement here produces a lot of effect there. So the tremors are also transmitted that way. So the precision of the surgery takes time and it needs a lot of practice. There's a long learning curve. And as I said, the fulcrum effect of instruments is there. There is decoupling of the visual and the motor axis. The hand-eye coordination takes time to come. We are looking into the monitor and operating somewhere else. So this coordination of the hand, eye, and the brain to be able to operate somewhere down and looking up at the monitor takes time. And there is decreased degree of freedom of movement. It is much less as compared to the open surgery. And robotic increases the freedom of movement to a bit. It's like the degrees of freedom of movement are 4 in laparoscopic, 7 in robotics, and of course 36 in open. Then there is a static posture. We are usually, because we are kind of staring at the monitor, there is eye strain, there is back muscle strain, there is accumulation of lactic acid in the legs, and that leads to musculoskeletal problems to the surgeon. And if there is crowding, too much crowding of the floor, of the space, of the cable management is not efficient, the surgeons, the technicians, the staff can fall. So it reduces the efficacy also. And so this is it. These are the essential things one must know, the ideal angles. So we have to know these basic 3 angles at least. the manipulation angle, which is the angle between the tips of two operative instruments, the azimuth angle and the elevation angle. The azimuth angle is the angle between the scope and the operating instruments. If this is the scope,
This is the scope.
this is the scope and the operative instrument, that angle should be
This angle.
yeah, this angle
Or
should
this
be between
angle.
30 to 45, and the elevation angle, which is the angle any instrument has with the abdominal wall. So this angle, elevation above the abdominal wall of the patient, which should be approximately 45 to 60. So these are the ideal angles. So correct port placements can maintain proper angles. So ports should always be placed as per the convenience of the surgeon. That's the dictum. Just do not go by the book, but they should follow proper angles. Otherwise, the surgeon would be uncomfortable. So this, they're showing the elevation angle. These are the azimuth angles. And now another thing which is important is the position of the monitor. The monitor should be right in front of the surgeon's eye in the same axis, and we should not be looking up. We should have a gaze down view. So it should be approximately 15 to 25 degrees lower. So this is a wrong position. We have to stare up. This is right. The horizontal is this, as Dr. Ila is showing, and the gaze is downwards. But this is putting a lot of strain on the second assistant. So there can be torsion of the neck for the second assistant. This is not right. So there should be a monitor in front of all the operating surgeons. So what we have to adjust is the OT table height, which should be, see, if we see the height of our elbow. So the elbow height, first they're showing the angle. So the angle should be between 90 to 120 degree. It should not be hyperflex. It should never be less than 90 degree if we have to be comfortable. And the height of the table should be between 70 to 80% of the surgeon's elbow to ground distance. And by the table, I mean the operating height, that is the abdominal wall height after inflation. Then the monitor position, as I said, then the foot pedals and wires, they should be properly placed. We should have, like, normally what do we prefer? We prefer the cable tube, the light cable, the
Towards
camera
the
tubing towards the assistant.
And
all the energy sources towards the surgeon's side, so that there is no crossover and nobody falls and no entangling of the wires. Then the port placements, as I said, should be perpendicularly placed, and we should see that the target outlet should be between 15 to 20 centimeters from the central port, which is used for the optical trocar. I mean the camera port, and they should be placed without tunneling. Then laparoscopic instruments should be chosen according to the surgeon's preference. The wrist should be in neutral position. We should be able to move our arms on all sides, avoid pressure points on the hands. Now this is very important. So if this is the instrument, we should use it this way, hold it this way. We should never hold it this way, because if we put our fingers in, this will cause a lot of strain on the thenar and hypothenar eminences. So we should be gently holding the instruments this way, like this. And whenever need, then we can quickly insert the finger in and apply pressure whenever required. Similarly, instruments which require a lot of pressure, like the needle holders, should have a powerful grip. So their grip should never be like this. So the needle holders always have a very strong, sturdy grip, which we can hold with the palm. Yeah, this way.
This way.
Because we have to apply pressure, rotate the needle, take it out. So this grip has to be.
So your wrist movement is also?
Yeah, this should be the grip for them. Then latest things that have come up are arm support. So if we have our shoulders hanging with some support, there's a lot of strain avoided onto the shoulders if the elbow is being held properly. So this is another thing which is coming up. More videos. So this is just a video showing how ergonomically convenient we can get to avoid strain. So we have a camera in front of the surgeon, we have a camera in front of the first assistant, and we have the second assistant also tilted so that the camera is right in front of her. The distance between the surgeon and the camera should also be, and the monitor should also be adjusted. It should not be too far off or too nearby to avoid strain on the eyes. So to conclude, laparoscopic surgery is highly beneficial for patients with reduced post-op pain and faster recovery. Over the years, high technological complexity and at times poorly adapted equipment and environment has led to alarming complaints of fatigue and discomfort from surgeons during this surgery. So a promoting of better understanding of the ergonomics would avoid this. We should prefer the surgical device depending on nature of surgery to be performed, surgeons' experience with the instrument, availability, efficacy, safety, and cost. Despite all the advanced options available, conventional, monopolar, and bipolar should always be in the armamentarium of an endoscopist. And the best vessel sealer with no lateral effect, no smoke production, seals vessels effectively is the vascular endosurgery. That is a must. One should not jump to endoscopic surgery unless one is well versed with vascular endosurgery. So one should learn from tips from experts, learn from the others' mistakes, adopt tricks, and of the experienced endoscopist and carve one's own learning curve to perfection.
Over to you, Dr. Sakshi. Any questions?
Hysteroscope, I think we forgot to show the hysteroscopic videos.
Do we have time?
Sakshi?
Actually, the time is up, but you're the last lecture. If you want to show, up to you, absolutely.
You can just show the instruments with the hysteroscope.
Basic hysteroscope, that is the diagnostic one. Here you can see, this can be opened. This is basically the camera. We insert it.
This is the main scope and
main
this
scope.
is the inserter.
Inserter, we insert it. And here is the irrigation tube attached.
We attach it. This is the operating
hysteroscope. We can insert, as you can see. This is the inlet. This is the outlet for the outflow.
Just make it a little central.
Yeah, can you see it?
Yeah.
Yeah. So this is the inlet. This is the outlet. And with this, there is a groove here you can see, I hope. Here, with this we introduce the instrument for any operating thing. This is for tubal cannulation basically. Here you can see it has come out from here.
Yes, ma'am, we can see.
Yeah.
And these are small operative instruments. If
This
you can
is a
see the
scissors.
scissors opening and closing. Sakshi, is it visible?
Yes, ma'am.
It has to become very near to the camera. Yeah, can you see it?
Yes, ma'am.
Yeah. So this is a scissors.
It
Now
is
we have-
sectoscope.
This is the resectoscope in which various cautery like loop cautery can be used of various sizes for TCRE, that is transcervical resection of endometrium. Yeah, can you see it?
Yes, ma'am.
Yes, it works like this. With this, the loop comes out. Here the
Loop
camera.
attached.
Loop attached. Loop is here.
These are the various loops. This is for resection, and this can be used for submucous myoma resection, or
These are the various
these are the
sizes
various
basically,
things
and
can
this
be
is the
used for ball for TCRE.
Can you see it?
Yes, ma'am.
And this is the
again
hook Collins kind of. These are the various balls. I think that's about all. That's about all, Sakshi.
Thanks a lot, ma'am. You covered all the basics. I'm sure our PGs must have benefited. And I hope like the videos would have been working and they would have understood all the more.
Seriously. Are there any questions, Dr. Sakshi?
No, not as of now.
So can we ask questions to the PGs?
I think you can ask them, but then they'll only be answered on the chat box only.
Okay, okay. Yeah.
Yeah.
I was just joking whether they are awake or they are sleeping.
I do not. They must be tired also since 11
Yeah,
o'clock.
it's a long day.
Yeah. Chalo, thanks a lot. So finally we concluded the first day of Gurukul. And thanks a lot, ma'am. Thanks a lot, Dr. Kanika. Thanks a lot, Dr. Hila. And thanks a lot to all our postgraduate students who have been here till now. And thank you, our backhand team, who were so supportive to us.
Thank you.
Thank you.
Stop share. Please stop share.
Stop sharing.
So, ma'am, so on the behalf of Jackson Park, I would like to close the present a closing talk for today. So very good evening. Jackson Pal Pharmaceuticals presents Lycorate Prex sachets containing L-arginine, lycopene, and DHA to prevent pregnancy complications. Injection maintain of hydroxyprogesterone caproate 250 and 500 mg to prevent preterm birth, and Endoreg Dynogest 2 mg tablets for prevention of and management of endometriosis and endometriosis associated pelvic pain. We thank the esteemed faculty and attendees present with us today. With our knowledge sharing platform and with the support of medical fraternity, we hope to go a long way. We look forward to your presence again tomorrow to continue with more of Gurukul classes from 2 p.m. onwards. Thank you very much.
Thanks a lot.